Good morning, everyone. We will start in another 5 minutes.
Varun, can you stop
Yes,
sharing
ma'am.
this and
Yes, ma'am. Please tell me.
you can stop sharing this and go for Dr. Santosh profile. Before that, that
Okay.
first
All.
five slides, just quick run and start up. TAPCON first five slides, then you can.
Over to you, ma'am.
Good morning, everyone. Welcome you all back to TAPCON 2020, the last and final day, third day of the session. So welcome you all for this wonderful day. So today's first topic and first speaker is going to be Dr. Santosh Menon from Tata Memorial Hospital, and we are going to have multiple sessions. Like all are going to be very interesting, and I'm sure all of you are going to be totally on the line, and you cannot even think of going out of this screen. So it's going to be a very interesting day for all of us. So we'll start with Dr. Santosh. So Dr. Santosh graduated from Calicut Medical College. He's currently working as Professor of Pathology at Tata Memorial Hospital. And he did his MD Pathology in PGI Chandigarh. DNB also is finished. And currently he is associated with Tata Memorial for more than 15 years, I would say. And his main fields of interest are genitourinary pathology and gynecological oncopathology. His teaching interest is in surgical pathology, IHC, and molecular pathology. He's not a new person to us because last year also we had his talk and it was really interesting, and all of us were really very much motivated listening to his talk and all cases. So he's got a treasure of cases, good cases with him. So he's going to share his knowledge. He's got awards and best paper awards for in IGPM, which was held in Bhubaneswar, and international poster presentation at London. And he's reviewer of many journals, IGPM, gynecological pathology, and human pathology. He's lead coordinator for the network of Indian Network of Uropathology, member of European Society of Pathology, and he's secretary of Society of GU Pathology, and he's got more than 30 publications for his credit, and he's faculty speaker in more than 47 national and international conferences. His CV runs to many pages. I'm just condensing it for the sake of lack of time. Over to you, Dr. Santosh. We welcome you on behalf of Tamil Nadu Pondicherry chapter of IAPM for this wonderful session. Thank you.
Thank you, Dr. Padmavati. A very good morning, everybody. Thank you, Madam, for a very, very kind introduction. First of all, I would like to thank you, Dr. Arunalata and Dr. Sudha and TAPCON for having me here. I remember last year I had a lot of fun in Chennai, and it was a fantastically arranged and fantastically organized meeting. And as we adjust to this new normal where we just see each other over a screen, I think this is going to be the norm for at least next 6 to 8 months. And hopefully everybody stays safe. So I think with that, I can start my session, my lecture today. Can I share my screen?
Yes, sir, you can stand.
Yes, sir, please go ahead. Please go ahead.
So I hope everybody is able to see the screen. So today's topic, which has been given to me, is on testicular tumors. I'll be briefly highlighting the salient points of grossing and what to be reported on a pathology report. So it's not just the entities which we'll be describing, it's something which is more clinically relevant. Because finally, at the end of the day, we all are clinical people and clinicians, and we have to fall and make our place into a team which manages patients. So so my screen is moving, I hope.
Yeah.
I'll begin with a disclaimer saying that this is not going to be an exhaustive lecture on pathological entities in testicles. So I'm not going to go into details of sex cord tumors and other rare tumors in this. It's going to be the run-of-the-mill common tumor which we see. I'm not going to be an extra lecture on in testicular cancers and how to use it. Maybe I'll touch upon what needs to be done, where it needs to be done, and definitely not touching on molecular pathogens in testis and its tumors. But I would like to claim that this lecture is going to give some practical aspects of testicular cancer pathology, and whereas we pathologists fit into a clinical management team. So where would the clinical treating urologist, treating uro-oncologist look at you for some kind of direction in their management? And I'll highlight some IHCs which can be used judiciously, where it should be used, and what matters in our report, what doesn't. So this is going to be the salient points in the lecture which I would like to cover. So this is the basic unit on histology of the testis. I'm not going to anatomy, the scrotal sac and all that. I think those things are, I'll just directly go on to the topic. So this is your basic unit of the testis, which is the sort of seminiferous tubules. You know that they are Sertoli cells, spermatogonia primary, spermatocyte, sperm head, spermatids, and then there is Leydig cells in the interstitium of the testis. So if you look at the classification of tumors of testis, this is the 2000 old one, 2010, 2011 classification, 2016 classification, which basically shows you again a list of tumors. So if you look at WHO classification, they have got a family, or they've got a rubric under which you have many listed tumors. So again, if you look at the classification, the germ cell tumors in 2016 were basically divided into two categories. That is germ cell neoplasia in situ derived tumors and non-GCNS derived tumors. So I'll show you some pictures. What do you mean by GCNS? Basically, what is GCNS? It's a precursor lesion. So just like you have CIN 1, 2, 3 in cervix, you have other pre-neoplastic lesions in many other organs. This is kind of the pre-neoplastic or the incipient neoplasia within the seminiferous tubules, which then invades the basement membrane and forms all these kinds. So it's kind of precursor lesion for all these tumors, including seminomas and all non-seminomatous tumors. Whereas if you look at this classification, the non-GCNS, so that there are certain tumors which do not pass through this phase of pre-malignancy, like the spermatocytic tumor, the prepubertal yolk sac tumors and the prepubertal teratomas. So these two tumors don't have this pre-malignant or incipient neoplasia within the seminiferous tubules, and hence they do not have a pre-malignant phase. So this basic understanding led to the classification and division of germ cell tumors into GCNIs. And so I'll be highlighting more on germ cell tumors. There is a lot of list. I'll show you a list of tumors which can happen together, but I'll be mainly concentrating on germ cell because 90 to 95% of the tumors in the testis are basically belong to this category. So just to show you a picture, this is a testicular germ cell tumor, mostly a teratoma. You can see the cystic cavities, and this you have the seminiferous tubule, and there is something happening here in these tubules. If you look at, and I'll show you the high power. So this is what happening. There are some normal tubules here, whereas if you go to some high power in certain areas, you start seeing these big cells which are sort of hugging the basement membrane and replacing the normal testicular cells, seminiferous tubule cells. That means there is no spermatogenesis in these tubules, but these cells which are hugging the basement membrane, the large cells, this is what is known as GCNAs. Earlier, we used to term them as intratubular germ cell neoplasia, but now the term which we should be putting in our reports and which we should be using is germ cell neoplasia in situ. So you can see that there are certain normal tubules where you see the Sertoli cells with this windswept appearance of the cytoplasm. There are some spermatids and spermaids. But if you look at this tubule and this tubule, you see that they are replacing this cells near the basement membrane, these large cells which are GCNIs. So again, showing that. So this is GCNIs you should pick up. And at the outset only, I would like to say that you should look at GCNIs on microscopy at an area which is away from the main germ cell tumor. So it should not be very close to the germ cell tumor, because sometimes the seminomas and embryonal carcinoma can get into the tubules and form GCNS like areas. So you should look at GCNS away from this. So what are the major changes in WHO 2016? Like I said, the major classification is based on GCNS versus non-GCNS derived tumors. The term spermatocytic seminoma should not be used because it is nowhere related to the seminoma. It doesn't have a GCNS precursor. So the term has changed to spermatocytic tumor, and it should be used in your reports. There are certain trophoblastic tumors which have been recognized in your testis, although they are extremely rare again. We should not be using the word anaplastic seminoma, anaplastic spermatocytic tumor anymore. If you see immature elements in a testicular tumor, immature neuroepithelium, there is no need to report them because they are just part of non-seminomatous tumors. So there is no point in reporting immaturity in a teratoma. You are free to put a comment or something that there are immature elements, but then in the bottom line, you should not be saying that it's an immature teratoma. It's understood that it's a non-seminomatous germ cell tumor. Then they have recognized more and more somatic type of malignancies which can occur. So any teratoma can develop any kind of somatic malignancy, like a squamous carcinoma, an adenocarcinoma, a nephroblastoma, or any kind of tumor, or an rhabdomyosarcoma. These can occur in any kind of tumors. So coming to the main tumors, the tumors of the testis are basically the most common ones are the germ cell tumors, which include seminoma and non-seminoma. You have the spermatocytic tumors, sex cord, non-Hodgkin lymphoma, paratestical tumors. I don't think I can go into the details of these. I think the most common ones are the germ cell, and I will be concentrating on those tumors. So how do you approach a testicular mass set? So what do you understand? If there are a lot of PG students in the audience, most of the testicular stool would present as painless scrotal swelling. So there'll be a pretty fast growing scrotal swelling, which is painless. There will be loss of sensation. So the patient holds his testis, he would not be able to feel his normal testicular sensation. There might be undescended inguinal mass, which is an undescended testis. Sometimes there is a primary mediastinal or a pre-primary retroperitoneal germ cell tumors which present as abdominal or with the dyspnea. Patient present with dyspnea if it has a mediastinal. So am I missing something here? Missing a very, very important thing which I'm missing here is age. So generally they present at young age. So you have non-seminomas which occur early compared to seminomas which occur from 25 to 40 years of age. But then sometimes you may have a 60-year-old man or a 55-year-old man coming with a seminoma. So that's not an exception. But the point is age is an important. So young patient coming with a testicular mass, you probably are dealing with a germ cell tumor. So that needs to be kept in mind. Another very, very important useful thing for diagnosis of is serum tumor markers. So any young patient who presents with either abdominal mass or a testicular mass, has an undescended testis, these three markers are usually done: beta HCG, serum AFP, and LDH. Radiology is important. The question of FNAC is very, very dicey. Many people do not prefer to do these. Many urologists strongly differ and they don't want to do this. And testicular biopsy has got a very, very limited utility in diagnosis of testicular germ cell tumors. So the management, just a little about management. Seminomas are usually managed. All of them are usually operated first. So the first thing, if you have a testicular mass, if a patient has testicular mass, he gets an orchidectomy. And following that, either the patient goes for surveillance or chemo or radiotherapy in case of seminomas. Seminomas are very radiosensitive, so radiation is also. Whereas in non-seminomas, metastatic disease are given more intense chemotherapy compared to seminomas. So come to most common clinical scenario. Scrotal mass, unilateral, clinically and tumor marker wise, it's a germ cell tumor. So you have an AFP raise or a beta HCG raise and LDH raise, and there is a scrotal mass young. So what the clinician or urologist would do, they would do an orchidectomy. So we come to the grossing of orchidectomy. What are the important salient point which you should keep in mind in grossing of orchidectomy is? So this is just a cross section of that cartoon showing the seminiferous tubules, the radiate testis, the epidermal head, and then the tail which forms the vast difference. This all these things you know very well, and this is hanging in the scrotum from the mesothelial extension or the peritoneal extension, which is called the tunica layers. You have the tunica albuginea, which is stuck to the testis, which you cannot separate out, and the vaginalis through which it hangs into the scrotum. So what is the most important point in testis grossing? Where do pathologists scan a pathology? So basically, the orchidectomy, you have to give a report in stage 1 disease. You give information what kind of tumor it is, and there are certain other points which I will highlight in this. So what is the rationale behind grossing, testis grossing? The idea of grossing any specimen in oncology is to give a TNM stage, to give a TNM stage or give the T1, T2, T3. This is given and it is freely available on the internet. And I think you should just not try to mug these things up. Whenever you need, you can just refer to it. So if you look at it, all T1 to T4 are confined to testis and scrotal sac. So it is here in this kind of scenario that you have to give different things. And you obviously this is clubbed with the serum tumor. So this is one of those tumors in testis where you have a TNM stage as well as a SHS stage, referring to the serum tumor markers, which you combine to give the UICC staging. So basically, steps of grossing, you have to measure the length of the spermatic cord. You have to measure the length of the specimen. The best part is to, when you get a specimen of germ cell tumor of testis, it's important that you cut the excision margin of the spermatic cord first. The reason for this is, if you cut the tumor first, there is a lot of carryover because these tumors are very fragile, very friable. So they stick to your knife, stick to your scalpel, and then they can give you a lot of carryovers onto the margins. So that's important. The first point is, before cutting open the tumor, it is always best to cut the spermatic cord cut margin, place this in a cassette and send it, keep it. You reflect the parietal tunica, you bivalve the testis, you look at the location of the tumor. You have to, very important to look at the color and consistency, solid, cystic. An important point is, if you see hemorrhagic and necrosis areas, it probably is seen in NSGCT, but let me tell you, many seminomas are also very necrotic, so that's not an issue. But the point here is, if you see hemorrhagic and necrotic areas, it might represent a choriocarcinomatous area, so you should definitely sample. And many other tumors in other organs, we would say, don't take the necrotic areas because it's obviously necrotic. But in a germ cell tumor in the test, it's the other way. And if you see necrotic and hemorrhagic areas, you must sample it, because you may find choriocarcinoma under the microscope in these areas. You have to look at the tumor's relation with the epidermis, the cord, the tunica, and look for any areas of scarring on gross. If you can see, difficult to find many times. And you have to mention the presence or absence to this epidermis or cord. You have to slice the testis at intervals, and the important blocks which you take, I'll show the diagram. So this is the diagram of the testis and the cord. You see that this is your tumor, and this is the yellow one is your normal testis. So you take sections from the tumor, various areas of the tumor, about 4 to 5 sections. The general rule is one section per centimeter. The interface of the testis and the normal testis tumor, and then the testis. And then you take 2 sections of the tumor with the epidermis, radiate testis, and the tunica layers. So these are the sections. Obviously, the section of the cord cut margin you've already taken before cutting open the tumor. So that's an important practical point when you gross the testis. So these are certain tumors. My important thing is, in a seminoma, the size of the tumor does matter. So exact size of the tumor should be measured in 3 dimension in a case of a seminoma in the testis. So what should be the microscopic pathology report in a germ cell tumor? So you have to basically tell them basic difference, which you should say is a seminoma versus a non-seminoma, presence of LVSI, GCNS, whether the tumor involves the tunica, retate testis, epidermis, base of the cord, and the cord cut. So this is the basic minimum report which you should be giving in a testicular germ cell tumor. The important thing is, based on this, what the clinician would do, what the urologist would do based on your report, they will go refer to this international germ cell consensus classification and divide them into risk groups. So seminomas clinically after your report are classified into good risk and intermediate risk, whereas non-seminomas have 3 categories of good, intermediate, and poor risks, non-seminomatous tumors. So that's based on your report, and based on the percentage of tumors and all, they would sort of decide. So in a seminoma, the most important factors are the size of 3 centimeters. So any seminoma more than 3 centimeter is likely to relapse and would require probably a more chemotherapy regimen rather than just an orchidectomy. And involvement of retate testis is important. Now I understand there may be many questions people may raise. It's sometimes very difficult to find retate testis. You may have to take multiple sections, but in a seminoma, you should make a more effort to find the retate testis compared to a non-seminomatous germ cell tumor. Because the risk of relapse is different for these 5-year relapse. Would be only 10% if only one factor is there, but it would be 32% if both size is more and both retate testis is involved. In contrast, in a non-seminomatous germ cell tumor, the important thing which a clinician needs is the percentage of embryonal carcinoma component. And the presence or absence of lymphomas. So if you say that there are definite lymphovascular emboli in NSGCT, though that patient is a definite candidate for chemotherapy. And if the percentage of embryonal is more than 50%, they would consider giving extra chemotherapy to this patient. So that's the salient thing. If you can take these points home, I think that is an important thing which you can remember when reporting these germ cell tumors. So they are least bothered what is the percentage of, say, some minor trophoblastic component, 5% trophoblastic component or something. They're not bothered. They really want to know what is embryonal component and whether the LVS are present in these tumors. So coming to our favorite thing, the pictures also, you can see this is cartilage, there is epithelium. Sometimes in a teratoma, you may have very, very spindle stroma, very blue looking stroma. You may be tempted to call that this is immature mesenchyme, and that's why it's immature teratoma. I'll make it again very clear. There is no reason and there is no point according to 2000 WHO that you should be reporting immature component. In any case, immature teratoma is based on finding of immature neuroepithelium and not just solely based on immature mesenchyme. Again, to show some, these are embryonal component, lot of smooth muscle bundles. You can see the teratomatous epithelium, glandular epithelium here in these areas. Most of the non-seminomatous tumors were large areas of necrosis, both within the embryonal component as well as other components of the tumor. At many places, both in seminomas as well as now, you may find the syncytial trophoblastic kind of giant cells. They have a lot of vacuolated kind of cytoplasm, which is very easy to pick at even low power. So this is again to show that this is how an embryonal component looks. This is embryonal, and within the embryonal, sometimes you may have this faint looking, more wispy kind of cytoplasm cells, which are the yolk sac. So many times in an adult non-seminomatous germ cell tumors, you have this kind of what is called as a polyembryoma kind of pattern, in which the embryonal component is investing or completely covering the yolk sac component. So here you can see this is the embryonal component which is going, and the central part is the yolk sac component. And this can be confirmed with immunohistochemistry if you want, which I'll be showing you some pictures. So again, to show the testis parenchyma here and the germ cell tumor here, which is very necrotic. Other pictures to show seminoma. Seminoma can have different patterns. I'm not going into the details of seminoma patterns and all. Again, to show syncytial trophoblastic giant cells, cartilage, presence of different kinds of epithelium, squamous epithelium. Again, sometimes the tubules and glands may start looking like immature neuroepithelium. You have to be careful. Usually, immature neuroepithelium has got a blastic and blastemal kind of appearance with central areas of necrosis and all. And sometimes they may form tubular rosettes kind of pattern in these tumors. Again, to show Schiller-Duval-like bodies in yolk sac tumor. Yolk sac tumor can have glandular pattern along with the classical reticular or the reticular or YST pattern, endodermal sinus pattern. Embryonal can have solid areas, and you can look at these embryonal areas. They look very smudgy. They've got a lot of rip-roaring mitosis in these areas. the nuclei are looking very, very bad. And one of the most fiery looking tumors is the embryonal carcinoma in the body. But the good part about all these tumors, they are very, very chemosensitive. They almost melt away with the standard chemotherapy regimens. So just a highlight about IHCs. If you want to remember, embryonal carcinoma is nicely positive for CD30, cytokeratin, and OCT34. So these are the images. You can see that CD30 is positive, and the nuclear marker is OCT34. These usually we don't use IHCs in many of these tumors. Most of them are very classical on morphology, and that's why IHC is reserved for only few cases in which we have a little doubt, and we really want to quantify the embryonal component. That's where we use IHC. So that's what my point is. Using IHC on all cases of germ cell tumor is not at all recommended. It's only when you really want to pick up these cells and the quantity of these embryonal component that you would want to sort of distinguish. Another is to distinguish from a more anaplastic looking seminoma, although we don't use that term. Then you have to resort to CD30 and other markers. In contrast, seminomas are positive for c-KIT and D240, and again OCT234. So if you do only OCT34, you may not be able to distinguish between embryonal and seminoma. You may have to resort to c-KIT and D240. So if you remember these, there are other markers like SAL4, which is a very good general germ cell markers, which we have recently acquired, and we are doing it on some cases just to, especially in mediastinal cases and retroperitoneal where you have very little tissue and you want to confirm a germ cell. There you use markers like SAL4. Glypican is a good marker for yolk sac tumor, glypican 3, and even GATA3 is a good marker for yolk sac tumor. So I'm just highlighting few points about IHC, not going into too much details. Again, I just wanted to highlight some pitfalls. So this is GCNS, or what we used to call as ITGCN, which is away from the tumor, close to the tunica layers. You have large cells filling the tubules. Whereas this is a close to the tumor, a tubule which is being infiltrated by a seminoma. So intratubal extension of a seminoma should not be confused with a GCN. GCN should be looked away from the tumor, not close to the main tumor. Again, here, this is the tunica layer. The tumor is far away from the tunica, whereas here the tunica albuginea is being involved by the seminoma. A picture to show that this is the epidermis. The tumor is reaching close to the epidermis, not involving. It has to go in between the stroma of these tubules of epidermis to call it epidermal involvement in these tumors. An interesting picture to show rete testis. This is how a rete testis looks. Sometimes the rete testis is very prominent in germ cell tumors. Almost becomes very hyperplastic in these kind of tumors. And if you look at low power, you will say that the rete testis in this picture is involved. But if you go to high power, you can say that they are pagetoid involvement. So these tumor cells are actually just lifting the normal tubular epithelium of the rete testis. And this pagetoid involvement should not be confused with the rete testis. So when you have to call rete testis involvement only when you see, only when you see it in between the tubules in the stroma of the rete, you call it rete testis involvement. So this is a picture to show the base of cord involvement, or the hilum of the cord of the testis, which is involved by tumor. And this is a large picture of a LVSI of a tumor within the large blood vessels. So this is again very, very dicey. I told you LVSI is extremely important in non-seminomatous germ cell tumor. They would give chemotherapy. Hello. Am I audible?
Yes, sir, you're audible. You're audible.
Yeah. So you have to, there can be a lot of knife carryovers in the blood vessels, which can look like lymphovascular embolia. And you have to look at the overall picture of the many sections to confirm whether it's widespread carryovers in many of the sections, or whether it's really a genuine lymphovascular embolia in the large vessel. So this needs to be understood exactly. And because this has got important treatment implications. Coming to the last section, the other things which you may receive in germ cell tumors in an RPLND or a retroperitoneal lymph node dissection. So the drainage of testicular tumors is towards the paraiotic nodes or the retroperitoneal nodes like iotocaval nodes and all that. So once the testicular tumor is removed and once they are given chemotherapy, the chances that these testicular tumors recur in the abdomen in the retroperitoneal tumors is very high. Or you may have a residual kind of a lesion which is left post chemotherapy in retroperitoneal. So that's when the urologist will go in and operate this retroperitoneal node. So you may get a different sets of nodes, and it needs to be thoroughly evaluated for any residual tumor. What are the different pathologies? So I'll just show these are the different pathologies you may see in a RPLND. There may be no residual tumor, because the patient has already had an orchidectomy and a chemotherapy. So you may have no tumor. You may have viable malignant germ cell tumor like an embryonal carcinoma or a yolk sac, which is still there. In about 30% cases, you may have a residual teratoma. So mature teratoma you may have, which is there. And then there is a rare cystic trophoblastic tumor, which you may sometimes find. The important thing which we will come to is, again, secondary somatic. So you may have a patient of testicular tumor who has been given chemotherapy. He has got some residual retroperitoneal nodes which are growing in them. You find that there is some totally different looking malignancy like a rhabdomyosarcoma which has developed. So that's called a secondary or transformation or a somatic malignancy which is arising in a teratoma. So that's another possibility. So in the case of no residual tumor, you may find different kind of pathologies. You may have a lot of necrosis. You may have this kind of foamy histiocytes, pigmented histiocytes, lot of bad spindle looking proliferation, which are nothing but myofibroblastic cells and fibroblastic cells which are developing in the retroperitoneum, presence of cholesterol clefts, sheets of foamy macrophages, calcification, necrosis, and foamy histiocytes. So these combinations can be seen in most 30 to 40% of cases post chemotherapy in the retroperitoneum of patients of germ cell tumor. The other thing is presence of residual teratoma. There is a lot of confusion against the use of viable word. Many times when you use the word viable teratoma in the retroperitoneal lymph node dissection, that the clinician gets confused. He thinks there is a residual viable tumor left, and they may again call you for these kind of questions. So you have to be clearly right that this is a mature teratoma which is left post chemotherapy, and no further chemotherapy is needed in these kind of patients. So this is again to show different kinds of epithelium, glandular and intestinal kind of epithelium, squamous epithelium, cartilage, and bone, which can be seen in these kind of retroperitoneal lymph node dissection as a part of a mature teratoma. Sometimes you may get viable tumor like embryonal carcinoma, yolk sac, choriocarcinoma, anything can be there. So residual seminoma might be there. An important pitfall I want to say in RPLND, you may find granulomas. So seminoma can have lots and lots of granulomas in there, even in the primary as well as lymph metastatic sites. So once you see granulomas in a known case of a seminoma in a retroperitoneum, you should sample it more to find some residual seminoma which is left behind. The third part is the somatic malignancy, which I was telling. So these are non-germ cell malignancies in the form of sarcoma, RMS, PNETs. So we have seen cases of PNET sarcoma arising in the retroperitoneum post chemotherapy in testicular germ cell tumors. So this is just a picture to show PNET in a retroperitoneal node dissection, which was done for a non-seminomatous germ cell tumor. I think I'll not go into the details of these. If I need to summarize in a very small nutshell, I think for the postgraduate, this is very important that you look at the age of the patient, the clinical presentation, whether it's primary retroperitoneal, does the patient have undescended testes, does the patient have a testicular swelling? Some things which many people forget to mention is serum tumor markers. I think they are almost diagnostic without even pathology. Most of the times the serum tumor markers would tell the clinician this is a non-seminomatous germ cell tumor based on the raised AFP levels and raised beta HCG levels. The important grossing tips need to be kept in mind, especially the point that the cord cut margin should be taken before you cut open the tumor. You have to keep in mind that these tumors are very, very friable. They have a lot of carryovers, and they can mimic, which can mimic LVSI, and they can go into different places within the tumors, within specimens. So you have to be careful about when you gross this. The other important grossing tip, which I told, was to sample the hemorrhagic and the necrotic areas, because those might represent choriocarcinoma areas. Important thing is to distinguish versus seminoma. The treatment implications are different. The prognostication, seminoma has only a good risk and an intermediate risk category, whereas non-seminoma have got 3 different categories with different prognosis. The size of seminoma and the radiation invasion is important in seminoma, whereas in non-seminoma, LVSI and percentage of embryonal is most important. So I think these are the salient tips. If you remember these, the next time when you gross a specimen and you report a specimen of testicular cancer, you would actually be giving a more meaningful report to the clinician, rather than picking up small findings on pathology which are irrelevant to the clinician. I'm very happy to share our Society of Genitourinary Pathology's paper, which came as a review article in Indian Journal of Cancer, written by our younger colleagues. And so if you want, you can go through this article in Indian Journal of Cancer. Dr. Sandhya Sundaram is amongst you. She is the president of this society. And if anybody is interested in joining us, you can contact Dr. Sandhya. So I would like to thank my colleagues. This sort of looks like Corona in these times, this picture. But yeah, this is how we are going to defeat it also by holding hands with each other. Thank you so much.
Thank you, Dr. Santosh, for that enlightening and crisp lecture. There are a few questions for you. So first question is, do we have to stage testicular lymphomas is one question.
Pardon?
Am I audible to you?
Yes.
Do we have to stage testicular lymphoma?
Testicular lymphomas are not staged as per germ cell tumors. Lymphoma is a completely different staging. You have to do bone marrow and all that as a workup for any other lymphomas.
Okay. And the other question is, only embryonal carcinoma component decides need for chemotherapy. What would be the management if yolk sac and other components are seen? Can you explain that?
Point is, if the tumor is confined to testis, supposing the tumor is just in the testis, and you have a sizable proportion of embryonal component, that means 50% is embryonal. That patient would definitely be given care. Compared, supposing the embryonal component is only 5%, 10%, it's completely removed. Those patients may not be a candidate for a chemotherapy. So embryonal component is something which decides. Presence of LVSA is something which decides the chemotherapy in these patients.
Can there be a satellite nodule within the cord away from the tumor, and will it affect the involvement of cord without LVI?
You can have satellite deposits in the cord. It's not very common. Most of the times it's an extension through the LVSI into the cord. But you can get, even at cord cut margins, you can sometimes have satellite nodules of germ cell tumors, especially seminomas and all.
Any tips to get the, I don't know what they mentioned. Any tips to cut the media, some testis with the VT testis in the cut?
That's a difficult question. Like I said many times, you will not find retitestis in the usual sections. You'll have to go back and see close sections close to the epidermis. In and around the epidermis, you will find the retitestis. The other confusing thing which the AJCC has done is the hilum of the testis. That's a difficult area where between the epidermis as well as the reti, there is an area of soft tissue which is beyond the testicular parenchyma, which is called the hilus. So again, finding that is difficult. You may find it in some, but not. So like I said, in a seminoma, you should take more sections to find these retitestis invasion, but in a non-seminoma, this may not be of much clinical relevance.
Can neuroendocrine carcinoma arise in teratoma? One question.
Neuroendocrine carcinoma can arise, any type of tumor can arise in a teratoma. So any kind of malignancies are known to occur.
Is there a relevance of base of cord invasion in staging?
So yes, the base of cord is now basically, that's what I'm saying, the hilum. The hilum is just beginning of the cord or the base of the cord. We still continue to use the word base of the cord in the testis. Again, there is a lot of controversy. There have been a lot of surveys among experts of geopathology to say whether base of cord should be called T3 or T2. But now most of the people would say that hilum involvement is T2 of the tumor.
VT testis invasion, some of them have asked. Stromal invasion alone is there. Can we take it as an extension?
Yes. So stroma of the retitestis is it. So pagetoid involvement should not be called as invasion of the retitestis. It's the stroma of the retitestis should.
VT testis involvement, does it change the stage?
Yes, I think if you go to the staging, you'll find that the staging of epidermis, it's a PT stage which changes actually.
Regarding RPLND, what is the concept of
Pardon? I'm not able to hear you, madam.
Regarding RPLND, what is the concept of maturing, treating, post-therapy?
Maturing,
treating, post-therapy. That is how they have typed out. I don't know what they mean by that. I think there are a lot of typing errors. They have to.
I think they mean, is it a maturing of the? So it's kind of a maturation only. You can say that. So I didn't go into the confusing concept of a pre-pubertal teratoma and post-pubertal teratoma. This is a PG lecture. So I think the concept is any post-pubertal teratoma in the primary testis has gone through the stage of GCNS. So it's basically a malignancy, whereas a pre-pubertal teratoma which does not have a GCNS is not a malignancy. So that's a basic understanding of teratomas as far as concerned. Sometimes you may be able to pick one over the other even in adults. You can call a pre-pubertal type, but then these are difficult lesions to pick under the microscope.
I think that ends the questions. Let me just check. There are few.
I can see several questions actually.
Yeah, if there are any in your screen, maybe. Do seminoma with syncytial trophoblastic components have any specific significance?
No clinical significance, only by the fact that the beta HCG may be raised. So in a pure seminoma, sometimes when the patient comes to the clinic, you may have beta HCG raised till the tune of 200, 500, usually less than 1000. Usually it is less than 1000 in seminomas, but if in the presence of syncytial trophoblasts, you may have till 500, 200 beta HCG may be raised. The important thing is in seminoma is sometimes in seminoma, if you find AFP raise, say it's a 100, 150, you should go and take more sections from the gross again to find those yolk sac areas, because then the patient is going to be treated like a nonce. So if you have a mixture of a seminoma and a non-seminoma in a patient, the patient is going to be labeled as a non-seminomatous and treated, prognosticated, risk categorized as a non-seminoma and not a like a seminoma. So that is the importance of serum tumor markers.
I think these are the questions. If there are any more, I think you can type out the message and.
Webinar, the direct questions and questions which you take from the.
Yeah.
Sir, I have a question.
Madam.
You were talking about the serum markers, but I believe some of the oncologists, even though we say there is no other element, like, I mean, when we talk about the beta HCG raised, there are some oncologists who would prefer to take it as a bad prognostic marker, and they say that we alter the treatment, even though you say there is no element of, I mean, like choriocarcinoma or anything. There are, I just want clarity on that.
The clarity on that would be, madam, that you have to let me know the levels of it. See, you can't have a seminoma with level of 10,000 beta HCG. That's impossible, almost next to possible. I think there are only few case reports which would describe that seminoma is secreting beta HCG or seminoma is secreting alpha fetoprotein. Very anecdotal single case reports might be there. But otherwise, in a pure seminoma, if you have, say, beta HCG raised than 500, you are not seeing syncytial trophoblastic cells under the microscope. You have to go and sample it thoroughly to pick that little kind of embryonal component or the choreo component which is present there. So the point is, pure seminoma, you may call it a seminoma, but if the beta HCG is really raised, they're going to treat the patient like a non-seminoma. And that's why the prognosis, because non-seminoma has got a worse outcome compared to seminoma, the prognostication, the risk category stratification is totally different.
Thank you.
Thank you. Pleasure.
So that was a wonderful session, Dr. Santosh.
Madam, sorry, I have not gone into very specifics of this is embryonal, this is.
No need. So you were actually addressing the practicing pathologists.
Where the report is important in testicular tumor.
Yeah. You were highlighting mainly on the classification, and you were giving the importance of GCNIS terminology, and you highlighted about the word immaturity in teratoma not to be highlighted, and you enlightened about approach to testicular tumors and the clinical and tumor markers, that staging, that also you highlighted. Then grossing protocol you excellently highlighted.
Yeah.
And the presence of necrotic areas, how significant is it, that also was highlighted by you. And the VT test's importance, again you highlighted. So it was a wonderful session for the practicing pathologists. So it was really good having you and your lectures. It was really good. Thank you.
Thank you so much for having me.
Project the certificate.
Wow. Virtual certificate.
Yes, we'll be posting it online, and
pleasure. I hope to meet you next year, maybe.
Yes, sir, definitely. We'll also pray for that. Pray for the end of this COVID era, and we want to get back to normal.
Much. Yeah, we can move on to the next session, madam.
Yeah.
I'll mute myself now.
Can we move to the next session, Dr. Padma?
Dr. Sudha, I'll coordinate with you. 1 minute.
Yes.
There is a slight change in the session. Dr. Munita is going to continue with the session. Then Dr. Sukesh will join us.
Okay, right. Thank
Okay,
you.
Dr. Munita, you are okay with it? I confirmed with her. She said she is okay. So meanwhile, we have few announcements. I want the attendees to log in with their names, not with their mobile or something, because we are unable to. If you have your names only, we'll be able to generate the certificate. So we want your name to be included in the participant name so that we are able to generate the certificate. So that is one thing. Then we are going to email feedback form to you, and we want the feedback form to be filled and sent to us. So only after receiving the feedback form, your certificate will be posted online. So that is one request. So as soon as you receive the feedback form, kindly take some time and fill it up and send it back to us. So after receiving your feedback form, we will be able to send your certificate online, right? And we would encourage many of you to enroll and get into Tamil Nadu Pondicherry chapter of IAPM. We'll again be circulating we'll be sending you the application form for registration. So we want more registration for the chapter to make the chapter grow stronger. So we have around 300 life members right now, but we have so many pathologists in and around Tamil Nadu and in Pondicherry. So we want every one of you to become members of the chapter so that the chapter goes stronger. So these are the requests and things which I wanted to convey. If there is anything that Sudha, you can also join and tell.
Yeah, it's the same thing. Fervent request to all to become members, to enroll as members, and also to suggest and advise your friends also to become members of the Tamil Nadu and Pondicherry chapter of IAPM. And please fill up the feedback form and send it back to us. And another thing is, please log in with your proper names so that you will get a good you will get a proper certificate. Thank you.
Thank you, Dr. Munita, for joining as soon as we requested you. Thank you. So next session is going to be Dr. Munita Bal, because there is some issue with Dr. Kish. He's going to do as a third presenter. So we will have Dr. Munita CV. So Dr. Munita, she has 17 years of post-MD experience, and she was again from PGIMS, and she has specialties head and neck pathology and GI pathology. She has 20 years of PG teaching experience, and for HBN1 postgraduate training course also, she is the teaching in charge person. She has an additional position in oncopathology co-chair, Eurasian Federation of Oncology, Russia. She has many awards to her credit. Best Presentation Award in KDDW 2019 Seoul, South Korea. Best Poster Prize in Belgium. Best Paper Award in APCON 2018. Gold Medal in Jaipur. And the Best Paper again in APCON, Aurangabad. So she is the ICMR consensus document expert, working group. Next slide, please. Working group member of National Cancer Board. She is the editor of a book called The Glossing Technique of Glossing of Surgical Oncology Specimens, and she is in the editorial board for Pancreatic Cancer India and National Advisory Board. She has more than 50 publications to her credit. So we welcome you. We take great pleasure in welcoming you for this session, Dr. Munita. The screen is over to you. Can you start screen sharing? Mr. Varun, you can stop this and allow ma'am, Dr. Munita to screen share. Good morning and welcome you, Dr. Munita. I think you are on mute. You are muted. Dr. Munita, unmute yourself.
Thank you so much. Thank you, Dr. Padmavati and organizers of TAPCON for having me today. I'm very glad to be part of this. And without much further ado, I would begin my presentation. Is my presentation visible?
No, not yet. You have to start screen sharing.
Just give me one moment.
No issue, take it. Your screen is visible. Go to slideshow mode and start doing it.
Okay. So very good morning. My topic is sinonasal tract tumors. I'll be doing an update on this. And when we look at head and neck cancers, we think of squamous cell carcinoma, basically. And it is sinonasal. When we go to the sinonasal tract, it is completely different because per cubic centimeter of sinonasal mucosa has the greatest diversity of neoplasms all across from compared to the entire body. So it is a very exciting area in the head and neck area where we get to see a lot of diverse entities in the sinonasal tract. And there are a lot of challenges also involved in that. Because there are so many entities in this, it is not possible to cover, it would be like covering the world in 80 minutes. So this is again not going to be a didactic lecture talking about each and every entity, but just a practice point. So what I would do is basically give you a flavor of all the common entities that have existed for ages, and some of the young ones which have come up from these older entities that we have known and are now known as new entities. So regarding all these common tumors, I would mainly focus on the practice points of clinical importance and focus then on the newer entities which are recognized in sinonasal tract. So sinonasal mucosa, as we know, is a very unique mucosa, which is a mucosa lined by Schneiderian epithelium, which is a membrane which is ciliated, pseudostratified, having mucinous cells also. And it is a mucosa which is ectodermal in origin, and it gives rise to 3 very distinct type of papillomas, which are called as the Schneiderian papillomas. But as pathologists, it is important not to make a standalone diagnosis of Schneiderian papilloma. These have to be further classified, whether they are everted exophytic fungiform, inverted type, or the oncocytic type. Why? Because I'll just specify what is the importance. This is an everted type or an exophytic fungiform Schneiderian papilloma, where you have a more outward growth of the, it is an outward proliferation where you have papillary fronts with fibrovascular cores lined by squamous to transitional epithelium. The epithelium is hyperplastic, and you can see that there is absence of keratinization. There's not much inflammation, some scattered goblet cells. So this is a classical everted type of papilloma. And if you call this an everted papilloma, this is a very safe diagnosis. Patient does not need to follow up. Does not have any potential for any recurrence or malignant transformation. This is in contrast to inverted papilloma. I'm sure most of you have seen inverted papillomas. These are very characteristically showing, instead of growing outwards, they grow inwards. They have an inward growth into their stroma, into the parenchyma of the polyp. And because of this inverted growth pattern, they form these nests which protrude into into the underlying stroma. And what we can see is there is absence of any seromucinous glands here. There is no keratinization, and they don't have any thick basement membrane that you see in other type of inflammatory or allergic polyps. And inflammation is pretty common, but usually there is an absence of eosinophils. So inverted papillomas are important because clinically they are important because they tend to recur and they have a risk of malignant transformation. So it's important for pathologists to further classify whether it's an inverted papilloma or is it any other type of papilloma. Rarely we will come across these oncocytic papillomas, which on low power only you will see as a pink tumor. The epithelium is very oncocytic and the cells are pink, oncocytic with pinkish cytoplasm, and these because of their, and they have these characteristic intraepithelial microabscesses. So these are rare ones of all these 3, but it is important to identify them because the inverted papillomas are the ones which tend to recur and eventually undergo transformation to malignancy. And these are the patients who need to be followed up. Another entity is the respiratory epithelial adenomatoid hamartoma, also known as RHEA, which is not of any clinical significance to the patient, but it can create problems because of being mistaken for inverted papilloma or adenocarcinoma. These are basically benign glandular proliferations of benign glands which have pseudostratified mucinous epithelium and ciliated lining, and they can have very thickened basement membrane. Because of these crowded glands, they can be mistaken for adenocarcinoma if we are not aware, which is less likely scenario because these are usually very bland cytologically. But because of their crowding, they can seem to have an inverted type of growth pattern, and they can be mistaken for inverted papilloma. So just mention about this, that when we are considering inverted papilloma, we also need to be aware that there is an entity of respiratory epithelial adenomatoid hyperplasia, which is benign and should not be mistaken for inverted papilloma. So dysplasias can occur in inverted papilloma over time. About 5 to 20% of them can show dysplasia. So if we come across dysplasia in inverted papilloma, entire thing should be submitted because there can be a frank carcinoma somewhere. So dysplasia is seen in the form of cytologic and architectural disorder and atypia. And you can see that there is a lot of loss of polarity, increased mitosis, cytological anaplasia. So any mention of dysplasia it's important to look for dysplasia whenever we get inverted papilloma specimen, and it can be very focal, and it needs to be, the whole specimen needs to be embedded and examined. So carcinoma in situ, it can progress to carcinoma in situ, which basically means there is a carcinoma which is confined to the mucosa. And the incidence of carcinoma in situ is about 3.4%, and dysplasia about 12% of the inverted papillomas. And invasive carcinoma is when there is frank invasion associated with desmoplastic response, squamous pearls, and any type of cancers can be seen in inverted papilloma. And the commonest scenario is squamous cell carcinoma. The others are very rare. And another question is whether HPV, what is the incidence of HPV in Schneiderian papillomas? We see that most of the times this is not an HPV related disease. The high risk HPV that we see are oncogenic and seen in oropharyngeal squamous carcinomas are not the type of high risk HPV that we see with these inverted papillomas. Only 6 to 8% of the inverted papillomas show the transcriptionally active or the oncogenic high risk HPVs. Most of the HPVs which are associated are low risk and not associated with malignancy. So there is no routine recommendation for HPV testing in inverted papillomas. Coming to squamous cell carcinoma, even though it is in other areas, you may see more than 90% of the times this histology. If in sinonasal also, still about 50 to 60% of the tumors that you will see will be squamous cell carcinoma. And histology would be similar to the ones that we see in the oral cavity or in the larynx. Keratinizing and non-keratinizing, and all the variants which are seen elsewhere can be seen in the sinonasal area also. Compared to tonsil and the oropharynx, where we have HPV is very important. Now the squamous carcinoma is divided into HPV and non-HPV squamous carcinoma. Sinonasal has been found to be the second spot for HPV, transcriptionally active HPV. And about 15 to 21% can harbor high-risk HPV, and the morphology can be non-keratinizing or keratinizing, but the commonest histology that we see in those HPV-related sinonasal cancers are the non-keratinizing. How these behave is still not known. While we know in oropharynx the HPV-related cancers behave well, how they are in sinonasal tract and what are the etiopathogenesis, that is still not very clear. So I know this is going to be a long lecture and you'll have to bear with me. So we go to the next entities, sinonasal adenocarcinoma. Whenever we see something glandular in the sinonasal tract, we think it is going to be adenocarcinoma, but we should just pause and think that is it salivary gland tumor? So because salivary gland tumors of all types can occur in the sinonasal tract arising from the minor salivary glands, the entire spectrum can be seen. The commonest would be pleomorphic adenoma and adenoid cystic carcinomas. And diagnosis is not the only thing that the oncologist is looking for. One thing that we many times miss reporting is the grade of the tumor, and that is something which the oncologist is specifically looking for, because if it is a low grade tumor, surgery alone would be enough. But if it is a high grade salivary gland carcinoma, then they would need to remove the draining lymph nodes, as well as plan an adjuvant RT or chemoradiation. So as pathologists, we should not only give a diagnosis, whenever possible, we should also give the grade of the salivary gland tumor. Now, grading systems are available for mucoepidermoid carcinoma and adenoid cystic carcinoma, where they're divided into low grade, intermediate, and high grade. For other tumors like adenocarcinomas and myoepithelial, they're only divided into low and high grade. While others, by histology itself, the grade is implied. For instance, salivary duct carcinoma by itself is a high-grade carcinoma, whereas acinic carcinoma, polymorphous adenocarcinoma, and epithelial myoepithelial carcinoma by definition are low-grade carcinomas. So this is just a point I wanted to mention, that when we think of a glandular tumor in the sinonasal tract, first thing we have to rule out is it a salivary tumor? And in a if you're making a diagnosis of salivary tumor, you should grade it. And if it is not a salivary gland tumor, and if it's an adenocarcinoma, then we are supposed to see whether it is an intestinal type or a non-intestinal type. The intestinal adenocarcinomas of the sinonasal tract, they resemble exactly, they're called intestinal because they resemble, and morphologically and immunohistochemically, they have an overlap with the intestinal adenocarcinomas. They look exactly like colorectomy. If I don't tell you the site, you would say this is a colorectal biopsy. So they have this kind of stratified hyperplastic, this elongated CDX2, SAT-B2, MUC2 positivity, which are markers of colorectal or intestinal differentiation. And these intestinal adenocarcinomas show a strong association. History is usually very strong. The important thing is that clinically, these intestinal adenocarcinomas are high-grade malignancies, and they have a high risk of recurrence, and many of the patients die because of the disease. So many of the oncologists in some centers will give, because these are high-grade and they tend to present in advanced stage, they would like to shrink the tumor by giving neoadjuvant chemotherapy. So one of the requests that we get whenever we give a diagnosis of intestinal adenocarcinoma is to tell us the P53 status of the intestinal adenocarcinoma, because those which have, for a chemotherapy to act, the P53, for the cells to undergo apoptosis due to chemotherapy, the P50, if the tumor has an intact P53, then apoptosis is possible. Whereas if the P53 is mutant, does not work. So they always ask us as a predictive marker to identify whether the intestinal adenocarcinoma is P53 mutated or not. And it has been shown in various studies that P53, if it is functional, then it is an indicator to give induction chemotherapy or pre-surgery chemotherapy to downstage the tumor. So that I wanted to, if the tumor is not salivary, if it is not intestinal, then the adenocarcinoma is non-intestinal type. And in that also it is, sorry?
Your voice is little breaking. Can you adjust or do something? There was a lag little bit, 1 minute.
Okay.
Now you are audible.
Okay. So the non-intestinal type have to be distinguished and graded, whether they are high grade or they are low grade. So the high grade adenocarcinoma, non-intestinal, are like any other adenocarcinoma that we see elsewhere, and they typically don't show intestinal markers like CK20 and CDX2, and they are positive for CK7, CEA, and other glandular markers, non-specific markers. And usually these are high grade and you are not able to further characterize them. Then low-grade non-intestinal adenocarcinomas are the ones which they are uncommon, very rare, but it's important to recognize this type of tumor, which is papillary many times, has these very bland columnar cells with mucin, apical mucin, and they with hardly any mitosis. These are low-grade non-intestinal adenocarcinomas, which do not have any chance of much recurrence or metastasis. So these do not require any adjuvant therapy. So for as pathologists, we should be able to classify the adenocarcinomas into salivary, non-salivary, and non-salivary into intestinal and non-intestinal, and the non-intestinal into high grade and low grade. So going on to the other set of tumors that we very commonly see in this location are the tumors which just look blue. And very commonly you will see these closely packed blue tumors. And depending upon what age the patient has, it can be in a pediatric age group, you have these round cell tumors, these embryonal sarcomas, synovial sarcoma, leukemias, and the list is a long one that you would see anywhere else as well. If the patient is older, we would think of neuroblastoma, sinomesal, neuroendocrine. What do I do? Maybe
I think
the network is
just holding the mic and talking. That time there was no lag.
Okay. Yeah. I can hold it close to my. Is it better?
Yeah.
Okay. Thanks. So when we see a blue round cell tumor, or we are basically seeing a tumor like this, which is closely packed cells, don't give much clue about what they are. So age is an important change depending upon the age of the patient. If the patient is a pediatric patient, then round cell tumors and embryonal undifferentiated tumors are a differential, whereas in an adult we have olfactory neuroblastomas, SNEC, melanomas, lymphomas. These become our differential diagnosis. So neuroendocrine and neuroectodermal tumors, they have on one end we have the olfactory neuroblastoma on one differentiated, and on the least differentiated end we have the sinonasal neuroendocrine carcinomas. And olfactory neuroblastomas are tumors which arise from a very unique olfactory epithelium. And involvement of the cribriform plate is very important. As pathologists, we should know whether this tumor is arising or involving the cribriform plate, because as a dictum, if the cribriform plate is not involved, it is not olfactory neuroblastoma. Although there will be some case reports, but as a practice point, olfactory neuroblastomas involve the cribriform plate. And typically they have this lobular architecture, and they have these rosettes, and they there
is some voice lag again. Dr. Munita, there is a voice lag again. Dr. Munita, I think you can switch off and then join back again. Stop screen sharing and join back if that is okay. Yeah, again join back, just see whether it is okay.
Is it visible?
Yeah.
Audible?
No. Screen is not visible.
Okay.
Screen is not visible. Only video is there.
Okay.
The internet connectivity is good, no? At home, there is poor connection signal.
Is it visible now?
It has just started. Is there any connectivity issue? Just check your internet connectivity.
For Dr. Munita, internet connectivity is actually unstable. Sometimes it goes into red and then comes back into white.
Maybe it's because of
okay.
heavy rains.
Yeah, I know.
Yes, yes.
There are heavy
these are
rains in Mumbai.
Did it get connected?
Yeah, it's got connected. You'll have to go to slideshow mode.
Okay. So is the screen visible now?
Yeah. It is visible.
Okay. So do I need to go back?
Yeah, I think this has come way far up. You have to go a little back. 3 slides, 2-3 slides back.
That's mitosis, necrosis, and cellular pleomorphism. And if we see, and depending upon the descending
No, I think there is some issue.
Dr. Munita, your audio connection has gone. It doesn't look like your audio is connected to the meeting. So in case if you can hear me, kindly just rejoin and connect your audio.
Kindly bear with the inconvenience. We'll just resume in another 2 minutes. We'll just wait for Dr. Munita to join. I request all the participants to. Dr. Munita, the audience people are suggesting whether if you switch off the video, audio might become little clear, they say. So you can try that option also. You can switch off the video and talk on audio if that is working well.
Sure. So video is off only.
Now
I think the video I've turned off.
Talking, you can screen share and talk because of connectivity issue. If video is on and audio is on, there may be some difficulty. So you can switch off the video and talk with the screen share mode.
Is it now? You can see the screen?
Yeah, we are able to see the screen, and you will have to go back 2-3 slides earlier and go to screen share like slideshow mode and start up.
Okay.
You can
so olfactory neuroblastoma arises from a.
Yeah, fine. Go back 4-5
So
slides.
should I go back?
Yeah, should be fine.
Okay. So, about the neuroectodermal tumors, we have olfactory neuroblastoma on one differentiated end, and on the least differentiated end, we have the sinonasal neuroendocrine carcinomas. Olfactory neuroblastomas are tumors that arise from a specialized olfactory neuroepithelium. And the important point is that cribriform plate involvement is almost a dictum in olfactory neuroblastoma. If the tumor is not involving the cribriform plate, it is unlikely to be an olfactory neuroblastoma. It is typically characterized by lobular architecture. It shows these neurofibrillary rosettes, neurofibrillary stroma, and salt and pepper chromatin. People are raising hands. Do I need to stop or am I audible?
No need. They are inadvertently doing it. Not to worry about.
Hello?
No need to worry about the raising hands. Just Okay.
So the Himes grading is used for grading olfactory neuroplasmas. They are graded from grade 1 to grade 4, and this is based on 6 features. And basically, what we want to see is how much is the differentiation and whether there are any features of histologic aggressiveness. So based on lobular architecture, neurofibrillary stroma, and rosettes, if these are present, these are low grade Himes low-grade olfactory neuroblastomas, and they typically show lobulated architecture. They start showing these rosettes, and they have a very vascularized stroma and these rosettes, and these are low grade, and these usually do not require any neoadjuvant chemotherapy. The high grade are the grade 3 and grade 4, which have increasing mitosis, necrosis, and cellular pleomorphism, and loss of these kind of features of differentiation of stroma and rosettes. So the high grade olfactory neuroblastomas show more of these karyorectic bodies and apoptosis and increased mitosis and loss of that kind of lobular architecture. On the other hand is you see the sinonasal neuroendocrine carcinoma, where you don't see any differentiation histologically, except that there are small round cells in sheets with some stippled chromatin, frequent mitosis. And this is a diagnosis. For this diagnosis, you need synaptophysin chromogranin and show evidence of neuroendocrine differentiation. And then these are all aggressive tumors which require chemotherapy. Then there are tumors blue tumors where we cannot find any differentiation except for cytokeratin showing that these are epithelial tumors. These are called as sinonasal undifferentiated carcinomas. Only A1, A3 is positive. You have only sheets and sheets of undifferentiated cells. And cytokeratin tells you that this is epithelial differentiation. So I'll come back to SNUC again. Because there are a lot of recent developments in this. The other entity that we have to keep in mind in adults is melanoma. When the melanomas are pigmented, it is easy to make this diagnosis, but when they are amelanotic, this diagnosis can be missed and can be mistaken for a carcinoma. They can have all kinds of morphology, and very commonly they can almost look like squamous carcinoma when they are epithelioid. So it is important to have a low index of suspicion, and immunohistochemistry is required in amelanotic melanomas. We have a range of markers, melanocytic markers. S100 is a more broad spectrum marker. So in addition to S100, we need a specific marker like HMB45 or Melani to make a diagnosis of melanoma. The mucosal melanomas, in contrast to cutaneous melanomas are BRAF mutated, whereas the mucosal melanomas tend to be KIT mutated. These have poor prognosis. Important thing is we should always rule out a metastasis arising from any other part of the body. Then lymphomas are other round cell tumors which can occur in adults, and any type of lymphoma can involve the sinonasal tract also. The peculiar lymphoma which involves the nasal cavity is the angiocentric NKT cell lymphoma, so you should be aware, and it can be associated with a lot of fibrinoid necrosis of the vessel walls and a lot of hemorrhage. So I won't go into the details of lymphomas here. Regarding pediatric blue round cell tumors, all round cell tumors that can occur elsewhere in the soft tissues can occur in the sinonasal tract also. Important is to, and we require immunohistochemistry for their diagnosis and further subtyping. It is important to make the diagnosis because especially these three like Ewing sarcoma, rhabdomyosarcoma, and synovial sarcoma, it is important to make these diagnoses and not club them into any other undifferentiated tumor, because these have specific chemotherapy protocols. Again, it is a whole list of soft tissue tumors, round cell tumors that can occur. So I'll move on to the now. There has been a recent spurt in the new entities which have been discovered in the sinonasal tracts, and this
Dr. Munita, your voice is not heard now. some connectivity issue there, so we'll wait for her.
Okay, so can I start again?
Yeah, you can go.
So SNAC is so many diagnoses that we used to call as SNAC put into this waste basket of undifferentiated carcinoma. Now there are with the help of molecular advancements, many new entities have been discovered, and now we know that SNAC can be it is with the help of IHC and with the help of molecular, it can be categorized into specific diagnosis and entity. So for one of among them is the nut carcinoma. Nut carcinoma story begins in 1999 when a 12-year-old girl was diagnosed with undifferentiated carcinoma in the epiglottis, and she had a very rapid aggressive course and died a horrible death. That clinicians couldn't forget that, and they gave that tissue to the cytogenetics too, because they wanted to solve this case of why a patient a young girl with carcinoma had such a bad outcome. And the cytogenetics gave a breakthrough, and it found that unlike squamous carcinomas or other carcinomas which have very complex karyotypes, this tumor had a very specific recurrent translocations of translocation 1519. And this was involving the NUT gene, which is the nuclear protein in testis. This is the name of this gene. And it was found that this is a very specific mutation, and this gives rise to a carcinoma, which is the NUT carcinoma. And majority of the times the partner is BRD4, and the next common partner is BRD3. And this can be visualized on fish using a fusion probe for NUT and BRD4 or any other specific probe. Now, NUT carcinomas are recently described. They were earlier called as the NUT midline carcinomas. Now, the midline word has been dropped because they have been found not only in the midline location, but also in some lateral locations. These are highly aggressive tumors. Initially were reported in young patients, but now all ages are getting reported. And they have very poor outcome. And mediastinum and sinonasal are two sites which are very common. We have reported around 15 tumors in the sinonasal location. So it is one of the, in sinonasal location, NUT carcinoma is an entity that we cannot forget. What we see is sheets of undifferentiated cells and abrupt keratinization. So these two features are very important histologic features. Unlike squamous carcinoma, which usually shows a gradation, you have various ranges of maturation. What we see here are sheets and sheets of undifferentiated blue round cells, and then foci of abrupt keratinization, which may or may not be there. But this is quite, if we find this is a quite important diagnostic clue for NUT carcinoma. So again, blue round cells, and which are totally undifferentiated, and then you have this sudden keratinization. A specific antibody, NUT antibody, is available, which has a very high specificity and 100% specificity. So this is, we are fortunate that we have this antibody, and this is one of our case, which shows these undifferentiated cells, sheets and sheets of round cells. So when we see such a biopsy, our differential diagnoses there's a long list of differential diagnoses, but if we find this sudden keratinization, abrupt keratinization, single cell keratinization amongst these blue cells, we should think of NUT. These tumors are positive for cytokeratin, and these tumors are positive for P63 and P40. And if you note, these are markers of squamous differentiation as well. So many times we may think that we may stop short of these markers and give a diagnosis of squamous carcinoma. Also, when we see squamous differentiation, as pathologists, we tend to call it a squamous carcinoma. But in sinonasal location, if you have a blue round cell and keratinization with these markers, we should go ahead and do IHC for NUT, because otherwise this diagnosis can be missed. Fish is confirmatory, but it is not essential because the IHC is very specific. So we can see that these NUT carcinomas can look like any other round cell tumor. So it's important. So if you have a round cell tumor which is cytokeratin positive, then NUT IHC should be done, and fish is optional. This is another other cases which show this the keratinization can be very focal, or it can be extensive as well. And these are the cases which can be diagnosed as conventional squamous carcinoma or basaloid squamous carcinoma. Then these areas in small biopsies where you don't get any keratinization, they can be either diagnosed as undifferentiated carcinomas, or they can be diagnosed as any other round cell tumors. So it is important to be aware of the morphologic spectrum of nut carcinomas. Some other slides, you can have very focal squamous differentiation, single cell keratinization. So this is one of the pitfalls, that this is a diagnosis that we have to keep in mind. They can be misdiagnosed for squamous carcinomas, NUCs, Ewing's, nasopharyngeal carcinomas, and in mediastinum they can be mistaken for germ cell tumors. So they are not positive for muscle markers, neuroendocrine markers, lymphoma markers, germ cell markers, neural markers, melanoma markers. So these all markers are negative. They are also not positive for EBV or HPV. So all the other differentials can be ruled out on immunohistochemistry, but the most important is for the pathologist to have this differential in mind and to use this antibody. And why this is important is because right now there is no treatment for this disease, but if we look at the pathophysiology, this transfusion product of BRD4 and NUT, what it does is it sequesters the histone acetylase transferase, and it prevents acetylation, which as a result, the differentiation of the tumor is blocked. So histone deacetylase inhibitors, HDAC inhibitors, are available and are being used in clinical trial setting. If these are used in experimental models, they have shown that once these are used, they inhibit this complex and they induce a global differentiation, and you see the tumor undergoes complete maturation, and those round cells undergo all maturation. So that may be an answer, and there may be drugs available. So it is important to identify these tumors and select these patients for these clinical trials. And also it is important to keep NUT in the differential diagnosis of all high-grade sinonasal carcinomas. So this is, so next is another new entity is the SMART-B1, INI1 deficient sinonasal carcinomas. This is a new entity. We are, probably most of us are familiar with INI1, which is the other name for that is SMART-B1. SMART-B1 is a part of SWI-SNF complex, which is involved in chromatin remodeling, gene expression, and cellular proliferation. And SMART-B1 here, when this is involved, a lot of tumors are associated with INI1 deficiency. These more familiar one are the ATRTs, malignant rhabdoid tumors, epithelioid sarcomas, renal medullary carcinomas, myoepithelial carcinomas, and so on. And to this list, one more is this SMART-B1 deficient sinonasal carcinomas. Now these are, this is based on, it's a diagnosis that you make on IHC, but you can suspect on morphology, which it has a basaloid blue appearance, and something which is seen in all INI1 deficient tumors is these rhabdoid cells, and those can be identified. So if you see a basaloid high-grade carcinoma in the sinonasal tract with rhabdoid cells at any focal or diffuse, then INI1 IHC should be used, because it could be an INI1 deficient sinonasal carcinoma. They also tend to show extensive pagetoid surface involvement, and these are some of the reported cases. And the rhabdoid morphology has to be many times looked for. It may not be as apparent, but if you can see that a high-grade blue basaloid tumor, which otherwise we could either call it as NUC or basaloid squamous carcinoma, if rhabdoid morphology is looked for, we can do INI1 immunohistochemistry. It is a negative immunohistochemistry. Normal cells express INI1, and INI deficient tumor will be devoid of INI1 positivity. So these are some of our cases, which are, so again, it looks like any other blue round cell tumor with the high grade, and there is, here you can see some pagetoid involvement of the surface epithelium. It can show sheets and sheets of undifferentiated cells and rhabdoid cells. It can also show very clear cell morphology. In some of our cases, we have seen clear cell morphology also. So the basic thing is to include INI1 in all high-grade sinonasal carcinomas. It shows consistent expression with cytokeratin, so you know it is a carcinoma, and it tends to show variable positivity with P63. So it can be diagnosed as a basaloid squamous carcinoma. So important thing is, whenever we are thinking of a high-grade basaloid squamous carcinoma with some clear morphology or with some rhabdoid morphology, we should include INI1 to rule out SMARCB1 deficient sinonasal carcinoma. These are negative for NUT or negative for EBV and HPV. And these are highly aggressive tumors. And these were previously called as, these have been put into, labeled as SNUCs or non-keratinizing squamous, myopithelial carcinomas, polydifferentiated adenocarcinomas. But if you have INI1 IHC, we can give a more specific diagnosis. 78% of them are associated with the deletion of this gene. So the key features are that they have rhabdoid and basaloid morphology, pagetoid surface growth with a carcinoma in situ like features, INI deficiency, one deficiency on IHC, and an aggressive clinical course. Just a word about a very recent entity is the SMARCA4 deficient sinonasal carcinomas. Just like SMARCB1, SMARCA4 is a brother of SMARCB1, which is part of the same complex. And not much is known about it, but we know that about some of the SNUCs that we used to diagnose are now SMARCA4 deficient sinonasal carcinomas. Again, IHC is required for this diagnosis. A loss of tumor showing loss of SMARCA4 is labeled as SMARCA4 deficient SNUC. Another thing that we know is that majority of the SNUCs that we are diagnosing are turning out to be IDH2 mutant SNUCs. IDH is a isocitrate dehydrogenase gene, which is involved in this is a protein which is involved in cellular mitochondrial respiration. And there are other tumors like gliomas which are associated with IDH1 mutations. There are intrahepatic cholangios which are associated with IDH mutations. Similarly, SNUC is a new tumor which is found to be associated with IDH2 mutations. And the good thing is that IHC, a very specific mutant IHC is available, which is a multi-specific antibody MSMAB1, which is for the mutant IDH1, IDH1 by 2. So if this specific antibody is used and this is positive in the cytoplasm of the tumor cells, that tells you that this SNUC is IDH2 mutant. This is some of the slides. It shows cytoplasmic positivity. So the thing is, with the use of immunohistochemistry and morphology, we can now subtype this wastebasket of SNUC into various specific categories. So if we see the SNUCs originally, they can now, about 15% of them turn out to be NUT, about the same amount turn out to be SMARCB1 deficient, about 9% turn out to be SMARCA4, and about half to 80% turn out to be IDH2 mutated SNUC. So SNUC is disappearing as more and more specific entities are getting diagnosed. So I'm coming towards the end of this thing, just a few more entities. This is a very classical adenoid cystic, right? In the ethmoid mass. So this is a diagnosis that we like to make and very easy for us to make, adenoid cystic carcinoma. But if you see adenoid cystic carcinoma with sheets and sheets of solid sheets and areas of necrosis, we should stop short, because this may not be an adenoid cystic carcinoma. So especially tract, it has been seen that there are some tumors of salivary gland origin which are actually HPV positive and may not be salivary gland tumors. So this was a new entity described by Dr. Bishop, that HPV related with adenoid cystic-like features. This was adenoid cystic carcinoma showing HPV positivity in the form of diffuse P16 positivity and in situ hybridization with HPV positive. So they exhibited all high-grade morphology, unlike the typical adenoid cystic carcinoma. And the unique thing was this is a tumor which is restricted to the sinonasal tract. So whenever we are making a diagnosis of any salivary gland tumor, especially adenoid cystic in the sinonasal tract, we should also see that there are no high-grade features or high-grade areas like necrosis and solid sheets. And then we should also do P16 immunohistochemistry to at least screen out that it is not this entity rather than adenoid cystic carcinoma. So like adenoid cystic carcinoma, it has showed dual differentiation of ductal and myepithelial cells, but it also shows surface squamous dysplasia, or even inside the tumor you can have squamous differentiation. So that is something which is different from a typical adenoid cystic carcinoma. But it's important to note that normal P16 positivity can be seen in adenoid cystic carcinoma, and the pattern of positivity of P16 that is seen in a conventional adenoid cystic carcinoma is a canalicular or a ductal type of patchy positivity. But if in HPV related adenoid cystic like tumors, you see a diffuse positivity. Almost all the tumor cells are positive for adenoids for P16. And on in situ hybridization, it shows HPV viral particles. So that is the difference. That is a pitfall. So just a positivity is not important. It is the diffuse and strong positivity for P16 which is required. This entity is not like a basaloid squamous carcinoma because it does show true glandular and myoepithelial phenotype also. So this is now seen that it is not only adenoid cystic carcinoma. You can have other salivary gland like EMC-like areas or any other type of salivary phenotype as a part of the spectrum of this. So the term has been revised to HPV-related multiphenotypic sinonasal carcinoma. So these are the key features of this. It is HPV positive, typically located in the sinonasal location, salivary tumor-like morphology, and showing surface squamous dysplasia. So another case very quickly is an adult with spindle cell tumor arranged in fascicles and composed of basically a monophasic tumor, and associated with basically long fascicles, low-grade spindle histology. And what we suddenly see are invaginations. The surface epithelium shows it is embedded right within the spindle cell tumor, and other areas of HPC-like areas. So this has a long list of differential diagnosis in as far as the spindle cell tumors is concerned. And
I got connected now through my hotspot.
So IHC for this shows S100, which is a neural marker, and SMA positivity, which is a muscle marker. So when we see a spindle cell tumor with both neural and myeloid marker positivity, it is an entity which is now called as a biphenotypic sarcoma, which is a low-grade sarcoma, which has spindle cells and shows neural and muscle differentiation. It is typically characterized by PAX3 translocations and is associated with favorable biology. PAX3 IHC is now available, and it shows it can be used to make this diagnosis. And last but not the least, a rare tumor which is very unique to the sinonasal location is the sinonasal teratocarcinosarcoma. If you see a tumor which has a lot of components similar to an immature teratoma in the sinonasal location and comprising a mixture of neuroectodermal, epithelial, and mesenchymal elements, do not forget this diagnosis of sinonasal teratocarcinosarcoma. So maybe if I'm overshooting the time, I can skip the rewind. Dr. Padmavati?
Yeah, no problem. How many slides more?
Just few slides, 4 or 5 slides.
No issues.
Okay, so just because we have discussed so many new entities, I would just like to recap that if you see a with a basaloid cell and rhabdoid cells, do INI1 IHC, and if it shows an INI1 loss, then it is a SMART P1 INI1 deficient sinonasal carcinoma. If you see a salivary-like tumor in the sinonasal gland, do not jump to just call it adenoid cystic or salivary gland tumor. Look for surface dysplasia or squamous dysplasia. If you find that, do P16. If it is diffuse P16, it is a entity called as HPV-related multiphenotypic sinonasal carcinoma. If you see a patient with rapidly growing aggressive sinonasal tumor and looks undifferentiated, blue round cells with abrupt squamous keratinization, then we need to do NUT IHC. Nuclear positivity for NUT IHC is NUT carcinoma. Again, a spindle cell tumor, there can be a long list of differentials, but if you find these embedded epithelial, invaginated epithelial islands, and a biphasic nature, biphenotypic in the form of neural and muscle marker positivity, then it is a biphenotypic sinonasal carcinoma, and PAX3 IHC can be used to confirm it. So sinonasal undifferentiated carcinoma is now disappearing, and using immunohistochemistry, we can first see if it is a carcinoma using cytokeratins. If it is a carcinoma and shows positivity for squamous type of markers, P40, P63, and CK56, then we have to see it could be squamous carcinoma, it could be EBV positive. If it is EBV positive, it is lymphoepithelial carcinoma. If it is not positive, it is not carcinoma. If it is showing INI1 loss, it is a SMARCB1 deficient carcinoma. If these squamous markers are negative, then we have to think of polydifferentiated adenocarcinoma, which will be positive either intestinal or non-intestinal type. Or it is, if it is neuroendocrine marker positive, we have synaptochromo positivity, it is a neuroendocrine carcinoma. SMARCA4 loss is seen, then it is a SMARCA4 deficient carcinoma. And IDH mutation, if it can be IDH2 positivity is seen, then it is a SNAC, IDH mutant SNAC. So cytokeratin negative, you have a whole list. Important is we don't have to forget melanomas, olfactory neuroblastomas, and lymphomas, and a whole lot of round cell tumors. So immunohistochemistry has a lot of role to play in conjugation with morphology. And that's all I would like to say, that sinonasal pathology is exciting and includes diverse pathologic entities, and it is a perfect combination of morphology and immunohistochemistry in molecular tests to make a diagnosis. This is my head and neck DMG. Thank you very much.
Thank you, Dr. Monica. You can come on screen if possible. You can switch on the video if possible, Dr. Monica. Yes,
Yeah.
thank you very much, except for the technical.
I'm sorry for all the interruptions.
In spite of the heavy rains and with all that beating, you had done a great job. It was really wonderful listening to you. For want of time, I think there are a few questions in the chat box. Please address to it in by texting the messages, if that is okay for you, because I think we are running a little short of time. So we would, you can address the questions in the chat box and answer them.
Sure.
Thank you, Dr. Monica.
Thank you so much. Thank you.
Yeah, thank you. Thanks for accepting our invitation. Thank you.
Thank you so much for having me.
Next session will be Dr. Sukesh Nair. I hand over the mic to Dr. Sudha. We welcome you, sir, for the session. Thank you.
So it's a great pleasure for me to welcome and introduce Dr. Sukesh Nair for this session. He is at present holding the post of Professor of Pathology, Department of Transfusion Medicine and Immunohematology at the Christian Medical College. He did his fellowship in hematology at Westmead Hospital, Sydney in Australia. And he's a scientific coordinator of a proficiency testing program, that is a EQUAS program about which all of us are quite familiar. And he volunteers a lot of time for the bleeding disorder community. And he has conducted a lot of hands-on workshops and has held a lot of teaching sessions with respect to this bleeding disorders. And he has also created the concept of hemocytomorphometry, which is to create the awareness that cell counters could provide parameters which reflect the peripheral blood morphology. And his laboratory is also the preferred training center in hematology for laboratory personnel and who are awarded fellowships by WFH and ISTH and ASH. Without wasting much time, over to you, sir, Dr. Sukesh.
Okay. Can I share my screen?
You can start sharing the
Yes, sir.
screen.
You can share your screen now.
Okay. Fine. So thank you very much for inviting me for the webinar.
Sir, 1 minute. You'll have to go to the
okay, fine.
presentation mode. Yeah.
Is that fine?
Yes, it's fine.
Okay, fine. Okay. So thank you very much, Dr. Sudha, for the introduction, and Dr. Padmavati for inviting me for this webinar. Today a lot of adrenaline has flown trying to connect to this site. I think probably because of the lockdown, everybody is at home in the campus here. So all connections are preventing some connections. So that's probably the reason why this has happened. So I will be taking you through conditions that cause abnormal bleeding. We all know that we all bleed when we have an injury. But what is necessary is to understand what is abnormal bleeding. So bleeding, we all know, is attached to this particular pathway that we have learned from our MBBS days, which is the coagulation pathway of intrinsic and extrinsic pathway. We know that activation of coagulation happens by either contact activation or release of tissue factor. Tissue factor will initiate the extrinsic pathway, which combines with factor 7A to activate factor 10. Activated 10 will activate prothrombin to thrombin, and while the contact pathway will activate factor 12 to 12A, which activates factor 11 to 11A, and that activates factor 9 to 9A, which combines with factor 8A to activate factor 10, and of course that is the generation of thrombin through the intrinsic pathway. And we know that deficiency of factor 9 and 8 causes a severe bleeding disorder called hemophilia A or hemophilia B, respectively, and they definitely cause abnormal bleeding. So I will start with this lady, a 45-year-old lady who was referred by a surgeon, cardiothoracic surgeon from Coimbatore, because this lady was awaiting coronary bypass, and they found that the APDT was very high, more than 100 seconds. When it was done in CMC2, it was 113 seconds, while the reference range for APTT is 27.8 to 36.5 seconds, which is established in the laboratory itself. So obviously this APTT is quite prolonged. So what is APTT? APTT is the time taken by an anticoagulated citrated plasma to clot in the presence of negatively charged contact activator like silica, kaolin, ellagic acid, in the presence of phospholipid, which is called the partial thromboplastin. That's why this is called the activated partial thromboplastin time. And of course, calcium has to be added to recalcify the citrated plasma. So this contact activator will activate factor 12, and of course you have the intrinsic pathway being carried out till the formation of the clot, which is through thrombin. The normal way to result the APTT will be your time of the patient obtained on the patient's plasma along with the reference range. Some people like to compare it with that day's control time, but the standard says that please use it along with the reference range. Some of the hematologists, they like to use the ratio, that is the time obtained on the patient's plasma divided by the normal plasma time, and any ratio of more than 1.2, which will be equivalent to 6 seconds more than the control time, will be indicating an abnormal or a prolonged APTT. And we know that a prolonged APTT can be because of the deficiency of the intrinsic pathway factors, that is factor 12, 11, 9, 8, 10, 5, thrombin and 5, prothrombin and fibrinogen. So this patient had also other tests done, like prothrombin time, which was 12 seconds, and also a platelet count was done, which was normal, 185,000. What is prothrombin time? Prothrombin time is also plasma clotting time, which is taken by recalcified citrated plasma to clot in the presence of tissue factor. So tissue factor will activate the extrinsic pathway. So it is basically measuring the extrinsic pathway. Tissue factor is nothing but thromboplastin, which has got a lot of negatively charged phospholipid attached to it. So what are the screening tests for hemostasis? There is platelet count, bleeding time, which is checking the plasma, the platelet activity or platelet function analysis, prothrombin time, which looks after the extrinsic pathway factors, activated partial thromboplastin time, which looks after the intrinsic pathway factors. So it covers fairly the entire area of coagulation. So what is the goals of pre-surgical hemostasis? Obviously, this lady had a pre-surgical hemostasis assessment in which the APTT was found to be prolonged. So the goals of a pre-surgical hemostasis assessment is basically because of the worry that after inducing an injury to the patient during the surgery, you have an bleeding that will start. So we are trying to identify who will have abnormal bleeding compared to just normal bleeding. So discrimination between normality and pathological bleeding or abnormal bleeding tendency is a significant challenge. Of course, differentiating between a severe and a mild bleeding disorders is very, very easy, but distinction between normal subjects and those with mild bleeding disorders is often unclear. So what happens in a lab when you have a prolonged APTT? So we do a test called, before doing the test, we actually find out whether the sample was collected properly. Because one of the most common cause of a prolonged APTT is a bad sample collection. So the most common cause for abnormal APTT is the bad sample collection. So you have to basically look at time of sample collection versus time of analysis. Then sample collection itself, whether the long procedure was followed. Most of the hospitals now in India are now collecting samples in the evacuated tube. So it uses an evacuated tube system. So evacuated tubes, always you need to collect samples using an evacuated tube system, which is the evacuated tube system needles, the needle holder, and the evacuated tubes. It is the best system of sample collection because the sample comes directly in touch with the anticoagulant as soon as it comes out of the vein. Most of the people tend to use syringe and needle method. Only problem is how do you transfer the blood in the syringe into the tubes? Most of the people open the caps of the evacuated tube, converting the evacuated tube system into normal tubes because the vacuum is gone, and then transfer the blood from the syringe into the tubes. You must realize that opening the cap of an evacuated tube increases the chance of compromising the integrity of primary sample. Never open the cap of the tube if you're using evacuated tube system. Of course, many people don't use evacuated tube system, but at that time they take that care of collecting the sample properly by transferring the sample from the syringe in the tube into the anticoagulant within 1 minute of the draw of the sample. So if you take that much care, no problem. But just because you have evacuated tube system doesn't give you the guarantee that opening the cap may give you a good sample. So so when we have an abnormal APTT, generally we call the system as the blood collecting system, maybe from the ward or from our own laboratory where the sample was collected properly. Then after the that is verified that the sample was collected properly, you must realize that a test is done, which is actually the most important test in a coagulation laboratory. This test is mandatory to hospitals which manage patients who are likely to have abnormal bleeding or any form of bleeding, because this test will tell you whether the patient is bleeding because of any particular disorder. And that test is called the mixing studies. It's also called correction studies because we are trying to correct an abnormal APTT or find out the reason why to correct an abnormal APTT. So how is mixing studies done? It's basically very simple. You mix equal volumes of the plasma which gave the abnormal time with normal plasma. Ideally, we must use a control pool plasma where all factors will be in close to 100%. That means normal quantity. So that's why you pool some people's plasma, because some single plasma may not be, single normal plasma may not be the right one. So you pool some plasmas and then you call the control pool plasma. So you mix that with abnormal plasma in equal volumes and repeat the test which was abnormal. Like in this patient, the APTT was abnormal. The rationale of this test is that if the prolongation in time is due to deficiency of factor in the test plasma, the normal plasma will provide the deficient factor on mixing, and therefore it corrects the prolonged time. So it indicates that there was a deficiency of a factor. But if the prolongation in time is due to an inhibitor, like the patient may be on heparin or there may be an antibody to a factor, the normal plasma will also be inhibited and the prolonged time will remain prolonged. So correction of time, which was abnormal in the patient plasma after mixing, will indicate deficiency of factor, but no correction will indicate the patient has got an antibody to a factor or maybe on heparin. Most common cause of non-correction is heparin, lupus anticoagulant, factor inhibitor, and large amounts of FTPs and D-dimer. This correction study has direct interpretation to therapy. So just imagine if you have a patient who is bleeding in the theater, has a prolonged APTT. Correction of time by mixing studies will mean that with normal plasma means that if you supply the normal plasma to the patient, which contains a deficient factor, or transfuse FFP, the clotting defect which prolong the time will get corrected and the bleeding will stop. So that is the importance of mixing studies. Without mixing studies, you cannot transfuse anybody. Non-correction of time, which is important information, will tell you that there is no point in transfusing FFPs. Instead, identify what the cause could be and use safer products like heparin in the case, protamine in the case if it was heparin that was identified. And if it's an inhibitor, use other agents. So coming back to my patient who had an APTT of 113 seconds, prothrombin time was normal, platelet count in the CBC was normal, bleeding time was normal. Mixing studies showed that the patients with normal plasma showed complete correction of the prolonged APTT, which was 32.3 seconds, which now gives me an indication that this patient has got a factor deficiency. So which factor? Because PT was normal, we are looking at the factor in the APTT pathway. That is factor 12, 11, 9, 8. The APTT pathway has 10 prothrombin and fibrinogen, so common pathway factors, we don't worry. So this prolonged APTT would be either a deficiency of factor 12, 11, 9, or 8, since prothrombin time was normal. So I did an assay on this patient, all these factors, intrinsic pathway factors, and we found that the factor 8 was 283%, normal is 50 to 150, so it's quite high. Factor 9 was also high, 175 international units per deciliter, or 175%. Factor 12 was also normal, 75%, but factor 11 was absent. It's less than 1%, so we have a severe deficiency of factor 11. So this patient in the old days would have been called as severe hemophilia C, because factor 11 deficiency was called as hemophilia C, but they also have a bleeding tendency. So what is the screening test for hemostasis? Platelet count, bleeding time, PT, and APTT. But there is one more test which is the most important test in the field of hemostasis, and that is history. This patient has no past, 45-year-old lady, has no past or present history of bleeding. She had 2 full-term normal deliveries, and there was no transfusion that were required. So we may think that the history taking must have been very poor, but nowadays there is a very objective way of taking history, which is called the bleeding assessment tool, whereby you have this questionnaire in which you have all the bleeding symptoms like epistaxis, bleeding from minor wounds, oral cavity bleeding, GI bleeding listed, and the severity. That is, whether it was just seen, whether it's the patient consulted a doctor because the bleeding was slightly more severe, or sometimes the bleeding was more severe and therefore it required any intervention by the clinician. And of course, the next severity is bleeding was so severe that blood transfusion was required. So all the bleeding symptoms are listed here, like menorrhagia, and of course hemarthrosis, CNS bleeding, and a score of 4 or more than 4 in an adult male, score of 6 or more than 6 in an adult female, especially those who have menorrhagia as a symptom, and 3 or more than 3 for a child is considered to be a bleeder, with almost a negative predictive value of, or lower values of 99.6%. So let's look at how you apply this bleeding assessment tool. So we have an 18-year-old female. I'll just highlight her symptoms. She's got epistaxis and oral bleed since the last 5 years, and for which she has been taking tranexamic acid. So she was referred to rule out platelet type disorder or von Willebrand's disease. So applying her bleeding tool, she has epistaxis, for which she had antifibrinolytic agent. So what is the bleeding score? Bleeding score is 3. Is she a bleeder or not a bleeder? So you must remember that she is a adult female, 18 years old. And for an adult, a score of 4 or more than 4 is considered to be a bleeder. So this will be not a bleeder as per the bleeding assessment tool, but she was referred to the lab for identifying whether she has got mild von Willebrand's disease or platelet function disorders. In such type of patients, we have to do so many tests because the clinician has referred the patient. But if the clinician had used the bleeding assessment tool, may not have referred this patient. And finally, we come out with a diagnosis of no intrinsic hemostatic defect, which even the bleeding assessment tool did identify. For patients who have got menorrhagia, you have got what is known as the pictorial bleeding assessment chart, where you can even allow the patient to score based on the number of the pads that were used for the menorrhagia. So here we have a 2-year-old boy who was brought to the emergency department for oozing blood from his mouth following a fall 6 hours back. He has also had prolonged bleedings from his immunization site, and he has bleeding following trivial trauma which required suturing. So if you look at his bleeding assessment tool, bleeding from minor wounds requiring surgical hemostasis. So bleeding score of 3. So this is a child who has got a bleeding score of 3, and in a child a bleeding score of 3 or more than 3 is considered to be a bleeder, and the final diagnosis was mild von Willebrand's disease. So bleeding assessment tool can be very objective assessment of bleeding history. So coming back to my patient who has severe factor 11 deficiency, there was no history of bleeding at all. So if you look at this particular pathway that we had, intrinsic and extrinsic pathway, we should assume that factor 11 deficiency, absence of factor 11 will not generate thrombin, and there's a likelihood of bleeding in this patient. But this patient has never bled in her entire life. Now in this picture, I'm trying to show those two groups which actually published this pathway. The extrinsic pathway was published by Robert McFarlane from Oxford, and that's a picture that he got of him. He got interested in the extrinsic pathway because his father died of a Russell's viper venom bite, and that we know that Russell's viper activates factor 10 to 10A, and that's how he got interested in the coagulation system, and he described the extrinsic pathway to us. For the intrinsic pathway, we have the picture here, which was described by the group from Oscar Ratnoff and Davy from Cleveland. And that picture, you see Oscar Ratnoff collecting blood from a gentleman called John Hagman. And we know what John Hagman is. This particular gentleman did not have any factor 12. He had severe deficiency of factor 12. You can see that he's not that young. This picture was taken a week before he died of a pulmonary embolism following an accident. And interestingly, he has never bled in his life. Yeah, and later on, it was found out that he had episodes of deep vein thrombosis and he died of pulmonary embolism. So question raised is, why does factor 12 deficiency not bleed? So this guy has never bled in his life. So factor 12 deficiency does not cause bleeding, was later on identified. And coming back to my patient, factor 11 deficiency is also not a bleeder. But we have also identified patients who have got factor 11 deficiency, may not be as severe as this lady, maybe 2%, maybe 5%, maybe 11%, who actually have bleeding symptoms. So factor 11 deficiency is known to cause variable symptoms, no bleeding to severe bleeding. So interestingly, I was looking at the names. I mean, the publication that these people published. One group published it Oxford published it in Nature, and Oscar Ratnoff published it in Science. One of them called it as the cascade, and other one called it as a waterfall. So you can make a good guess which one is the extrinsic pathway of the waterfall or cascade, or the intrinsic pathway of the waterfall or cascade. It's easy for us to look at the picture, but later on I found out that the intrinsic pathway was called the waterfall and the extrinsic pathway was called the cascade. So coming back to the issue that obviously people started questioning this pathway because the factor 12 deficiency does not cause bleeding. Factor 11 causes variable symptoms. And also the question was raised is that we know that deficiency of factor 9 and 8 causes severe bleeding disorders called hemophilia A or hemophilia B. But why should these people bleed when they can actually generate a clot through the extrinsic pathway? So that was a big question that was asked. So answers started coming in the mid-80s, early 80s, by the discovery of the fact that tissue factor extrinsic pathway along with factor 7 can activate factor 9 in addition to factor 10. And a discovery of a very important protein called the tissue factor pathway inhibitor, which is TFPI. It inhibits or blocks the further action of tissue factor and factor 7A. So what happens is when 10A is generated by the tissue factor, it combines with TFPI and comes and blocks the extrinsic pathway. So no more further contribution will be happening from the extrinsic pathway. So answers started coming in the form of a new pathway, which is called the cell-based theory of hemostasis. That is, all coagulation process occurs on the surface of tissue factor-bearing cell, either the endothelial cell, platelets, or monocytes. And they came out with 3 steps: initiation, amplification, and propagation. So you can see that the initiation is just the exposure of tissue factor. Tissue factor is usually hidden between the phospholipid bilayer. Not even a small part of the tissue factor is exposed, but when it's exposed, it immediately activates a coagulation. So you can see here that as soon as it's exposed, the combines with factor 7A and activates factor 9 to 9A and 10 to 10A. This 10A will find a little bit of prothrombin near it and activates prothrombin to thrombin. So it produces very small amount of thrombin. This thrombin is of no use, but what this thrombin does is it actually initiates the amplification pathway by activating the platelets. And in the platelets, it activates the factor 5 to 5A because platelet contains factor 5A. Factor 5. The platelets also contains 1 Williams factor, which carries the factor 8. So it activates factor 8 to 8A. And platelets contain a little amount of factor 9 and converts 9 to 9A. So this activated 5 and 5A allow the formation of two important complexes, which is called the tenase complex and the prothrombinase complex. The tenase complex is basically because the substrate is factor 10, and the factor 8A allows factor 9 to activate factor 10 to 10A. While the prothrombinase complex, the substrate is prothrombin, the enzyme is factor 10A, but factor 5A brings 10A close to factor 2 so that it allows the activation of factor 2 to 2A. At the end of this particular step, lot of thrombin is produced, almost 100,000 molecules of thrombin is produced. But just to make sure that it is 100,000 and not less, the system has created another step called the propagation. You remember the factor 11 that was activated by thrombin. That 11A will activate factor 9 to 9A, and then you have the tenase complex forming, the prothrombinase complex forming, and it produces some more thrombin. So this ensures that definitely more than 100,000 molecules of thrombin is produced. So now you can see that it's not very much different from the old pathway. The initiation is nothing but the old intrinsic pathway, but with factor 9 involved. Amplification, nothing but the old common pathway with additional participation from factor 9 and factor 5. And propagation is nothing but the old intrinsic pathway with no factor 12 at all. So the answer is no role for factor 12 in coagulation. And you can see the sheer importance of factor 9 and factor 8. Without factor 9 and factor 8, you will not get amplification at all. And that's why the patients bleed a lot. The cell surface helps localize the clot formation. And you can see that at the end of amplification, that is the amplification step, where 100,000 molecules of thrombin is produced. If it guarantees that 100,000 molecules are produced, what is the role for propagation? There is no role for propagation because all the molecules of thrombins are produced from the amplification step. So there is no role for propagation. If there is no role for propagation, and what is the single enzyme in propagation? Factor 11A. So there is lesser role for factor 11A if amplification does all the job. So for completing the coagulation system, just imagine this is a blood vessel where all the coagulation factors are in circulation. They're all in the inactive form. So you can see the factor 8 being carried by 1 Williams factor. And all these coagulation factors will be coming out through the injury site. Now, all we require is that something should hold these coagulation factors and platelets at the site of injury so that the coagulation can take. So something has to hold them. Otherwise, they'll be keeping on flowing out from the site of injury. So let's magnify this. So just imagine if it's arterial bleeding, all of them will fly out. So just to magnify this, there's a platelet which is being carried out by the flow of blood outside. Somebody should hold this platelet at the site of injury so that they can start clotting. And now, of course, the subendothelial collagen is also exposed, so something has to hold these platelets. And that is done by this large protein called 1 Williams factor. It's a very large protein which is found circulating in the blood in coiled form. It needs to get activated, and what you see down is activation. It rolls out like a carpet when it sees exposed collagen. So what happens is in the coil, the inside part of the coil is actually the activated part of the active part of the 1 Williams factor, which binds to platelets. Usually it is hidden in the coil. It cannot be exposed. And then A3 part, which is the outside part of 1 Williams factor, has an affinity for collagen. So now you can see that when the collagen finds collagen, when the 1 Williams factor finds collagen, the A3 part will start attaching to collagen one by one, allowing the 1 Williams factor to roll out like a carpet and expose the active part, which binds the platelet. So now you can see that the platelets are being taken with the flow of blood. It suddenly finds something it likes, tries to bind, but every time it tries to bind, the flow of blood takes it away one by one. But every time it tries to bind, it develops resistance to the flow that finally it can have enough resistance to stop, resist the flow, and get activated in the process. So just imagine if the von Willebrand's factor was not long enough, by the time the platelet is able to develop resistance to the flow, it goes off and the bleeding will continue. So this happens in a very qualitative type of platelet, von Willebrand's disease called type 2A, where there is absence of high molecular multimers. So you must remember that von Willebrand's factor will be only functional if the entire multimers are normally present and in normal form. So let's see, the platelets are able to resist the flow of blood, stop, get activated in the process. During the activation, it releases more procoagulant substance, which attracts other platelets and activates those platelets and allows the platelet aggregation to happen through the glycoprotein 2B3A and fibrinogen. And it allows the formation of the primary hemostatic plug. Now, this primary hemostatic plug is not stable, so it requires stability, and that stability is a cemented stability is brought in from in the form of fibrinogen getting converted to fibrin. So coming back to my patient, no past or present history of bleeding. The issue is, if history is so good and allows a patient to be identified as a bleeder or a non-bleeder, why don't people just use history alone? So the issue again is inadequacy of history by a physician, but that can be overcome by using the bleeding assessment tool. Then, of course, the unreliable patient who is not able to give proper history, and sometimes even a poor person, a person who does not elicit history properly. And one of the most common history that is missed out is that there will be increase tooth extraction, bleeding from tooth extraction will usually be missed by the person taking history or even the historian. Tonsillectomy bleeding, because everybody thinks that anyway we bleed from, but abnormal bleeding is usually ignored. So this is a symptom that is usually missed. Then, of course, you must appreciate that there are certain disorders which can bleed only when the knife is put, like mild factor 11 deficiency or factor 7 deficiency. But these are all mild factor deficiencies. Then acquired disorders like acquired hemophilia A may not present till the surgery happens. So these things have to be appreciated. But the BAT usually overcomes all this. And if you can use a BAT and the short history BAT with a PT and APDT, which can identify the mild disorders as well as the acquired bleeding disorders like acquired hemophilia A, we can possibly identify patients who may have abnormal bleeding. So coming back to my patient, you see how much factor 8 she had, how much factor 9 she had. And now if you look at, apply these numbers to the pathway, the new pathway, you can see that her factor 8 and factor 9 was so high that she was producing not 100,000 molecules at the end of amplification, but almost 200 to 400,000 molecules of thrombin. She never required propagation. So her factor 11 was not required at all during her life. So, so what we did was, when we sent the patient back as a accountable hematologist, we decided that we have to write a report, not just factor 11 deficiency. We said that this patient will not bleed during surgery, and for that we did thrombin generation test, in which we found that patient produces large amounts of thrombin. And so that report was quite comprehensive, and we even said that the patient will not bleed during surgery. So after reading the report, you know what the surgeons did? They ordered 4 FFPs. So now, how did I get to know about it? Because the anesthetist for the surgery, who was actually trained here previously, she called from Coimbatore and said that should she transfuse the FFP before a particular test that they do called the activated clotting time, or should she transfuse the FFP and then do ACT, or do ACT, find the baseline and transfuse the FFP. So I said, why FFP? They said they have ordered the FFP. So I said that don't transfuse the FFP, just thaw it and keep it. The best judge of abnormal bleeding is the surgeon, and of course it's an experienced surgeon. If they say that the field is, if there is abnormal bleeding, they will tell you, then you can transfuse the FFP. So that, she called me later and said that the FFPs were discarded because it was not required. The surgeons were very happy with the field. So one thing I realized, that abnormal bleeding is identified when the abnormal bleeding is seen. But when we do the test, are we trying to identify those people who are potentially abnormal bleeders? I learned a lesson from this, is that the tests are done so that the surgeons can have a clear field. So it is for the clear field that we are doing the test and not to identify a potential abnormal breeder. Abnormal breeder will definitely have history. So one thing I realized that all these tests are done for identifying patients who will develop a clear field for the surgeon. Another scenario, we have, I think I may have, how many more minutes, Dr. Sudha?
Yes, sir, you have about 20 minutes. Is it okay?
Thank you. Yeah, that's fine. Thank you very much. Okay, so I have got another patient here. This is a lady who had acute fatty liver of pregnancy. She was bleeding very severely with coagulopathy after delivery. She was given 8 red cells, 8 FFPs, 21 units of cryoprecipitate, 16 units of platelets, and 7 separate monitoring of PT, APTT, fibrinogen, hemoglobin, and platelet count. And finally, when you look at the results, now we can say that patient is no longer coagulopathic laboratory-wise because the PT is 12.1, APTT is 28 seconds, fibrinogen is 155, the hemoglobin is 9.1, and platelet count was 65,000. So you can look at the results, very clear that none of them will cause abnormal bleeding because platelet count of more than 50,000 definitely is not a bleeder. But why is she continuing to bleed despite all these test results being normal? So does clinical management create another acquired coagulopathy? I wouldn't say iatrogenic, but yes, there could be an acquired coagulopathy. And why are these tests not reflecting clinical bleeding? So we know that the PT and APTT, which represent the old extrinsic and intrinsic pathway, is not exactly representing the coagulation process. Then we also know that pregnancy is a totally different coagulation scenario compared to normal state. Pregnancy is a transient hypercoagulable state where all procoagulant factors, especially fibrinogen, von Willebrand's factor, and factor VIII are very high. Some of the natural anticoagulants are low. There is increase in fibrinolysis. And what are these changes for? Are they to protect the baby or to protect the lady? I mean, the lady. Yes, it is to protect the lady. Because during normal delivery, there's a huge risk of hemorrhage because you must remember from between the placenta removal and the tone coming back, we have a large raw area, which can bleed like anything. So this coagulation factors are basically developed very high to stop the bleeding when the tone comes back. So of course, obstetric hemorrhage has different etiologies. Most common cause of obstetric hemorrhage is uterine atony, the tone not coming back. And of course, a little bit of few cases of some trauma in the tract, which may not be seen, obviously. So these are the most common cause of obstetric hemorrhage. Of course, DIC and all those things are very rare. So what is postpartum hemorrhage? 500 ml of blood loss within 24 hours of vaginal delivery or 1,000 ml of blood loss within 24 hours of cesarean. Of course, we must also know that blood loss assessment should be very objective and not just seeing the drain and getting alarmed. Some way you can look at hemoglobin concentration drop of 4 grams can be an indicator of this blood loss. Of course, massive PPH is when the blood loss is more than 2.5 liters. Then why are the tests normal in these patients? A study which showed in patients with PPH, most of the patients who were studied, their PT and APTT was normal till the blood loss reached 5 liters. So PT and APTT is not an indicator of a coagulopathy in a patient who has got PPH. And then, of course, there are other impaired preconditions like acidosis, especially in patients in intensive care, because we know that low pH can decrease the coagulation efficiency. Hypocalcemia because of a lot of transfusion of citrated blood, like FFP, they all contain a lot of citrate. And of course, other fluids that are given to the patient. Then low hematocrit, I will come to that later, and hypothermia. Hypothermia because we know that all coagulation functions happen at 37 degrees centigrade. So you must remember that hematocrit is, or red cells also help in coagulation. If the hematocrit is normal, the platelets are push to the sides of the blood vessel so that it can reach the site of injury very fast and also help in clotting. If the hematocrit is low, all the platelets are in the center and they are not able to efficiently reach the site of bleeding, and therefore the bleeding may continue. So hematocrit of 30% is mandatory to allow for good platelet function. So hematocrit of 30% will be close to a hemoglobin between 9 and 10. And in our lady, the hemoglobin was 9.1. So please, if you have a slight ooze, please make sure that the hematocrit is more than 30%. Hypothermia is also very important to note because the sample is sent. They will not tell you how much the temperature of the patient is because all the tests in the laboratory are done at 37 degrees centigrade and not at the temperature the patient has. And when we do the test, we may actually be overestimating the hemostatic competency of the patient rather than the incompetency because of low temperature. So this has to be kept in mind when doing the test. So we have this lady who has no other impairments, all clotting system was normal. Then we look at fibrinogen. We realize that fibrinogen levels are very important for normal pregnancy. And when the between the placenta coming out and the tone coming back, the fibrinogen levels from 600 can fall to less than 200 in very short time. So if the fibrinogen is less than 200 milligrams per deciliter, it has a positive predictive value of severe PPH. So fibrinogen of less than 200 is not allowed to happen when the tone comes back. And if it is less than 200, it may go on to major complications for the patient, including ligation of the artery, hysterectomy, and sometimes level 3 intensive care. So the fibrinogen has to be maintained at 200. So that was the message that I wanted to pass on. That is, in PPH, the fibrinogen has to be measured, and it has to be measured by the Won-Closs method and no other method. So Won-Closs method fibrinogen of 200 is a predictive of poor outcome in many times when the patient is bleeding, immediately they call the blood bank and said that, can you send us FFP, and you have the shock pack protocols, that is 1 pad cell, 1 FFP, 1 platelets. You must realize that shock packs can be very dangerous in pregnancy because shock packs have been decided by trauma people and not by PPH people. So disadvantage of unmonitored shock pack transfusion is that you must realize that the patient is actually having normal coagulation factors and platelets at the time. When you transfuse this, you may be diluting out the coagulation factors. So you must realize that a lady who is pregnant, she may be having a fibrinogen of 500, 400, 300. And when you transfuse FFP where fibrinogen is 150, you may be diluting the fibrinogen off. So finally, we realized that this lady's fibrinogen was 155. We gave her a full dose of cryoprecipitate and she never bled again. So you must realize that guidelines have to be understood properly, and unnecessary transfusion should be avoided, and proper measurement of coagulation has to be undertaken. So transfuse to correct only when an abnormal bleeding is evidenced, easy in facilities which have blood and blood products within inside. Good to know what is to correct because you have 4 choices only: red cells, FFPs, platelets, and cryos. We must realize that hemostasis changes in liver disease actually tilt towards hypercoagulable state, but all measuring systems will show that patient is hypocoagulable. So that also has to be appreciated. Products, especially FFP, will have lesser factors than the patient. So the risk of diluting the hemostatic potential of the patient or dilution coagulopathy is a possibility. So most common cause of unmonitored transfusion of shock packs is a bad outcome for postpartum hemorrhage. So there will be some other patient factors which I want to bring to your attention. I have a small anticoagulation follow-up on some patients. So this is a patient who is in Darjeeling. Poor lady has to come down to Siliguri to do her anticoagulation tests for INR because she's on warfarin. And after the results, she sends me her results and I advise her whether to continue on the same dose or not. So this mail came from her, and that is today her INR is 4.42. Because she has got double valve, her target INR is between 2.5 to 3.5. So this is slightly high, and she was taking 2 milligrams. So I immediately wrote to her that it's a bit high. Have you been well? Are you taking any antibiotics? Then the second question was, has the mango season started in your place and are you having a lot of mangoes? Please reply to this mail. Skip this evening's dose and restart at 2 milligrams tomorrow. And please check the INR on Saturday. So then she sends a reply that she took 2 milligrams yesterday and she has 3 to 4 mangoes in a day. The issue was, can't I have mangoes? Please let me know if I'm not supposed to have them. And then she also mentioned, last week I had antibiotics for sore throat and cold. You must realize that antibiotics in a patient with has to be very carefully administered in a patient who's taking warfarin, because the intestinal flora is destroyed, which produces a little bit of vitamin K, which balances the so when the antibiotic given, all the vitamin K source is lost, and therefore it enhances the effect of the warfarin. That's why INR went to 4.42. And please remember, she also mentioned that she developed a hemorrhagic cyst. If that's why clinicians have to be very careful when they administer something. They should know if there are any other drugs the patient is on. Anyway, so this was a good answer, good reply that she gave, because I realized that it was because of the antibiotics her INR had gone up. So I replied to her is that thanks for your reply. INR is a bit high because of the antibiotic. Now that it is stopped, you should be fine. So don't stop the medicine. Continue 2 milligrams and no need to skip today. There is no problem with mangoes, but people who usually have mangoes have lesser vegetables and salad. So this was a big study that was done in Baroda by Tushar Toprani and Biren Bhatt. They mentioned, they found out that during the mango season, a person who has 2 mangoes every day, the INR goes up slightly high. Person who has 4 mangoes, it is higher. A person who has 10 mangoes, it's almost like directly proportional to the number of mangoes you take. So then the reply to that was that most of the people in Gujarat are vegetarians and they have a lot of vegetables, and vegetables are a good source of vitamin K. So when you have mangoes, you have lesser vegetables because the space of vegetables are taken up by the mangoes. So please don't compromise on the vegetable intake. So you can have as many mangoes as you want, but do not have lesser vegetables and salads as you were having before. So that was a very interesting episode. So patient factors are very important to identify abnormal bleeding. So my final statement is hemostasis equals love. Everyone talks about it, but nobody understands it. Thank you very much.
Sir, excellent session. I don't have any words to describe the way you have told us how to approach a case of bleeding. And you have started right from the basics and you have gone to the most difficult and most interesting cases. Excellent. And I think it's an eye-opener for all the PGs and for the others who are consultants who are listening also. Sir, we have a few questions. One is, why in hemophilia the extrinsic pathway doesn't compensate to prevent bleeding? That is one of the questions.
Okay. What was the question, ma'am? Can you say that again?
Why in hemophilia the extrinsic pathway doesn't compensate to prevent bleeding?
Oh, that's because of tissue factor pathway inhibitor, as I explained. In fact, it's very interesting that you asked the question. Yeah, because it's very interesting that you asked a question. Nowadays, people are trying to see how you can use the extrinsic pathway to stop bleeding in hemophilia. One is Novo-7, which is almost 100,000 times dose of activated factor 7. Which produces a lot more of, so it overcomes the existing TFPI in the patient. The other one is trying to block TFPI by producing an antibody which actually blocks TFPI, allowing more thrombin to be generated by the extrinsic pathway.
Okay. And what is a good correction in a mixing studies? Is there a cutoff?
Yeah, so thing is, there are a lot of indexes which describe that, but for me, a good correction in a patient who is being tested for surgery will be a complete correction it should come within the reference range of the APTT. But a patient who is in the hospital, bleeding, surgery, there are a lot of other confounding factors which can interfere. So anything which will be coming closer to the reference range for me is a good correction.
Thank you, sir. And one final question. Why factor 12 deficiency doesn't cause bleeding, but deficiency of factor 11 causes mild bleeding?
Yeah, so that was explained by the new pathway of
Yes.
Why factor
Okay.
is not
Yes.
split?
Yeah. These were the questions which came up in the chat box from the audience. And if there are no more questions, so thank you very much once again.
Welcome.
And the story about the mangoes was really interesting, and it was an eye opener too. And there is a question about in dengue fever, the hematocrit is more and platelets are low. So
Yes.
can you, because you were talking about hematocrit and the platelets getting adhered. So is there any explanation for this?
Yeah, so thing is, when the thrombocytopenia happens in dengue, the bleeding that is resultant from in dengue is not exactly because of low platelet count. There are other issues too that cause the bleeding. Because in dengue there is thrombocytopenia, but most of the platelets are large young platelets. They are hemostatically far more competent, and of course hematocrit will definitely help, but that's mainly because of the dehydration. But the fact is that because there is bleeding, people may have a tendency to transfuse platelets. Sometimes, what happens is transfusing platelets alone in patients with dengue can actually worsen the clinical scenario, because these platelets will be recruited into the areas where end organ damage is happening, where the platelet microthrombi is being formed. So it can worsen the end organ damage. So please be careful when you're transfusing platelets in dengue. It may be a good idea to transfuse 2 FFPs along with the platelets to reduce the recruitment of platelets into platelet microthrombi.
Yes, sir. Thank you very much, sir. And I think now the treatment protocol for dengue also is changed, and no longer they rush into giving platelets. So thank you very much, sir.
Welcome.
Thank you, sir. It was a lively and wonderful session with all the case scenarios. One more question is there in the box. Second case, why did the patient bleed despite 21 units of cryo?
Can you say that question again?
In the second case, why did the patient bleed despite 21 units of cryo in the first place?
Oh yeah. So you must realize that the tone is not back, and the consumption is happening. So there is a lot of consumption that's happening. That's why frequent monitoring is required to find out whether the transfused products are stable or they are being consumed. So frequent monitoring is ideally good, so that we can decide how much more to give and when to give.
Okay. It was a wonderful session. It was an eye-opener for the clinical history, and though it is known to every one of us, but generally people don't give much of importance. You had that case-based thing was very good. Thank you, sir. We'll send the certificate to you by email. Thank you.
Thank you very much.
Can we have Dr. Febi or Sudha again?
Yes, Dr. Febi is ready, I suppose. So we move on to the next session. This will be by Dr. Febi. She is a well-known figure amongst the pathologists in the city. I don't think she needs a big introduction, but nevertheless, it's my duty to introduce her. She completed her MBBS from KMC Chennai, and I'm proud to say that she did her MD from my own alma mater, that is PGIBMS, and she's having a rich experience of over 3 decades working as a lab in charge and as blood bank medical officer, and currently she holds the position of Professor of Pathology in Ramachandra Medical College and Research Institution. And she has to her credit many publications, and she has also given a lot of invited lectures and oral presentations in both national and international conferences. Over to you, Dr. Febi.
Yeah, thank you, ma'am, for that wonderful introduction.
Ma'am, you have to start sharing your screen. Yeah, yes.
You have to minimize your PPT and go for
Yes.
it. Yeah.
Yes, madam. Yes, fine.
Good afternoon and a warm welcome to one and all who have joined this webinar as organizers, speakers and delegates. I've been sandwiched between two stalwarts, Dr. Anil and Dr. Sugesh. This is our Srihar campus where our management has provided all infrastructure to make this presentation possible. I thank the Tamil Nadu and Pondicherry chapter of IAPM and the TAPCON 20 organizing committee of the TAPCON 2020 and also Padmavati ma'am and Sudha ma'am for allowing me to share our experiences titled Case-Based Approach to Monoclonal Gammopathies. Under this heading, I like to do introduction, distribution of monoclonal gammopathy, diagnostic algorithm with case-based laboratory evaluation, and to summarize the presentation. What is monoclonal gammopathy? Presence of monoclonal protein in the serum or urine or both is called monoclonal gammopathy. Then what is this monoclonal protein? It is the presence of either immunoglobulins as a whole or components of immunoglobulins which can be detected by this M spike. So this is called M spike because this is of M stands for monoclonality and the sharp peak like church spire. So it is called spike. And the presence of this can be present either from alpha 2 region to the gamma region. This can spread out anywhere. And in the protein electrophoresis. This is albumin, alpha 1, alpha 2 globulin and beta 1 and beta 2 globulin. And this spike can occur anywhere from here to here. And this is an indication of an underlying plasma cell or B cell neoplasm, which is a disease of elderly with an incidence of 3.2% in individuals aged 50 and above. And this monoclonal gammopathy is a spectrum of diseases with the benign MGUS, monoclonal gammopathy of undetermined significance at one end, and multiple aggressive ones like multiple myeloma, Waldenström's and amyloidosis at the other end, and in between we have the smoldering type. This is a study done at Mayo Clinic for 55 years, and they have found this MGUS to be predominating in their study with more than 50% of their cases, and multiple myeloma 18% with amyloidosis 9%, and the rest of it forms about 25%. The same study, they found the IgG to be the commonest monoclonal protein, followed by IgM and IgA, then a very negligible fraction of IgD and IgE, with a reasonable proportion of light chains alone and biclonal expression also. But in SRMC, for this past 5 years, we have got about 128 cases. And our cases, among our cases, multiple myeloma was the predominating. That may be because of inadequate health checkup and asymptomatic people never coming for any routine health checkup, etc. And when do we detect monoclonal gammopathy? It's either during the evaluation of a clinical symptom or during an abnormal evaluation of an abnormal laboratory test. So what are the symptoms that we have to evaluate? Bone pain, skin lesion, or any lymph node involvement, or any recurring sinopulmonary infections. And sometimes our clinical colleagues find out osteoporosis disproportionate to the age of the persons, and bone lesions, neuropathy, restrictive cardiomyopathy, and Raynaud's phenomenon, which needs to be evaluated. And we in the laboratory, when we carefully look at the peripheral smear, we find Role and anemia, ESR, as well as proteinuria needs to be evaluated. Our biochemistry colleagues sometimes reports increased serum protein, deranged RFT, and hypercalcemia. So any one of this needs to be evaluated for the diagnosis of monoclonal gammopathy, and it should be a systematic approach. Why it should be a systematic approach? That is to prevent unnecessary testing and not to test those who need watching. Also, those who need aggressive treatment should be diagnosed so that they require the treatment at the proper time, and an algorithmic approach to be followed. See, this is the normal protein electrophoresis with albumin and the globulin area with, I told you, the components of it. And in this electrophoresis, there is some increase, but throughout the globulin and elevated plateau at the gamma globulin area. Whether this needs to be evaluated is a question. We are going to see about it. And this is the perfect M spike we have to evaluate further. So how does we evaluate? There is a diagnostic algorithm. Initially, we have to see whether there is a protein, M protein or not, by protein electrophoresis. And next, once the M protein is found or some abnormality in the electrophoresis, we have to type it whether it is non-IgM or IgM. That is by immunofixation electrophoresis. After typing it, that has to be quantified by nephelometry, how much of it is present. Again, in case the whole immunoglobulin is not present, we have to do a free light chain assay to find out whether only light chains are present. This should be followed by tissue diagnosis, and that is bone marrow biopsy or any other lymph node enlargement or extranodal site, etc., and to identify whether it is a lymphocytic proliferation or lymphoplasmacytic proliferation or plasma cell proliferation. Also, IHC, then cytogenetics, molecular diagnosis can be done in the tissue. And this is followed by the clinical correlation to be done, whether the patient is symptomatic or asymptomatic, so that all these diagnoses are to be made according to the criteria. So the criteria I'll be discussing with each cases. With this, we move on to the first case, dizziness in an elderly person. So he is a 70 years old gentleman. He had angioplasty 4 years back, and now coming to the hospital with giddiness for 2 days. He was hypotensive also, and clinically they investigated and found there was restrictive cardiomyopathy. So restrictive cardiomyopathy is it amyloidosis with a hypotension due to hypoalbuminemia and giddiness due to autonomic neuropathy, all fitting in. They thought of amyloidosis. But as soon as the patient enters the hospital, we do routine checkup. So in the routine, we could find in the peripheral smear staking of this RBC role, a very important finding. Then the ESR was elevated, and our biochemistry people released a report with high protein and little derangement in the AG ratio. But RFT, LFT, radiology, no contribution. So next, first step is finding out the M protein. This is the gel electrophoresis picture, and this is the source. From here it is moving, and this is the gamma region. There is a band, and then the densitometry tracing done shows a sharp M spike. So next step, we have to do immunofixation as well as the nephelometry. That found out IgG to be increased 3.1 grams, and the lambda chain was increased, but kappa was within normal range, and kappa lambda ratio was within normal range. Immunofixation electrophoresis says it is IgG lambda. So what is this? Next step, tissue diagnosis. So bone marrow aspiration, this shows this plasma cells, but this plasma cells were only 13%. Bone marrow biopsy, this is a cellular smear for a 72-year-old person with lot of plasma cells infiltrating the whole marrow and lot of droplets, intracellular as well as extracellular droplets are found. The marrow was congruent negative. So we did the IHC and CD138 and lambda were positive among the plasma cells as well as within the droplets. So can this be a multiple myeloma? 13% plasma cells, IHC, IgG, lambda restricted. Can this be myeloma? So we go, slim criteria needs 60% clonal. This is, we go by the International Myeloma Working Group criteria 2014. So 60% clonal plasma cells are needed. Also serum light chain ratio should be 100. No, this is not fitting in here. So can we jump to Crab criteria? The plasma cells are 13%, but all these were normal. So this is multiple, not multiple myeloma. Then what it is? We shift to the left, then the smoldering multiple myeloma or IgM, non-IgM MGUS. In non-IgM MGUS, the protein should be less than 3 grams, but our case 3.1, and the cells are less than 10%, 13% we had. And both of them should not have any end organ damage. So can it be smoldering? More than 3.1 gram, and bone marrow clonal plasma cells are 13%. So what is this? We signed it out as smoldering multiple myeloma. What is smoldering multiple myeloma? It is created for clinical purpose. This includes patients with pre-malignancy, as that is MGUS, as well as early asymptomatic malignancy and multiple myeloma. So at present, with our histopathology and laboratory methods, we cannot distinguish this patient where he is. He is more in the smoldering state. Whether he will be silent throughout or he will go into multiple myeloma, we cannot judge. We can distinguish benign and malignant, but not pre-malignant and early asymptomatic malignancy. So why should we distinguish this smoldering multiple myeloma from multiple myeloma? Because multiple myeloma needs aggressive treatment, whereas smoldering multiple myeloma needs just watching. So this, and why should we distinguish that from non-IgM MGUS? Because MGUS, the progression to the next state is 1% per year. But in smoldering multiple myeloma, it is 10% per year for the first initial 5 years, then 5% per year for the next 3 years, and 1 to 2% for the subsequent years. So this needs to be, these patients need to be closely monitored with investigations also. Whereas MGUS patients need to be evaluated or monitored, followed up with for 1 to 2 years only. What are the learning questions here? What is that restrictive cardiomyopathy due to? Can this be amyloidosis? We cannot say, as we have not done tissue diagnosis unless we prove it by tissue diagnosis. And what are the learning points from this history? Meticulous examination of the peripheral smear and the bone marrow cell count, 500 cells, and 3x people counting that will give a clear cut, because 10 is the cutoff, 60 is the cutoff. There are two things. So that is needed, and we should never forget our ESR. And criteria should be followed, not making the patient to get either aggressive treatment or just watching. We have to distinguish. This is a literature review which says that yes.
Madam, are you having any
Yeah,
problem?
yes, ma'am. 1 minute. No net. The literature review says a case of cardiac dysfunction associated with monoclonal gammopathy of youngers also. So we have got the case with cardiac dysfunction with SM. Moving on to the next case, mystery in upper GI bleed. This is a 60 years old gentleman. He is walking to the department of medical gastro with 1 day bleeding, 1 day hematemesis. He was tired since 1 month and more for the past 1 week. And as per the routine investigations, he was found grossly anemic and his platelets were pretty low. And the analyzer differential count showed some lymphocytes were some 74% and there were flaggings. So the technician subjected it for smear review. Some 43% of cells, what are they? As well as there is prolongation of prothrombin time and APTT also. So this 43% of cells were plasma cells. In the peripheral blood, we can see this role also. Then we have to see whether there is clonality, IgM, gel electrophoresis. This is the normal one control, and this is the patients. So here we see two bands at the beta-2 region and the gamma region, but both are merging. So here also we can see the densitometer tracing, both are merging. Next step is nephelometry and immunofixation, and free light chain. So see, by the time the biochemistry released the report with elevated creatinine and calcium, but to our surprise, the immunoglobulins were low. And free light chain assay showed enormously increased kappa light chain with the kappa lambda ratio being highly elevated, and urine Bence-Jones proteins were also present. The MRI shows a diffuse osteolytic lesion with diffuse involvement of the spine with osteolytic lesion and compression in L3. Bone marrow. Next is tissue diagnosis. Bone marrow shows plasma cells plus binucleated cells, trinucleated cells. And biopsy, 60 years old man. This is a highly cellular smear composed mainly of plasma cells. And CD138 fully positive with kappa restriction, lambda was negative. And by the time, because of that high elevated creatinine, renal biopsy was done. This is a slide scanned in our slide scanner Morphil, and this showed fractured cars. Why this fractured cars are being produced? The light chains are normally filtered by the glomeruli and reabsorbed in the proximal tubules. Overwhelming of this process results in CAS. IF was done for kappa. There was tubular deposition for kappa, lambda and IgG were negative. Same thing for the CAS. Kappa was positive, lambda and IgG both were negative. So can we diagnose this as plasma cell leukemia, kappa chain restricted with renal involvement? What is the criteria? 20% circulating plasma cells or 2 into 10 to the power of 9 per liter should be there, and 2 to 4% of plasma cell dyscrasias have this circulating plasma cells. And there are primary plasma cell leukemia and secondary plasma cell leukemia. And what is the immunophenotyping? Normal plasma cells lack CD56, and once there is multiple myeloma, it acquires CD56. This is a neural cell adhesion molecule found in the malignant plasma cells and is a hallmark of plasma cell leukemia and of a special subset of multiple myeloma. And these people are very slow to develop osteolytic lesion. Like in our patient, there is a diffuse infiltration, but the osteolytic lesion was only one. And once this subset becomes plasma cell leukemia, they lose this antigen. And CD28 is present in about about a reasonable proportion, about 30% of cases, and it is associated with translocation 14 and 16 or deletion 17p. I will discuss this later. And overexpression of PRAD-D1 and cyclin D1 is also seen in the plasma cell leukemia. They are more aggressive and they have complex karyotypes too. So why the myeloma kidney? And 16% of multiple myeloma is kappa light chain type. And when this is so, the risk of renal insufficiency is more. And we have to distinguish this from light chain deposition disease and AL amyloidosis. By urine examination, in AL amyloidosis, it's the albuminuria that predominates. But in myeloma kidney, we get the Vince-Jones protein, light chains. And histopathologic examination with Congo red, IHC, etc. and immunofluorescence can be done. Also, predominantly in myeloma kidney, the initial deposition is mainly in the tubules, whereas in other two, the deposition is mainly in the glomeruli. This patient has to be investigated for Fanconi syndrome also. Why should we do bone marrow in this case? We have seen circulating plasma cells more than 20% to find out whether it is primary or secondary. And sometimes we see circulating plasma cells in SMM also. And IHC for CD45, 56, 28, and CD117 can be done only if the tissue is available. Also the tumor burden. In our case, the whole marrow is filled with 138 kappa plus, 138 positive cells, and also for looking for amyloid. Why this patient was bleeding from the GIT? It can be due to gastric plasmacytoma, maybe amyloid infiltration of the gut wall, or the patient has only 43,000 platelets. So thrombocytopenia can be there. And this monoclonal protein have the tendency to interfere with platelet aggregation as well as with coagulation proteins. So maybe because of that or hyperviscosity. As we didn't do endoscopy, we are not able to tell what it is due to. Or simply it can be a preceding peptic ulcer as the patient thought. This is literature review says a gastrointestinal bleeding as initial manifestation in asymptomatic multiple myeloma in a middle-aged male. What are the learning points? Again, peripheral smear, very important. We have to distinguish that from plasmacytoid lymphocytes. Then Benston's protein, still it has got some value, and ESR, of course, and CD56 to be included in the myeloma workup because that is associated with prognosis. And CD28 is a future therapeutic target because the CD28 mediates regulation of the multiple myeloma cell proliferation and survival and is associated with prognosis. So also, so people who are interested in research can take up this topic as CD28 as a therapeutic target. And my case number 3 is rosy and red patches and blotches. A 50 years old female came to the OPD with complaints of a single swelling in the neck and headache for 2 weeks. And on examination, she was pale and a single cervical node, small lymph node which was firm was present. Also, the clinician noticed some purpuric patches as well as some ecchymotic patches on both upper and lower limbs. Routine blood investigations look like CML. See, lax WBC, then with low hemoglobin and platelets on the higher side. But when the scatter plot was looking normal, whereas the histogram was looking like this. So there is some interference like cold agglutinin or cryoglobulins. So what should we do? We have to before releasing the report, we have to ask the history of the patient. Also, we incubated the sample for 30 minutes at 37 degrees centigrade and then processed in the analyzer. The WBC count became in the lower limit of normal. RBC parameters were not changed, but the platelets came to normal. And see the histogram, second time, this is some interference is there still, but it is almost normal. So next step is M protein electrophoresis. From here, there is a huge band here at the gamma region and a perfect M spike. And the gamma globulin was elevated with AG ratio being deranged. Next step is immunofixation and nephelometry. This is not our picture because we outsourced for immunofixation. I couldn't get this patient's picture. This is from the internet. This is the protein electrophoresis, which shows gamma band M protein here. And this is just a routine protein electrophoresis. But what is this due to? The protein electrophoresis does not say what it is due to. So we have to do this immunofixation. Here IgG is no band, IgA no band, IgM shows a band, and kappa shows another band, and lambda no band. So it is IgM kappa light chain. So see here the nephelometry and free light chain assay were done. IgM was elevated and kappa light chain was elevated with elevation of kappa lambda light chain. Lymph node biopsy shows a diffuse proliferation of lymphocytes with some amount of plasma. So this was the lymph node of this patient only. And at higher power, small lymphocytes, plasmacytoid lymphocytes, and some plasma cells were also found. So can this be a lymphoplasmacytic lymphoma? We subjected the tissue for all eyelids. See, So CD45, CD45, CD20, MUM1, and PAX5 and CD79A. CD3 only in reactive lymphocytes. Other markers, negative markers were also there. I didn't put the picture. And CD138 was done positive, and kappa restriction was there, lambda negative. Ki67 labeling shows occasional positivity indicating a low profile or indolent lymphoma. So what is it? Lymphoplasmacytic lymphoma. Can we label? What is the criteria? WHO 2017 says neoplasm of small lymphocytes, plasmacytoid lymphocytes, and plasma cells. It can occur either in the lymph node or in the extranodal region with or without bone marrow involvement and leukemic phase. And monoclonal protein is often seen, but it is not the criteria required for diagnosis. And in LPL, the monoclonal protein can either be of autoimmune type or a cryoglobulinemic type. So in our patient, it is a cryoglobulinemic type causing spurious leukocytosis and thrombocytosis. And autoimmune in HCV induced LPL, associated LPL, there is a autoimmune type immunoglobulin, monoclonal protein is being produced. So that workup was done and found to be negative. Though it is an indolent lymphoma, this serum beta-2 microglobulin was little elevated, indicating that it may progress to some other form or aggressive nature. And 90% of this LPL has MYD88L265P mutation. Of course, it is not required for diagnosis, and absence of this mutation is a bad prognosis. And CXCR4 mutation is seen in 30%, which again indicates, positivity indicates a bad prognosis. This is a reference, and we have to rule out all small lymphocytic neoplasms like CLF, small lymphocytic lymphoma, Mantle cell lymphoma, all that before concluding and releasing the report as LPL. And what is LPL and Waldenström's? Monoclonal protein was present. So can this be a case of Waldenström's macroglobulinemia? Initially, people were thinking that both are synonymous. So WHO as well as the International Myeloma Working Group has come out with some criteria for Waldenström's macroglobulinemia to differentiate that as a subset of LPL. So it is not synonymous. So when this Waldenström's has got the urticaria, it is called Schneiderian syndrome. So when there is small patches or purpura, we have to distinguish whether that is really purpura or is it urticaria and that due to scratching cause some trauma. So what is the criteria? Here we have the in smoldering Waldenström's, anemia, constitutional symptoms, hyperviscosity, lymphadenopathy will not be there, but monoclonal protein should be above 3 gram and bone marrow lymphocytes will be, this is less than 10%. But in Waldenström's, the monoclonal protein is just present and the presence is enough, but the bone marrow cells should be 10% or more. And all these symptoms are present. So in our case, all these symptoms were present, but we have not done bone marrow. So we subjected the patient for bone marrow, and there were some lymphocytes were present in the here. Otherwise, it's a normal bone marrow biopsy. So IHC was done, and it was, to our surprise, it was all CD3 cells. And 20 were very few, not amounting to 10%. and few kappa cells were also present, and 138 was negative. So it is a pure LPL, not the subset Walden's terms. What are the learning points? CBC is very important, viewing the histogram and the scatter plot before releasing and subjecting the slide for smear review to rule out cold agglutinin and strict adherence to the criteria. And the fourth case is unexplained weight loss in a 50-year-old female with vomiting, loss of appetite for 1 month, and she lost 10 kgs in 4 months. She was a known hypertensive on medication for 4 years, and bilateral pitting pedal edema was present. Her proteinuria is more 4+, and Bernstein's protein absent. Albumin is little bit low, but 24 hours urine is very high, with protein creatinine ratio also very high. Monoclonal protein, no. There is some elevation of gamma protein, gamma globulin site, but it is not, it's maintaining the shape of the electrophoresis, but here we cannot see the plateau here, but the plateau is not making a spike, So can this be some monoclonality? Can this be an indicator of monoclonality? We have to investigate. The radiology was normal. Upper gastrointestinal endoscopy was done. There is superficial elevated region in the body and small ulcerative and friable lesion in the cardia. Bits from all these sites were taken, and they show some proteinaceous deposits in this. Proteinaceous deposits were seen. The mouse is not working. Not able to point, there is not working. So here you can see on the left side, there are some protein deposits. Also here, eosinophilic acellular material was found out. And at the cardia also, the eosinophilic acellular material, here we can see that, and under higher power that looked like that. So what is this? This is under polarized light with Congo red, apple green birefringent, but this looks like yellow green. And in the renal biopsy, we got small proteinaceous, small eosinophilic material. Under high power, there is a acellular material here. And tubules with all tubular droplets. So IF for lambda nodular infiltrates were present, and also in the vessels we can see the deposits. Kappa, C3, C1q, IgM, IgG, IgA all were negative. So criteria for systemic AL amyloidosis, presence of an amyloid related systemic syndrome. Here we have the renal involvement and the GIT involvement, Congo red positive, light chain positive, and we have to see evidence of monoclonal plasma cell proliferation, either in the serum or urine or by plasma cells in the bone marrow. So serum is a non-invasive technique, better preferred. So lambda elevated, ratio deranged. So it is a systemic AL amyloidosis with lambda light chain. Lambda light chain is more prone to develop this amyloidosis. And renal involvement is seen in 50 to 60% of the cases. GIT involvement 7 to 8%. And among the GIT involvement, 1% can occur in the stomach. This is a reference. And in AL amyloidosis, why M spike was absent? That is because it's a free light chain, and in trace amounts it may be present in the serum. Some amount is also excreted in the urine, so that can be absent. And limitations of urine BJP because there is enormous albuminuria that is present. So this test, there are technical shortfalls. And urine, serum, immunofixation, electrophoresis, and free light chain assay, all has to be done. At least one will give a clue because of the trace amounts that are present and because of the renal clearance. What is the preferred test? The free light chain assay. Is bone marrow essential? Not in this case, because we have proved it by free light chain assay. And the last, I have covered the whole spectrum of monoclonal gammopathy, leaving this one. So for want of time, one slide. Solitary plasmacytoma occurring in a 43-year-old male as a right chest wall mass. What are this? These are all the plasma cells occurring in between the muscle tissue. Radiology was NAD. Once this was CD138 plus kappa plus, and bone marrow involvement was not there. So biopsy proven, and bone marrow should be negative for this, and normal MRI or radiology. So it is a solitary plasmacytoma. When there is minimal bone marrow involvement, we call it solitary plasmacytoma with minimal bone marrow involvement. And these are the two advanced techniques recently coming up. Matrix assisted laser desorption, ionization, mass spectroscopy. Depending on the biophysical properties of immunoglobulin, due to the unique amino acid sequences and the molecular mass, this will identify, isotype, and quantify the M protein. So we need not subject the serum for immunofixation, then nephelometry, free light chain assay, all that. So if we do this, this will do all the job at one shot. And applications of flow cytometry, it confirms plasma cell or plasmacytoid lymphocytes to assess the clonality, and these expressions, aberrant expressions, can be seen by flow cytometry. Also, it is more sensitive in assessing the response. Also for MRD, this is flow cytometry applications are now coming up in the past decade, and plasma cell DNA content can be assessed. It is a measure of ploidy and proliferation rate and very important for prognosis. And circulating plasma cells can also be assessed. But the limitation of it is the percentage of plasma cells we acquire in flow cytometry is less when compared to the bone marrow percentage, because lipid phase plasma cells are lost during processing for flow cytometry. To summarize, first initially we have to find the monoclonal protein by protein electrophoresis, identify and classify the isotype with immunofixation, nephelometry for quantification and monitoring, and then tissue diagnosis for plasma cell wise lymphoproliferative, and extent of marrow infiltration, immunohistochemistry, cytogenetics, and molecular studies can be done. Tumor burden can be assessed by radiology, metabolic activity by biochemistry analyzer, to correlate everything with the clinical scenario to arrive at a final diagnosis. And these are my references with, and also the articles which I have cited earlier. And I thank the patients, suffering patients, who are the living learning books for me, and also the interactions with clinicians. From them I have learned a lot, and also all the delegates who are here watching this, and my team, our team, and my postgraduates who have contributed their work for this presentation, and the postgraduates who have helped me to click the images. And finally, but not the least, the team, TAPCON 2020, hats off to you. Thank you.
Thank you so much, Dr. Febi. It was an excellent presentation, and there are no words to tell how you have really approached each and every case right from the basics, and you have emphasized the importance of simple tests like a peripheral smear, a urine examination before going on to the latest and high-tech investigations. And it was an eye opener, and I'm sure all the PGs would have really enjoyed this session. Thank you so much. And if
Thank you,
for
ma'am.
lack of time, I think we will.
Yeah, I will post.
We'll type out.
Yeah, so we will go to the next session, and if there are any questions, I think you can type it out in the chat box,
Yes,
and Madam will be ready to answer in the chat box. So thank you very much, Madam.
Yeah, thank you, ma'am.
once again.
Thank you, thank you,
Yeah.
thank you, ma'am.
Mindray certificate. Madam, you have to
Mindray,
stop
can you
share.
please show
Yeah,
the
Madam has to
certificate?
stop screen sharing. Madam,
Madam, you
Yeah,
have to
yeah, yeah.
stop.
yeah, later do.
Yes.
Yes. Mindray, yes.
Thank you, ma'am. We'll
Yeah,
post
thank
video
you,
on-
thank you, ma'am. Thank you, thank you. Thanks a lot.
We'll go on to Dr. Anil Hundu. Can we go on to this?
Yes.
Hopefully, we don't have any objections. We'll be having lunch little later, as per we are running late by 15 minutes, but I think it should be fine. So we welcome Dr. Anil Hundu, who is the Senior Director, Hospital Laboratory Services, Academics and Research, Senior Consultant Hematologist from BL Kapoor Memorial Hospital, New Delhi. He's finished his fellowship hematological medicine, fellowship for flow cytometry from Australia. His areas of expertise being hematopathology, flow cytometry, hematologic disorders, coagulation, and cytomorphometry. Welcome you, sir, for this session. Thank you.
Thank you, everyone. And at the outset, I would like to thank the TAPCON 2020 organizing committee, as well as Mindray, for giving me this opportunity to share my thoughts about cytomorphometry and platelet counting. I know I am the only hindrance between the lunch and the activity, but I would also request to people that in case they would like to have a lunch along with it, that would be wonderful. It's not nice not to have lunch and keep listening to something when you are, empty stomach. Anyway, so my talk is designed on cytomorphometry in platelet disorders. This is the place where I work. This is BLK Super Specialty Hospital, New Delhi. And I bring you warm regards from my department, that is the Department of Hematology, which works in this hospital. Now, without much ado, I would like to go ahead with a few questions. What I'm sure all of you would be facing these kind of questions and clinical scenarios in your daily practice. The first one, 7-year-old girl with petechiae, who visited otherwise asymptomatic, a 12-year-old boy with asymptomatic thrombocytopenia, tested somewhere else and came to our hospital. 24-year-old lady with low platelet count was having some menorrhagia symptoms. A 44-year-old man with a platelet count, which was given as 4+ on the analyzer and 3+ on the analyzer, and one didn't know what to go ahead and do with it. And a 65-year-old man with variable platelet counts, trying to go and reach any of these places just to get the right platelet counts. 60-year-old post-stem cell transplant, again, an unreliable count, and I'm sure all of you would be actually understanding what are the various kinds of scenarios in all of them. Just to give you an example, this is where the scenarios were. So you had the first case, which was an ITP, and the second case, which was a pseudothrombocytopenia, a third case, which was a systemic lupus erythematosus, a fourth case, which was essential thrombocythemia, the other case, which was myelodysplastic syndrome, and lastly, the case where the sample was being taken from the IV lines repeatedly, and that was giving you a wrong count, which was basically a pre-analytical error. So you can yourself imagine the kind of platelets which start getting problems, and you start getting issues with all of these cases. Just to understand how the platelets function in an individual, and I'm sure a lot of you would already know about it, but for the benefit of the postgraduates who will be participating in today's seminar, we all know that the platelet is manufactured within the bone marrow, And in the bone marrow, you have this largest cell, which is the megakaryocyte. And from the megakaryocyte, obviously, you have these larger pseudopodia-like stuff which comes out, and these are called your proplatelets. And the proplatelets eventually release these smaller particles in the sinusoids. And this is how the megakaryocyte generally gets, incorporated into the sinusoid. And from the sinusoid, from this megakaryocyte, these small little particles get into the sinusoid and get into the circulation. So this is how the platelets are generally seen over there. Now, why do we talk about platelets so much? Why are we so concerned about platelets? Is because a lot of people think just taking a transfusion would be like so simple, but I'm sure people who are actually with transfusion medicine and a lot of other people who have understood the implications of transfusion would understand and realize that there will be people who will have antibody development, which could be both HLA antibody as well as non-HLA antibody. You could also have platelet-specific antibodies. There could be transfusion-transmitted infections, which one could get, including bacterial infections, and of course the allergic reactions, which can happen to many individuals, in such cases. So, therefore, transfusion of platelets is best avoided. Now let's look at platelets in general. Platelet counting, if you look at the platelet disorders in general, you can primarily classify them between congenital and acquired. And within the congenital and acquired compartments, based on the numbers in the function, you can classify them as quantitative and qualitative. And within quantitative, they can be either reduced or increased. So that's how the ballpark differentiation of various platelet disorders can be done. If you look at the quantitative thrombocytopenia, quantitative defect, and that too a thrombocytopenia, it is primarily either decreased marrow production of the platelets, or you can have splenic sequestration where there is an increased destruction or accelerated destruction, which happens in, say, for instance, hemolytic uremic syndrome or some other viral infections like dengue, etc., or even bacterial infections. So I'm not sure how many of you would know this. The history of platelet counting dates back to early 1900s, and this is the man who actually gave us this information. If you look at this particular picture, the guy is an Italian pathologist. One second. Yeah. So his name is Aurelio Bizzero. He's an Italian pathologist, and he's the one who actually first described the platelets as distinct corpuscles and gave us the concept of counting the platelets, and also told us about the role in coagulation and thrombosis. Now, when we try to count the platelets, historically, the platelet counting falls into two major groups. If you call them, if we look at the groups, one is the direct method by hemocytometry, which is a lot of them, and then microscopy, and indirect methods wherein the platelets are counted in proportion to the red cells, and this can happen on a smear, and it can also happen in the analyzer, and we'll see it in my subsequent slides. Previously, when we would do platelet counting, there would be what we called semi-automated methods of counting, and it was like not really the true platelet counts, because they would always try to do platelet counts on a platelet-rich plasma, and obviously the reference ranges would be different. But if you look at the fully automated methods today, you just take the platelet sample and you just run it through the analyzer, and you are able to actually get the platelet counts at the drop of the hat. Now, till in fact 2001, and from 1998, the International Council for Standardization and Hematology gave platelet counting basis on a manual phase contrast microscopy, and this remained in picture for a very, very long time. However, it was soon realized that this has its own fallacies and therefore is not a reliable methodology of counting. And in 2001, the International Council for Standardization in Hematology has changed it from the manual counting on a Newbar's chamber to a flow cytometric platelet counting method using the RBC platelet ratio. And in this, two antibodies which are predominantly used are CD41 and 61 to identify the platelets in reference to the red blood cell counts. So this is from one of the articles that I have taken from Carol Briggs, where it's shown on a flow cytometric platform that you take the platelets are the ones which are showing either 61 or 41, and the RBCs which are either expressing glycophorin or 71A, or you're taking them on a forward scatter using the cell size, and basis that you're then counting the platelets vis-a-vis the RBCs. You are expected to avoid the platelet RBC coincidences, which can happen in flow cytometry, and then basis this, you give it basis on a formula. Now, when we look at platelet counting today, there are many automated platelet counting methodologies, which are based, a lot of them are based on impedance. Some of them are based on optical methodologies. Some of them are also based on impedance optical methodologies, and a lot of them talk about immunological methodologies as well. I will not get into details of all of them, but we need to remember that the counting platelets today is become much better than what we were, but the quest is still ongoing. Just to give you an idea about how the entire platelet concept counting in a hematology analysis comes about, it is important to realize that when the blood is aspirated into a hematology analyzer, it's actually divided into two major portions. One which goes into the RBC platelet channel and the other one which goes into the WBC channel. We'll not get into the WBC part of it, but let's remember that it goes into the RBC channel, and from the RBC channel, you are actually able to pick up your hemoglobin, you lyse the red cells, and then you start counting the platelets as well. And you are also able to take various other platelet parameters, which include the platelet pulses as well as the red pulses. And basis that, you're able to give your impedance-based counting. Of course, it's the same process which is then followed, and it's taken into what is called the optical or the fluorescence channel. And from there, you're getting other parameters as well. Now, why are we so much concerned about RBC and platelet count together is because if you remember, they are all coming together from the RBC and the platelet channel. And because they're coming together, they have a problem of affecting each other. The reason is that their counting is in the impedance channel is primarily based on the cell size. So it doesn't really know that it's a platelet or it's an RBC. It only arbitrarily distinguishes between them basis the size of the cell. Now, where is the problem? The problem is that when you have a platelet count, it is in thousands and lakhs, whereas the RBC count is in millions. It's equivalent to something like a bucket of water going into a sea versus a sea going into a bucket of water. So obviously, the RBC counts, when they are much higher and they are also smaller in size, like for instance, in fragmented RBCs or severely hypochromic microcytes, they are more likely to affect your platelet count than vice versa, because again, the counts are much lesser compared to the RBC count. And that's what is very, very important to be kept in mind when you're looking at hematology analyzers. So this is where the issue with the impedance platelet counting starts. You have the RBCs, which can interfere in the platelet, and the platelets, of course, can also interfere in the RBC area. So therefore, whenever you will have large platelets or platelet clumps, they will come into this area and give you problems while counting. And that's what the analyzer is able to pick them out as well. So to take care of this, you have what is called the optical or the fluorescence platelet counting, and we will see how all those parameters will give you some information subsequently as we go through the slides. Now, platelet counting, if we look at it, it's a man versus a machine kind of a concept, and I would really want to remove the term versus because it's man who's getting assisted by the machine. Sorry. So if you look at it, you have the impedance counting, which was based on these different analyzers. Of course, you also have optical methodologies. And now majority of the analyzers, including the analyzers from Mindray, include the impedance and the optics together. But for the morphologist and me and many others who might be attending this particular meeting, we would still prefer to use a peripheral smear on a microscope and give the platelet counting with a lot of issues which are there with counting on the peripheral smears. So now if we look at the platelet parameters which are coming out from various analyzers, they are very useful parameters which are coming from the analyzers, and these platelet parameters are actually extremely useful in differentiating various types of diseases. One of the very important parameters which a lot of us primarily ignore is the mean platelet volume. And if you look at various disease states where mean platelet volume is associated with various disease states, there are numerous publications to this effect. And if you see, it's the most common ones which are involved is the cardiac ailment as well as the neurological ailment. So whenever you have thrombosis or thrombotic episodes which are leading to, say, myocardial infarctions, anginas, as well as the ones which are affecting the brain, like the strokes, platelets do have a very important role. And for those of you who would have attended Dr. Nair's presentation, you would have realized platelet happens to be one of the most pivotal cells in the entire coagulation cascade. We also need to remember that mean platelet volume, the moment the mean platelet volume decreases, that also starts giving you some information with respect to the disease state that you might be dealing with. Of course, there is a plethora of investigations, which is a plethora of, sorry, not the investigations, but the publications which are there in literature, which talks about how the mean platelet volume is associated with various disease states. I will not really advocate that that's really true or not true, but what I would definitely say is that there are conditions where MPV becomes an important risk factor, and that includes the arterial thrombosis, the acute myocardial infarction, diabetics with all these high risk possibilities of having MI or arterial thrombosis, and of course the venous thromboembolism. Now, perhaps one of the most important and the most interesting examples where the mean platelet volume plays an extremely important role, and if we would not really have the analyzer in front of us to give us the mean platelet volume, it might be very difficult for us to actually calculate the mean platelet volume, which is so low. So you have this child which has got this eczematous rash, the rash on the back, as well as these small little tiny platelets which are there on the platelet, on the smear. And this is a typical case of what is called the Wiskott-Aldrich syndrome, or the WAS. And it is one of the indications where mean platelet volume plays an extremely important role for detection. So if you look at mean platelet volume in various other disease states, for example, one of the diseases which we grapple with almost every year is dengue. And there is this study which has come out from Tamil Nadu itself. I'm sorry, I don't remember the author here, but the mean platelet volume has been taken as one of the important parameters to determine how dengue would behave. So if you have a high mean platelet volume and it's stable platelet counts, it indicates recovery from the disease and no transfusions is required. Whereas if you have a high mean platelet volume and falling platelets, it indicates active disease, and therefore in such cases transfusions might be needed. Again, when you have a low mean platelet volume with a low platelet count, it also indicates hemorrhagic tendency and therefore a possible need for platelet transfusion. So when we look at this entire scenario, mean platelet volume has a very significant role to play, and one should keep that in mind. You would also need to remember that mean platelet volume has many influencing factors on itself. So it includes lots of genetic variations, age, of course, the gender also, race. All these have a very important role to play. But remember, it's also a very important inflammatory marker, and therefore many other parameters might affect it as well, and also the hormones, etc. The other interesting parameter which a lot of people talk about is the immature platelet fraction. And in fact, it had become such a big rage with many hospitals and many scientists and many pathologists, in fact, wanting to take the credit of discovering this new interesting parameter. Some of them did do that as well. However, I'm sure you've heard Dr. Nair in the morning also, but whenever you ask him about immature platelet fraction, the only answer you get is there is nothing immature about immature platelet fraction. And why does he say so is primarily for the simple fact, because it's absolutely elementary. If you see that your immature platelet will be actually proplatelets, and they will be platelets like the ones which you're seeing here, which are like more like pseudopods. However, what we are talking about in immature platelet fraction is a larger platelet, which actually is an relatively what is called a proplate, which is not really a proplatelet, the true immature platelet. Anyway, without getting into controversy of whether the immature platelet is immature or not really immature, what we need to remember is immature platelet fraction is here to stay, and it has got many utilities. Just to give you one of the examples, this is a blood donor from the East Indian origin. If you look at the impedance platelet count of this particular patient donor, the platelet count was low, and invariably such people would be dissuaded from donating, for the platelet harvesting. But in this particular case, when an optical platelet count was done, the platelet count was much higher at 162, and therefore was eligible to become a donor. I also like to show this picture in majority of my presentations whenever I talk about immature platelet fraction, for the simple fact that, this particular advertisement makes you remember so much about immature platelet fraction, because IPF, when you didn't have it, you were always envying the people who had it. And now, fortunately, we have it as well. So I think a lot of people do envy us. But immature platelet fraction is here to stay, and it helps you a lot in gives you a lot of information. So what is immature platelet fraction? It's nothing but a fraction of the platelets which is larger in size. So what you are doing is you are taking the size versus the fluorescence, and this particular portion of the platelets which is having a larger size and the larger fluorescence, more fluorescence or higher fluorescence, is the one which is taken as the fraction and is expressed as a percentage. So the higher the percentage of immature platelet fraction, the possibility of functionality of the marrow is obviously better. It is something what you do for a retic count. So if you look at immature platelet fraction, pathogenesis of low platelet count, high IPF always suggests an active bone marrow, whereas a low IPF will suggest a depressed bone marrow. In fact, in our center, because we do a large number of bone marrow transplants, we have also observed that IPF is one of the first indicators of bone marrow regeneration, something which has also been published by many other people in bone marrow transplantation fraternity across the globe. You need to develop your reference intervals for this. Obviously, there is a difference between various analyzers when you're looking at the IPF. The reference interval which we have derived at our place is 0.6 to 8%, and basis that we are able to take our calls. Now, let me give you an example of a very interesting and a landmark study, which was actually done by my colleague, Dr. Tina, and her colleagues at Hinduja Hospital in Mumbai, where they looked at dengue positive patients and looked at the IPF percentages, and eventually came out with a very beautiful paper, which got eventually published in the International Journal of Laboratory Hematology. All they did was they ensured that they did the platelet counts and the IPF within 6 hours of receiving the sample, because there are otherwise various variabilities which can come up in the IPF as well. This is what the publication was done in 2013, IPF as an indicator of platelet recovery in dengue. And just to give you an idea how it works, I'll just show you the slide from her presentation, wherein if you look at the platelet counts, which are in blue, as the platelet count keeps dropping, the IPF in the purple keeps increasing. And at certain point of time, the IPF starts becoming stable, and that's the point when the platelets start coming up. So basis this, it was a predictable variable or a predictable value basis which it was possible for us to determine when the platelets are going to be recovering. And therefore, if you look at this particular study, it was in fact a very interesting study, because it gave you a possibility of restricting transfusions in patients with dengue. In fact, for this purpose, it was recognized across the globe by 3 major societies and awarded as well. Now, they also came up with interesting information where they said that IPF is a potential tool for predicting platelet recovery in dengue patients. And they also gave a value of 10% as an indicator of platelet recovery in next 24 to 48 hours, which was eventually actually proved that it is not right. So all in all, what I would say is that the moment you're monitoring a patient of dengue with IPF, if your IPF values become stable for 2 consecutive values on 2 consecutive days, you need not transfuse the patient, and the patient is likely to recover in the next 24 to 48 hours. There is another parameter which is called platelet to large cell ratio. A lot of people don't even know about it, forget about using it, but this is a very interesting parameter. Again, the platelet to large cell ratio is the ratio of the platelets, is the amount of platelets which are seen at 20 femtoliters and beyond on the platelet distribution width. And this platelet to large cell ratio has been shown to be correlating very strongly with the coronary artery disease. And therefore, if PLCR values are taken and eventually looked at, you might be able to give this information to a lot of people as well. In fact, platelet to large cell ratio, IPF values, neutrophil to lymphocyte ratio, and a few other parameters on the CBC analyzers have already been proven very significantly to be useful, especially in today's day and age with the COVID-19 patients. There is also a very interesting index which is called the composite platelet index. It's a conceptual index which is derived by multiplying the platelet count with the mean platelet volume, and this has also been shown to be strongly associated with the coronary artery disease and the thrombotic episodes. We must remember that these various indices which are there, the mean platelet volume, the platelet distribution width in femtoliters, in percentages, platelet crit, equivalent of hematocrit, immature platelet fraction, and the platelet large cell ratio needs to have its own reference intervals. You need to set it up in your own laboratories, and then basis this, you are able to differentiate between various disease states. So my talk would never be complete if I do not talk about the congenital thrombocytopenias. Of course, the number of congenital thrombocytopenias which we deal in our laboratories in usual practice is pretty limited. However, people who are actually dealing with a pediatric kind of or a childcare kind of a hospital, they will be dealing with it much more often. We need to remember this congenital disorders were first discovered way back in 1735. And of course, the number of people who came into the picture and eventually gave us a lot of information, not only about their identification, but also about their therapy using thrombopoietin mimetics, has actually improved the lifestyle and the possible morbidity because of congenital thrombocytopenic disorders. You know, I would consider myself relatively lucky, because I had to just remember these few, the congenital syndromes, and amongst them also the ones which would actually come in my exams would primarily be either Bernard-Solier or Glanzmann's thrombasthenia. And then you would also need to know a little bit about Wiskott-Aldrich and one of these syndromes which are there, the TAR syndromes, etc. But just imagine the number of syndromes which have come up in last almost 10 to 15 years, and most of them have actually some associated abnormality, mutational abnormality along with it. And these are the ones which are actually becoming more and more difficult, first to identify and then to eventually even treat. So if you look at the evolving new inherited thrombocytopenias, this is where we were in 2000s when I had just just started my post-graduation, to a time where today, where the number of, congenital thrombocytopenic syndromes have increased markedly. Now, fortunately for us, a lot of these are actually dependent upon the platelet size parameters, and therefore, basis this, we are able to actually differentiate between various types of mutations if we are able to identify the various cell sizes. So if you look at the mean platelet volumes, mean platelet distribution, platelet to large cell ratios, and the platelet to small cell ratios, you are actually able to differentiate between most of these disorders and then do a specific mutation for them and get to know what you're dealing with. Just to give you an idea, if you look at the disorders vis-a-vis the mean platelet diameters, this is the MPD, is a mean platelet diameter here. So basis the mean platelet diameter and the platelet to large cell ratio, you're actually able to classify and subgroup all of these disorders, and that is how it is going to give you a much further information when you're trying to take it from a hematology analyzer. In addition to all this, we also need to understand that all of these parameters will need to have specific cutoffs. A lot of people have developed their own cutoffs for this, and we need to have this identified in our own centers. We are trying to do a study on this in our center as well, and hopefully, in due course of time, should be able to share the data with you all. So if I look at steps for interpreting the platelet portion of the complete blood counts today, we need to identify the total platelet count relative to the reference interval. We need to examine the mean platelet volume, the platelet distribution width. We should try and identify disease states based on the histogram. We can also have an algorithmic approach of identifying the platelet counts accurately, and then also examine IPF, correlate numerical parameters with the platelet morphology, and correlate with RBC and the WBC parameters in any patient for that matter, to know what we are dealing with. With that, I would like to thank you all for your kind attention. I hope you all will probably move into doing cytomorphometry of platelets far more aggressively on the analyzer than what we are doing so far. I'd be happy to answer any questions if there are. Thank you very much.
Thank you, sir. It was really an eye-opener session only. Many things which we learned, certain things we were able to learn from your session, and the importance of IPF and platelet morphometry in dengue and other cases. So it was really good one listening to you. Thank you very much.
Thank you.
If there are any questions, one second.
Well, I can just read one question which is here, which talks about does the anticoagulant affect the mean platelet volume or the IPF values?
Yes.
The answer to that is absolutely yes. Especially it is the time duration which is far more important. So if you're taking a platelet, if you're taking a sample which is in regular routine K2 or K3 EDTA, they are affected only after about 6 hours. This is the study which has been done by Dr. Tina et in Hinduja Hospital also. And we have also replicated the study in our center. There is also a study to this effect by Dr. Pradeep Suri from his center, which is all these studies are already published, where it has been mentioned. There is also another study from Bangalore I forget the name of the author, but it is from the lab of Dr. Prasad, Dr. Sujay Prasad, the Anand labs. So all these places, yes, everybody has proven beyond doubt that anticoagulants do have an effect. You are expected to take the sample only in EDTA and not in citrate or any other anticoagulants, because the IPF values from there as well as the MPV values are slightly different. If you want to follow those values, then you will have to set up your own reference intervals for all of that. And also the time duration is extremely important. So if you do not keep the time duration of 6 hours intact, then the reliability of these values will become questionable. There is another question which talks about, you've not mentioned platelet count on Newbar's chamber. Well, I did mention about it because that was the reference method by the ICSH in 1988. And from 1988 till 2001, it continued to remain as the reference method. However, from 2001 onwards, the reference method by ICSH now is a flow cytometry-based methodology, which is between the RBCs and the platelet increment ratios. That's what is taken into account. And however, I know it is practically not possible for everyone to do flow cytometry for platelet counting. So therefore, having that as a reference method is only for the fact that you will be able to get the best possible counting from the analyzer. The other aspect which I did not deliberately touch upon was the manual platelet count on a smear. The reason why I did not touch it was that I generally do not advocate using smear as the methodology of platelet counts, especially in low platelet counts, because we have not standardized. Most of the people have not standardized. In fact, when I did my post-graduation, The factor which I was told was 20,000. After my PG, when I did my residency, the factor came down to 15,000. And actually today I'm using a factor of 10,000. So you can imagine that the counting has changed from 20,000 to 10,000 in last 15 to 17 years in myself itself, So practically speaking, counting on a smear becomes very difficult because you have to have a very, very good smear, which is like an ideal smear. And then you should also be making sure that it's been prepared appropriately, stained appropriately. And once you've stained it appropriately and then looking at the microscope, you have to ensure that the field of vision is taken into account. Your field of vision might be smaller and the number of platelets might be lesser in that, and therefore the factor might be different. Whereas if a field of vision is larger, then you will have more number of platelets there and the factor might be smaller. So you have to analyze it in your own center. And once you've done that, you can adopt using manual technique on a smear for doing this counting.
The freshness of the sample affect MPV. That also is a question. Anticoagulant effect on MPV or IPF.
So as I mentioned, anticoagulant effect does happen on the MPV as well as on IPF. So if you want to use IPF and MPV, the best anticoagulant to be used is EDTA. And if you do not want to use EDTA and for whatever reasons you've had samples in other anticoagulants, you will have to validate in your center. What we have observed is that there are relatively higher values of MPV when you use heparin and citrate. So this is our study, which we have done in our center. There are other studies to this effect from other places as well globally, which are already published, giving you similar information.
Any algorithm to be followed?
Okay, so the ideal algorithm is still an enigma. Let's be very honest on that. But having said what I said, we need to remember that your analyzer has to be tweaked and customized in such a way that you have put in the rules in the analyzer for review very, very correctly and very, very perfectly. The best way to do that is tweak your rules appropriately vis-a-vis the values on the smear. Once you have done that, you then need to ensure that once you have taken a sample which has been run on the analyzer and it is being flagged by the analyzer, it automatically gets into running into an optical or the fluorescence mode. And post fluorescence mode, whatever counts are there, you will take them as gospel truth unless and until the analyzer itself again tells you that it is not sure of what it's done. Then in that case, there will be a slight review. As a practice in our laboratory, what we have done is whenever there is a first sample which is coming from a patient and there is no delta on that, we will review the smear, especially if the counts are low or counts are high. But if the counts are within the reference interval, we have the rule is that we let it go. But I must give a caveat here. You must keep one thing in mind. Many a times, these small little cell fragments can also interfere in the platelet counting, and you might get an absolutely normal platelet count. So there will be issues. Machine after all is a machine. It's the man who's the most important person behind the machine. You need to set up your algorithm. There are various algorithms available already in International Journal of Laboratory Hematology, which you can follow and validate in your center before you put them into your practice.
Dengue, which parameter is the most important one?
Between IPF and MPV. Okay, so if you look at IPF and MPV, it's a very interesting fight between the two parameters. The reason why I'm saying so is the analyzers which are giving you IPF, these analyzers at very low counts somehow are not able to give you the MPV. I don't know whether you people who are using this have observed this or not, but the fact is that at the very low counts, the MPV parameter somehow has been jeopardized in most of the analyzers who give you IPF. I don't know, maybe deliberately. But then considering IPF as a parameter, it's a very robust parameter, provided you use it within those first 6 hours. So if I have to choose between MPV and IPF, I would prefer an IPF in a setting of dengue. But then if I was looking at a disease like myeloproliferative disorder, or I was looking at a disease like Wiskott-Aldrich syndrome, then I would probably go ahead with an MPV, because IPF there will not have any significance at all. So it is disease specific. So if you look at it, my talk was also very clearly saying cytomorphometry in platelet disorders. The idea was that you have to take a parameter in consonance with the disease that you're trying to look for. Do not try to just generalize saying IPF is the best and MPV is the worst, or vice versa. Each of these parameters have a value in their respective states and respective disorders.
Thank you, sir. There are a few more questions I think you can answer in the chat box, because for want of time, we would wind up this. Thank you.
Thank you very much, ma'am. Thank you, everybody. Thank you. Bye-bye.
So, can we have the certificate, Shama? Yes. Thank you, sir. Thanks for
Thank you.
the
Thank
time
you very
and
much.
your knowledge.
Thank you very much.
Now we are running short of time only, so we will resume back at 2:15 instead of 2 o'clock for the next session. Please assemble around 2:15 for the next session. So we have three more lectures, and if time permits, one teaser session just for the postgraduate sake for 5 minutes. We will have a teaser session also. So be back by 2:15 for. Thank you.
இன்னும் பண்ண சொல்லான்னு நினைக்கிறேன். ஷேர் ஸ்கிரீன் வந்துச்சு.
அப்படியா? You have his number? Oh, but then I can't hear the voice of the speaker.
We are able to hear you.
கேக்குது
Okay, now, yeah, now I can hear. Okay.
ஓகேங்களா? ஓகேங்களா?
Okay. Can I have his number? Not essential. Okay, it's okay. Thanks.
அவங்கதான் இது பண்ணணும். நம்ம
இன்னும்
ஷேர்
கேக்குது.
இல்ல அது யாரும் பேசல யாரும் அப்படியே ஸ்டக்கா நிக்குது. அவங்க அந்த ஆளு அன்ஷேர் பண்ணுவோம் ஸ்கிரீன்.
இல்லங்க அவன் பேசிட்டு தானே இருக்கான்.
இல்ல பேசல. வேற யாரும் பேசலாம் கேக்குது.
Ma'am, are you facing a difficulty? Can I help you with something?
Yeah, hello.
Typing the message. I asked her to type a message.
Hello.
Please tell me, madam.
No. She's doing.
I can't hear the voice of the speaker now.
கேக்குதுங்க.
Type பண்ணிக்கோங்க.
Okay. You muted the speaker, no? From speaking.
இல்லடி நம்ம ஷேர் பண்ணலாமான்னு கேளு.
Can I start sharing now in session 2:30?
இல்ல.
Can you hear me now?
You can start.
Okay. I can start now.
Wait. Now you can start sharing if you want to.
Oh, is it my talk now?
எதுல இருந்து பண்ண முடியல? நான் இருங்க வருண் நம்பர் தரேன், you talk to him.
Hello.
Yes.
No, my talk is at 2:30 or is it now?
No. I am talking to Gunasundari also over the phone.
Next is Dr. Gunasundari, then Dr. Teleflow.
Okay.
I was talking to Gunasundari so long. Now I am talking to Dr. Teleflow.
Yeah. Okay, I can hear now. Yeah.
Your presentation, everything is visible. No issue.
Okay.
ஸ்டாப் ஷேரிங் பண்ணிட்டேன். இது எப்பவும் சொல்லி பண்ணணும்.
Varun, I will give Dr. Gunasundari's number. Just contact her, no?
Okay, madam, give me her number. I'll talk to you.
Yeah, I'll do that. Sent it. She is on Zoom platform, but she is unable to join.
Everyone, we will resume at 2:15. Till then, you might not hear any audio or video. Kindly be patient with us. We will join back at 2:15.
Madam, hi sir, message அனுப்பிச்சுட்ருக்கேன் madam.
Yeah, you're seen. Your video is there.
Yes, madam. Okay.
You're there, your video is there. If you want, you can try your screen share.
My PowerPoint.
If you want, you can try that.
Yes, madam. I have, madam.
You can remove your mask now if nobody is there around.
Yes, madam. Okay, madam.
If nobody is there around, if you feel secure, you can remove it.
Okay, madam. நம்மளுடைய PowerPoint open பண்ணி வச்சுக்கலாமா?
Yes. Voice, everything is clear, no issue. You are the department?
Yes, madam. I am in the department only, madam.
இப்பவே ஷேர் பண்றாங்க.
இல்ல.
Dr. Guru,
Yes, sir.
Your video was visible.
Yes, sir. Yes, I am able to visible, sir.
Yeah. So at 2:15 we will start.
Okay, sir. 2:15. 15 minutes. 15 minutes. ஐயோ. சரி உட்காருங்க. நீங்க அங்க உட்காருங்க.
அதுல நாங்க
யோகா ஸ்டார்டிங் வச்சுக்கிடுவோம்.
இங்க உட்கார்ந்திருக்கோம்.
அங்க இருங்க தினம் கூப்பிடுறோம். இல்ல நீங்க
சைஸ் பண்ணி நீங்க
சரிங்க.
Now you
Thanks everyone for being patient with us. We will resume in short while.
So Varun, you can switch off the PPT and go for Dr. Gunasundari's profile, please. Mr. Varun?
Yes, ma'am, I can hear you.
Yeah, yeah. Okay. Can you? It's almost 2:15.
All right.
Yeah, you can put the profile up, Dr. Gunasundari. Good afternoon, one and all. We welcome you back for the afternoon session, closing session today. So we have Dr. Gunasundari now. She's Associate Professor from Salem Mohan Kumar Mangalam Medical College. She's got 13 years of teaching experience in various medical colleges. She's a guide to MD pathology students. She's nodal officer for NHMT and prevention and control of hemoglobinopathy. And she's handled a project in screening of thalassemias and sickle cell anemias. And she has publications of 5 to her credit. And her field of interest being oncopathology and hematopathology. She has participated as a speaker in CMEs on hemoglobinopathy. And the topic was screening of hemoglobinopathy. She has received certificate of appreciation from the head of this institute twice in 2017 and 19. So we have Dr. Gunasundari, who is a young budding associate professor from Mohan Kumar Mangalam Medical College. So welcome you, Dr. Gunasundari.
Thank you, madam, for your nice introduction. Good afternoon, all. First and most, I like to thank organizing committee for this great opportunity, and also I express my special thanks to Padma madam, organizing secretary, and my professor Tejoli madam and friends, PG students for their help and support. The diagnosis of gestation plastic disorders are challenging one for pathologists. Here I am going to focus on updates and challenges include a distinction of molar, non-molar gestations, distinction of complete from partial mode, recognition of early complete mold and familiarity with extravillous trophoblastic tumors.
Screen sharing of your...
Yes, madam. Yes, madam.
Mr. Varun, you have to stop sharing.
Hello, ma'am.
You have to stop screen sharing. She has to start screen sharing.
Okay, sorry.
Yeah. Go to PowerPoint slideshow.
Yes, madam.
Yeah.
Yes, madam.
Everything is fine.
So I am going to discuss gestational trophoblastic disorders and the following headings. To start with definition, these are the heterogeneous group of disorders is due to abnormal placental development associated with proliferation and neoplastic transformation of trophoblastic cells. So this is the current WHO classification, divides into 3 categories: hydatidiform mold, trophoblastic tumors, and tumor-like conditions. And then hydatidiform mold is again divided into complete partial mold and invasive mold, and tumor-like conditions are exaggerated placental site reaction. Yes, madam. Exaggerated placental site reaction and placental site nodule. Trophoblastic tumors are gestational choriocarcinoma, placental site trophoblastic tumor PSTT, and epithelial trophoblastic tumor. So we'll start with the histology of trophoblast before going to case discussion. So what is trophoblast? These are the epithelial component of the placenta lining the villi. So this is the morphology of trophoblast. This is the villi lined by cytotrophoblast inner layer, and these cytotrophoblast fuse to form syncytial trophoblast at the surface of the villi. Again, these cytotrophoblast migrate. Yes, madam.
Yes, speak little slowly.
Okay, madam.
Yeah, no issues. We are getting messages from the participants. Okay.
Okay, madam. Okay.
Sorry for the interruption. Thank you.
Okay, madam. So these cytotrophoblast migrate, proliferate, and differentiate into intermediate trophoblasts at extravillous spaces. So this is the morphology of morphology of cytotrophoblast lining the villi. These are the mononuclear cells having vesicular nuclei scant clear to vacuolated cytoplasm. And these are the sensitive trophoblasts having abundant eosinophilic cytoplasm with the multinucleation with a dark pycnotic nuclei, and these sensitive trophoblasts have microvilli on their surface. And coming to morphology of intermediate trophoblasts, these secrete HPL, and again it differentiate into 3 subtypes according to anatomical set. They named as villus intermediate trophoblast at anchoring villi, implantation site IT at placental site, and chorionic IT at chorion leve. And the most distinctive properties of this intermediate trophoblast is CD146. So Malcolm, what is Malcolm? It's a melanoma cell adhesion molecule. It is a sensitive and specific marker for implantation IT, and also it is diffusely and strongly positive for HPL. And another important feature of this implantation IT is these cells secrete hyperglycosylated variant of beta HCG, and these cells invade the myometrium and endometrium, and their target is to invade the...
Dr. Gunasan, little bit slower.
Yes, madam. Okay, madam. And the main target... The main target is to invade the spiral arteries because of this hyperglycosylated variant of beta HCG. So this is the morphology of implantation IT. Look at the morphology. They appear large, pleomorphic, hyperchromatic and irregular nuclei. Most of the cells will be having abundant eosinophilic cytoplasm. Some cells have clear to vacuolated cytoplasm. Most of the cells are mononucleated except a few multinucleated cells. Again, we can be able to appreciate the infiltrating nature of the implantation IT cells. They diffusely infiltrate the myometrium, and this again picture showing vascular invasion by the implantation IT cells. So coming to this picture is comparing chorionic IT and implantation IT. Look at the morphology of chorionic IT. They are more or less uniform, having round nuclei, fine chromatin, abundant eosinophilic cytoplasm with well-defined cell borders. In comparison to implantation IT, they are large, pleomorphic, hyperchromatic, irregular nuclei, abundant eosinophilic cytoplasm, and well-defined cell borders. So coming to IHC of trophoblast, this is the new marker which is expressed exclusively in the trophoblast. It's very useful to distinguish trophoblastic lesions from non-trophoblastic lesions. So that is HSD3D1 is a new marker. Okay. Then coming to overall IHC of trophoblast, all cells are uniformly positive for cytokeratin, particularly low molecular weight cytokeratin, and each subtype has its specific marker. P63 63 is expressed by cytotrophoblast. Among all cytotrophoblasts, these cytotrophoblast has maximum proliferation capacity, which ranges from 25 to 50%. When it undergoes differentiation into sensitive trophoblast, it loses its proliferation capacity. So it becomes negative in sensitive trophoblast. And then coming to implantation IT, the specific markers for implantation IT are HPL and Malcolm. And here the proliferation index is 0. And the marker for chorionic IT is P63, which is and also EMA. EMA is specific for this chorionic IT, which is not expressed in other types. And the proliferation index ranges from 3 to 6%. So coming to pathogenesis, it remains poorly understood. It appears to be due to genomic imprinting. So it plays an important role in the pathogenesis of hierarchiform mold. So which is associated with the excess of paternal haploid set of chromosomes. Then coming to pathogenesis of gestational trophoblastic neoplasia, the stem cell, that is cytotrophoblast, undergoes neoplastic transformation into various subtypes which resemble stages of early placental development. And this is the stem cell cytotrophoblast which undergoes neoplastic transformation into choriocarcinoma, which is composed of all types of cytotrophoblast, all types of trophoblast, which resembles the pre-villus blastocyst. So this is the primitive one among all other tumors. On the other hand, these cytotrophoblast differentiate into implantation IT and transformation into PSTT. And again, on the other hand, these cytotrophoblast undergoes differentiation into implantation IT at the chorion level. It gives rise to ETT. So both these tumors are well differentiated one in contrast to choriocarcinoma. So coming to risk factors for malignant change, locally elevated beta HCG more than 1 lakh milli-units per ml, which is associated with malignant behavior, particularly choriocarcinoma. And these two disorders also have elevated HCG, but it is always less than 2,500. So coming to case discussion, case 1, 23 female, 13 weeks of gestation presenting with hypertension, vaginal bleeding and locally elevated HCG of 1 lakh international units per ml, and ultrasonogram shows complex mass with many small cysts in the uterus. And this is the gross picture showing great clusters of the villi. Here almost all villi appears abnormal and edematous, no fetal pot is seen here. And this picture showing edematous large villi with round borders with the central system. And this picture showing abnormal villi with circumferential proliferation of the trophoblast with atypia. This picture showing striking cytological atypia with the sensitive trophoblast, cytotrophoblast and intermediate trophoblast with abundant eosinophilic cytoplasm. So with this clinical diagnosis is suggestive of molar pregnancy. The clinical presentation of hypertension, that is PAH in first trimester itself indicates molar gestation, in contrast to its presentation in last trimester of normal pregnancy. The locally elevated HCG, even after 10 weeks instead of normal drop, you should consider the diagnosis of molar disorder in such conditions. Because the normal beta HCG, its secretion starts on 12th day and it reaches its maximum around 10 weeks. Afterwards, it drops. Okay. So associated with these clinical findings, abnormal villi and cytological atypia, so what could be the diagnosis? So the diagnosis is complete mole. So the complete mole is due to androgenic. All chromosomes derived from the sperm. Here the maternal chromosome is getting inactivated, is getting imprinted. This also all villi transform into grape-like vesicles filled with fluid. So again, this picture showing all villi appears abnormal and abnormal villi with round borders showing circumferential proliferation of trophoblast with atypia. Again showing cytological atypia composed of the sensitive trophoblast with multinucleation, cytotrophoblast and intermediate trophoblast with abundant eosinophilic cytoplasm. This picture again showing cytological atypia. So that's all about complete mole. Then histopathological diagnosis of molar pregnancy remains problematic, especially in early gestational age, because complete mole and partial mole are similar in morphology. They may have morphological overlap with each other because of underdeveloped villi. Villi may be absent, villi may not be evident, and trophoblastic proliferation is also mild and focal. But recognition of this early complete mole is very important because it is associated with a higher incidence of persistent GTD and choriocarcinoma.
Little slowly.
Okay, madam. P57 is very helpful in such conditions. So, what is the early complete mole? In which the typical morphological features of complete mole is absent before 12 weeks. So, villi may not be evident both gross and microscopy, but always trophoblastic proliferation will be seen, but it is mild and focal. So, we have to recognize the early complete mole. There are certain features which will which is helpful in diagnosis of this early complete mole is polypodal bulbous terminal villi with stromal changes like hypercellularity, myxoid change, stromal karyorrhexis, and apoptosis. Again, P57 is very helpful. So, what is P57? It's a cyclin digmertan kinase inhibitor. It is expressed only by the maternal navi and it is a strongly paternally imprinted gene. It is useful to identify complete mole by lack of its expression. Okay. So, this is the picture of early complete mole showing bulbous projection of the villi with stromal changes like increased cellularity, myxoid stroma, karyorrhexis, and apoptosis with the circumferential proliferation of trophoblast with atypia. Again, this picture showing bulbous projection of the villi with hypercellularity and circumferential proliferation of the trophoblast. So, coming to DD for complete mole. So, this picture for comparison of normal villi and gestational molar disorder. Look at here. All villi appears normal. Here there is no trophoblastic proliferation and atypia. And this picture showing small normal villi and large abdominal villi biphasic population with focal trophoblastic proliferation. Okay. This picture again the DD is partial mole. How to differentiate? This picture having my biphasic population of small and large villi. Again, this picture showing villi with this irregular and scalloping borders, which is characteristic of partial mole, and again it shows trophoblastic proliferation focal only. Again, this picture showing irregular and scalloping of villi with trophoblastic invagination. That trophoblastic inclusion into the stroma is characteristic of partial mole in contrast to complete mole. Complete mole have round villi. So again, this picture for comparison of complete and partial mole. Here all villi appears abnormal. There is no fetal part. Here fetal part with placenta having normal and abnormal villi. Here this complete mole shows abnormal villi with round borders, circumferential proliferation with atypia. In contrast to partial mole with irregular and scalloping of the villi with focal trophoblastic proliferation. So there are other disorders also have abnormal illness morphology. They are hydropic abortus and early non-molar pregnancy. But this hydropic abortus is in this condition there is no trophoblastic proliferation, and it is often associated with early demise of the embryo. But this early non-molar pregnancy is characterized by polar distribution of the trophoblast with no atypia and cystole in contrast to complete mole. So this picture showing polar distribution of the trophoblast in contrast to complete mole. This is a case of early non-molar pregnancy. And this picture shows hydropic abortus with large edematous villi with increased vascularity. And here there is no trophoblastic proliferation and atypia in contrast to complete mole. So these disorders also having abnormal trophoblastic proliferation with atypia. We have to differentiate from complete mole because the prognosis and course of the disease varies. So sometimes complete mole also have extensive proliferation with marked cytological atypia mimicking choriocarcinoma. So how to differentiate it? You have to take thorough sampling. You have to take extensive sampling to look for the areas of necrosis, hemorrhage and invasion, which is characteristic of choriocarcinoma, but it is lacking in complete mole. And these two disorders also show atypical proliferation, but they are characterized by proliferation of intermediate trophoblast rather than syncytial and cytotrophoblast. Then coming to IHC of molar gestation, P57 is particularly very useful to differentiate complete from partial mole. This P57 is a maternally derived one, which is negative in this complete paternal origin. Whereas in partial mole, it is diffusely positive.
Dr. Gunaswati, they want you to be very slow.
Yes, madam. Okay.
So even if one case is missed, it's okay. Whatever you are conveying, they want you to be very slow. Okay. Thank you. Sorry that I'm interrupting. It's from the participants. Okay.
Okay, madam. Okay, madam. So that's all about molar gestation. Then coming to case 2, 28 years female with abnormal vaginal bleeding had previous history of missed abortion 2 years back, and her beta HCG is normal, for which endometrial pherotox was done. Okay. This picture showing endometrium with a circumscribed nodule in which the tumor cells are embedded in a eosinophilic hyaline matrix. So again, we can able to appreciate extensive hyaline matrix, and this picture showing extensive hyaline matrix with the tumor cells surrounding the matrix. So look at the morphology of the tumor cells. They appear uniform, having round nuclei, fine chromatin, abundant eosinophilic cytoplasm, and well-defined cell borders. So this cell morphology is resembling chorionic IT morphology. So with this normal history of normal serum HCG, circumscription, chorionic IT features, gland cytology, lack of necrosis and atypia, it is considered as benign trophoblastic tumor of chorionic IT origin. So what could be the diagnosis? So the diagnosis is placental site nodules. What is placental site nodule? It is an uninvoluted placental site from the remote gestation in the uterus. Most of the time it is seen as an incidental finding in the uterine or endocervical keratins. The size ranges from 1 to 14 millimeter. They are macroscopic in size. And they are characterized by well circumscribed nodular aggregates of chorionic IT in a hyalinized stoma. Again, these pictures shows well circumscribed nodule composed of eosinophilic matrix within the center, surrounded by tumor cells at the periphery. Again, look at the morphology. They are small cells having abundant eosinophilic cytoplasm and well-defined cell borders, resembling chorionic IT morphology. Pleomorphism is very mild only. So mitotic figures are absent or rare, and proliferation index in this case will be low, less than 8%. And the cause of the PSM is because of its microscopic in size, circumscription, it is completely removed by the curettage. So after curettage, there is no chance for recurrence and progression, and no specific treatment and follow-up is needed. So DD for this tumor is the other tumor with the same origin from chorionic IT. So what is the DD and how to differentiate from each other? Let us see later. Then coming to case 3, 53-year-old woman.
More slowly, Dr. Guna.
Sorry, madam.
No, not to feel sorry. I think you want to finish. Don't.
Yes,
if the
madam.
5 minutes are delayed, it's okay, but do it very slowly so that people are able to follow.
Okay, madam.
Sorry that I'm interrupting again and again. It's from the audience I'm telling.
Okay, madam. So 53-year-old woman with a gestational event 25 years prior, abnormal vaginal bleeding and her beta HCG is 1900. So her beta HCG is less than 2500. And this 25 years prior is a long-term history indicates it's a slow-growing tumor. So this picture showing large hemorrhagic circumscribed nodules in the endocervix. Okay? And this morphology showing cords and nest and solid masses of tumor cells surrounded by geographic necrosis with extensive calcification. This picture showing necrosis, look at the morphology. They are small round cells with abundant eosinophilic cytoplasm and having well-defined cell borders, and the pleomorphism is small to moderate. Here we can able to appreciate the cytological atypia. So most of the cells will be having abundant eosinophilic cytoplasm. Again, we can able to see solid masses of tumor cells with eosinophilic dense bodies resembling keratin. So with this picture of slightly elevated beta HCG, but it is less than 2500, chorionic IT morphology to moderate nuclear atypia, necrosis, geographic necrosis and calcification, neoplastic trophoblastic tumor from chorionic IT is considered. So what could be the diagnosis? So it is a case of epithelial trophoblastic tumor. It is a new entity. It is extremely rare, which is distinct from other trophoblastic disorders by resembling carcinoma because of its epithelial appearance. So the one characteristic point for this epithelial trophoblastic tumor is it have a tendency to grow in lower uterine segment and cervix, replacing the endocervical epithelium, mimicking dysplasia and squamous cell carcinoma. So gross appearance, solid, discrete, well circumscribed nodule with areas of hemorrhage and necrosis. Again, this picture showing nest and cords, the solid masses of tumor cells with areas of necrosis. Look at the morphology. The tumor cells are small round cells with abundant eosinophilic cytoplasm, and this picture shows tumor cells will be seen surrounding the blood vessels, but here there is no invasion. Again, this picture showing permanent cellular necrosis within the nest of the tumor cells. Okay? Again, this picture showing solid masses of trophoblastic cells embedded in a hyaline matrix. So this hyaline matrix is very characteristic of this tumor. Again, this picture showing eosinophilic dense bodies resembling keratin, giving rise to a DD of squamous cell carcinoma. So how to differentiate these two conditions? Both have similar origin, same cell of origin, chorionic origin, both have same morphology and same hydroxy, except a few points. So how to differentiate from each other? So these PSN is a physiological process which is microscopic in size, is characterized by extensive hyalinization with less cellular fate. So lack of necrosis, lack of hemorrhage, lack of mitotic activity, all will be in favor of placental site nodule. Whereas this ETT have large polypoidal mass with infiltrative margins. The areas of necrosis, look at the pleomorphism. Pleomorphism is mild to moderate. So all these features, it is suggestive of malignant trophoblastic tumor, and the proliferation index is more than 10% in this case, whereas it is always less than 8%. And the one marker which is useful to differentiate this PSN from this malignant tumor is cyclin E. Cyclin E is positive in this ETT, whereas it is negative in PSN. The coming to DD, because of its epithelial appearance, it resembles epithelial smooth muscle tumor, but the trophoblastic markers cytokeratin 18 and inhibin will be negative in this tumor. Okay? And another TD is muscle carcinoma of the cervix, because of its tendency to grow in endocervix, the presence of eosinophilic dense material resembling keratin, all give rise to a DD of muscle carcinoma. But the marker P16 is positive in muscle carcinoma of the cervix, which is a human papilloma virus marker, and the proliferation index is also more than 50% in case of muscle carcinoma, but it is less in case of this trophoblastic tumor. So that's all about the chorionic lesion. Then coming to case 4, 23 years female, 10 weeks gestation, presenting with vaginal bleeding, for which endometrial curettage was done. So we can able to appreciate the diffuse infiltration of the myometrium by the tumor cells. Look at the morphology of the tumor cells. They appear large, pleomorphic, hyperchromatic, irregular, having abundant eosinophilic cytoplasm and well-defined cell borders. So again, we can see the diffuse infiltration of the myometrium by the tumor cells. The pleomorphism is marked 1. Most of the cells are mononucleate except few multinucleated cells, and each cell is having abundant eosinophilic cytoplasm with well-defined cell borders. And this picture showing infiltration of the myometrium by the tumor cells, they split the muscle bundles. They are separating the muscle bundles, which is very characteristic of implantation site. So with this diffuse infiltrated growth pattern of myometrium, splitting and separating of the muscle bundles, tumor cells resembling implantation site IT, lack of necrosis hemorrhage and lack of mitotic activity, all in favor of benign trophoblastic tumor of implantation site IT. So what is the diagnosis? So it is a case of exaggerated implantation site. What is it? It indicates increase in the amount of placental site. It is characterized by extensive exuberant infiltration of the endometrium and myometrium by the IT. So despite its diffuse infiltration, there is no necrosis and mitosis. Chorionic villi are morphologically unremarkable. So coming to the cause of the disease, it's a physiological process. It indicates normal variation of the implantation site. It resolves spontaneously. And coming to DD, because of the pleomorphism of the tumor cells, myometrial and vascular invasion, it is confused with neoplastic conditions with the same cell of origin with the same similar morphology. That is PSTT. So how to differentiate these two disorders? Let us see later. Then coming to case 5, 30 female with missed abortion had history of proteinuria and the proliferation index is 10%. Hysterectomy specimen shows large polypoidal mass protruding into the endometrial cavity with infiltrating margins. This microscopy shows diffuse infiltration of the myometrium by the tumor cells having large pleomorphic hyperchromatic irregular nuclei with abundant eosinophilic cytoplasm. These cells are infiltrating the myometrium by splitting the muscle bundles. It is very characteristic of implantation site IT. Again, we can able to appreciate the pleomorphism of the tumor cells with atypical mitotic activities. This picture showing vascular invasion. These tumor cells are trying to invade the vessel from periphery to the lumen, replaces the vessel wall with eosinophilic necrotic material. So with this history of missed abortion, proliferation index of more than 10%, large polypoidal mass, infiltrated growth by the pleomorphic cells, vascular invasion, and focal necrosis, absence of villi. With this, we can suspect neoplastic trophoblastic tumor with implantation site IT morphology. So what is the diagnosis? So this history of proteinuria indicates nephrotic syndrome is the one clue for diagnosis of this disorder. So what is the diagnosis? Okay. So it is a case of PSTT. It is due to dysregulation of the extravillous intermediate trophoblast. It is evidenced by invasion of the endometrium and myometrium by the implantation site morphology. Okay. It is a benign one, but it is locally invasive, locally aggressive one because of its diffuse infiltrating nature. Despite its diffuse infiltration, these tumors undergo spontaneous suppression. Sometimes these tumors may deeply invade the uterine wall and results in perforation. So always consider this PSTT as a malignant tumor. And the most common presentation is missed abortion. So it is the only trophoblastic tumor which is associated with nephrotic syndrome in contrast to other tumors. And this gross appearance shows large polypoidal mass and protruding into the uterine cavity with infiltrating margins. So with this microscopy shows confluent modes of implantation IT with diffuse infiltration of endometrium and myometrium with vascular invasion, and hemorrhage and necrosis is focal only. Not more than focal necrosis is allowed. If it is extensive, think of malignant behavior. And villi is characteristically absent. The characteristic features of this PSTT are fibrinoid deposits and fibrin necrosis of episodes. And this picture showing vascular invasion, this tumor cell is trying to invade the vessel and which is replacing the vessel wall with eosinophilic necrotic material. And this picture showing fibrinoid necrosis of the vessel wall. So these are the characteristic features of PSTT. So how to differentiate these two tumors? Because both tumors are having same cell origin, same morphology, except a few points. This exaggerated placental site is a physiological one, which is microscopic in size with preservation of uterine architecture, lack of necrosis and mitotic activity, and proliferation index is 0, and it is characterized by presence of chorionic villi. And this PSTT is characterized by large polypoidal mass with infiltrating margins, confluences of trophoblast cells with local destruction, focal necrosis, and absence of villi. And Ki-67 is more than 5%. This is very most important to differentiate this physiological process from this PSTT. It is always more than 5%. So coming to IHC of implantation site IT lesions, the specific and sensitive marker for this implantation IT is MELCAM, that is myeloma cell adhesion molecule. CD146 is positive in both conditions, but in the proliferation index is more than 5%. So the diagnosis of PSTT should be considered if it exceeds 5%. So coming to DD, choriocarcinoma comes under DD because of areas of necrosis and infiltrated growth pattern, but it is characterized by three populations: elevated HCG and diffuse and strong positivity for HCG in contrast to PSTT. And we have to think of malignant behavior in PSTT if we have extensive areas of necrosis, more number of cells with clear cytoplasm, and high mitotic activity. So that's all about implantation IT.
5 more minutes. How many?
Okay, madam. Case number 6. 40 female with irregular bleeding and discharge of bloody brown fluid with the previous history of molar pregnancy, long-term use of OCP, and her beta HCG is markedly elevated. With this, the clinical features are suggestive of malignant trophoblastic tumor. All these are associated with malignant change. So this picture showing large polypoidal circumscribed modes with pushing margins having variegated appearance. This picture shows diffuse infiltration of the myometrium by the trophoblastic cells. Here we can able to appreciate syncytial trophoblast, cytotrophoblast, and intermediate trophoblast. This picture showing striking cytolytical atypia with alternating layers of cytotrophoblast, syncytial trophoblast, and implantation IT with abundant eosinophilic cytoplasm. So with this history, these features of this is in favor of malignant trophoblastic picture. So what is the diagnosis? The diagnosis is choriocarcinoma. It arises from trophoblast of primitive blastocyst composed of 3 populations without villi. It resembles primitive trophoblast. And this picture is showing comparison of primary choriocarcinoma in the uterus and the secondary deposits in the liver. This is solitary nodule, and this is multiple circumscribed hemorrhagic nodules in the liver. This picture showing trimorphic population with a syncytial trophoblast. And this picture showing central areas of necrosis and hemorrhage, which indicates rapid growth of the tumor. So coming to DD for choriocarcinoma, previllous trophoblast, which resembles choriocarcinoma by having 3 populations, we have to differentiate. And complete modes also have extensive areas of trophoblastic proliferation with marker cytological atypia. So how to differentiate? So this picture showing previllous trophoblast, blastocyst surrounded by the trophoblastic cells, but the pleomorphism is only mild, lack of necrosis, mitotic activity, and lack of invasion in contrast to choriocarcinoma. And again, another DD is PSTT because of the diffuse infiltration of the nature. PSTT comes under DD, but it is characterized by lack of trimorphic population. And if you see this picture with the splitting of muscle bundle, think of PSTT. And another DD is CTT. Because of necrosis comes under DD, but it is characterized by geographic necrosis with extensive calcification, but it is having monomorphic population of chorionic IT morphology. And sometimes, in some cases of choriocarcinoma, sensitive trophoblast is indistinct, attenuated. It resembles poorly differentiated carcinoma. So we need extensive sampling, thorough sampling to look for numerous sensitive trophoblasts, and also we need to do assay to differentiate from poorly differentiated carcinoma. So coming to IHC approach to gestation trophoblastic tumors, if you are suspecting trophoblastic lesion, so do with these trophoblastic markers. If they are diffusely and strongly positive, it is confirmed as trophoblastic lesion. Again, you have to separate into whether it is implantation site lesion or chorionic IT lesion. So we have to do with P63 and HPL. If HPL is strongly and diffusely positive, think of implantation site IT lesion. Again, we have to differentiate from benign and malignant by doing proliferation index study. If the proliferation index study is negative or it is less than 1%, think of benign, whereas it is more than 10% in case of malignant tumors. And after confirmation of trophoblastic lesions, if P63 is diffusely and strongly positive, think of chorionic IT lesion. Again, we have to separate benign from malignant by doing proliferation index study. If it is less than 8%, think of benign, and if it is more than 12%, think of VTT. The one marker which is useful to differentiate benign from malignant is cyclin E, which is positive in malignant tumor and which is negative in PSN. Now it is a time for cognizance. So the typical IHC profile of placental site nodule is, so placental site nodule is composed of chorionic IT. So the marker for chorionic IT is P63. And cyclin E is negative in this case of placental site nodule. So the answer is D. The second question is, exaggerated placental site is characterized by absence of villi? No. Presence of necrosis mitosis? No. It is a benign process. And proliferation of chorionic IT with invasion? No. It is okay. The next one is proliferation of implantation site IT with invasion of myometrium and blue. The answer is D. Then coming to third question, characteristic histological features helpful in differentiating PSTT from other neoplasms are ability to replace and replace the endocervical endometrial surface epithelium. No, this is characteristic of VTT. Invasion and replacement of the myometrial vessel wall. So this is the answer. Presence of distinct neoplastic components with triphasic population. It's case of choriocarcinoma. Presence of extensive geographic necrosis and expression of P63 is characteristic of ETT. So the answer is B. So coming to conclusion, trophoblast in complete mole always has cytological atypia. The diagnosis of complete mole, heredity for mole is problematic in early gestation. So we have to use P57 for diagnosis. So if you have, if you see any abnormal villi, it should be assessed by P57. The concurrent use of serum and urine testing for beta HCG is recommended as a routine policy nowadays in follow-up of gestation trophoblastic disorders to assess the progression or regression of the tumor, because the heterophilic antibodies to beta HCG are known to interfere with serum analytes. When the diagnosis is not straightforward, the descriptive diagnosis of atypical trophoblast is the best one, and at the same time, alert the clinician with the possibility of trophoblastic disease. And in case of any doubt regarding the diagnosis of GTD, a simple marker is very useful with IHC for HCG, which will highlight the HCG negative and HCG positive tumor cells. Okay? And take-home message is, abnormal vaginal bleeding is the most common clinical presentation. Extensive hyalinization is characteristic of PSN, and ATT is characterized by Geographic necrosis and calcification. Calcifications are unique feature of PTT not seen in any other trophoblastic disorders. And PSTT is characterized by fibrinal necrosis and deposit. And in case of PSTT, the mitotic count should be stated because it is the feature made to predict the behavior of the tumor. And all PSTT should be considered potentially malignant, even those with a low mitotic activity, because sometimes these tumors deeply invade the myometrium going for perforation, so always consider as potentially malignant tumor. And PSN and EPS undergo spontaneous resolution. PSTT and ETT are self-limited or may persist, may be aggressive. These are the chemo-resistant tumor, whereas choriocarcinoma is the chemo-sensitive one. And diagnosis of gestational trophoblastic disorders in curettings is always difficult. It may not be always possible. So subsequent curettings and monitoring with HCG and HPL is very important. Thank you.
Thank you, Dr. Gunasundari. It was an exhaustive lecture on gestational trophoblastic diseases. You covered almost all the lesions, except for little being fast. It was very good. I think PGs would have had a nice session.
Thank you, madam.
The session was really good. So you need to be more slower in your future. That is all.
Okay, madam. Okay.
Really good.
Thank you very much, madam.
Okay. Thank you. Mindray, can we have the certificate of madam? You have to stop sharing. Dr. Gunasundari, you have to stop.
Yes, madam. Yes, madam.
Yeah. So we will post this certificate to you online. Thank you, Gunasundari.
Okay, thank you, madam. Thank you very much, madam.
Thank you, for the next session. Dr. Sudha also. Dr. Sudha,
yes, thank you, Dr. Padma. Before we go on to the next session, I have a few announcements to make. The same announcements which were made in the morning. Like all of you, maximum please kindly register and become life members. And the next thing is please fill up your forms, your feedback forms, and send it to us. And after this Dr. Teleflow session, we have a teaser session for postgraduates just to break the monotony. So I hope all of you will continue to attend and enjoy the session. Now we go on to Dr. Teleflow's session. I'm indeed very much pleased to introduce and welcome Dr. Teleflow, who I have known for many, many years. We have worked together as assistant professors in Madras Medical College, and I've known her for more than 20 years. And she is a very methodical person. Whatever she does it in a very methodical way. And she has over 20 years of experience in government medical colleges. She has presented a lot of papers and posters, and she has been the nodal officer for the thalassemia project, and she has many, many feathers in her cap. I request and welcome Dr. Teleflow. Over to you, Dr. Teleflow. You may please switch on your video and start screen sharing.
Video. Can you see the screen?
Can you see the screen? Yeah, can you see the screen?
Yeah. You can start. You're audible, and the slides are also visible. You can start.
Okay. So good afternoon, everybody. My topic today is on an array of interesting breast lesions. So before starting the topic, I would first like to thank the organizing team, Dr. Padmavati Madam, Dr. Sudha Venkatesh, and Dr. Aruna Madam for having given me this opportunity to present today. I would also like to thank my HOD, Dr. Andal Madam, and the entire team of KMC, my associate professors, assistant professors who have been instrumental. It was a teamwork, whatever slide I'm putting today. So first, starting with a brief overview. So as per the WHO, breast cancer accounts for about 14% of all cancers in women. And it is very imperative to diagnose correctly because any breast malignancy can cause severe psychological distress in the patient. So it is very important to have an early detection, and correct reporting is also very critical. For example, you cannot overdiagnose a benign as a malignant or a malignant as a benign. So early detection, correct reporting is critical. And the prognosis of these tumors usually depends on the staging and also a lot of predictive factors, including size, grade, the hormone receptor status, age, and recurrence. The average 5-year survival for women with most breast cancers is 91%. So that's why it is very important. Of course, this varies depending on the staging, depending on the age of the patient, and depending on whether it is localized to the breast. But since the prognosis is good and it causing a lot of psychological distress, it is very imperative to make an early diagnosis. So starting with the first case, case 1, a 37-year-old female presented with swelling in the upper inner quadrant of right breast for 6 months. The lump measured 5 into 4 centimeters. It was mobile and firm in consistency. The ultrasonogram revealed a hypoechoic lesion with speculated borders. A true cut biopsy was done, which was reported outside as tubular adenosis. So what we received was an excision biopsy. So the excision biopsy showing a globular soft tissue with a cut section showing a grayish white circumscribed lesion. So this is the microscopic appearance where you're seeing a circumscribed neoplasm, where you're seeing numerous tubules and dilated ducts. There's a haphazard arrangement of the ducts, and some tubules being dilated and some having a tubular pattern. So this is next showing the areas with the dilated tubules, some areas showing epitheliosis, and in between, surrounding the tubules, you can see the myoepithelial cell proliferation. So this shows the apocrine metaplasia, and again to show the haphazard arrangement of the tubules. So with this, we did a P63, and this shows increased proliferation of the myoepithelial cells around the tubules. So with this clinical picture and with the gross and the microscopy and the marker, the diagnosis was adenomyoepithelial adenoma, tubular variant. So coming to a short discussion, this adenomyoepithelial adenoma is a benign proliferative lesion which is characterized by hyperplasia in both the epithelial and myoepithelial cells. There will be mild nuclear atypia to rare mitosis. It can be seen in the salivary gland, skin, and parathyroid. You can have a lot of metaplasias like apocrine, sebaceous, chondroid, squamous. So this metaplasia is, again, it forms a differential diagnosis. For example, if there's extensive chondroid metaplasia, we should think in terms of a pleomorphic adenoma. There are different variants like tubular, lobular, spindle. So again, based on the variants, the differential diagnosis will vary. For example, if it is spindle, it could be a fibromatosis. Our case is tubular. So tubular, there are a lot of other differential diagnoses. The myoepithelial cells in general could be polygonal, spindle, plasmacytoid, or clear. So these cells, you have to do a myoepithelial cell marker, and it will show cytoplasmic positivity for smooth muscle actin and nuclear positivity for P63. So just a brief thing about the classification of benign breast disease. We can classify it into epithelial, myoepithelial, and fibroepithelial. So I will not be touching upon everything. Just the brief differential diagnosis, which is microglandular adenosis, tubular adenoma, sclerosing adenosis, fibroadenoma. All these form differential diagnosis for this lesion. So in the case of sclerosing adenosis, you will have compressed ducts, but it will be present in the center, and surrounding that you will have the dilated tubules. You will not have this much amount of myoepithelial hyperplasia. So this way you can differentiate it from a adenomyoepithelial adenoma. In the case of microglandular adenosis, which is a mimicker of malignancy, you have tubular glands which will infiltrate into the fibrous tissue and the fatty tissue, but the lining is usually single. You don't have a myoepithelial lining. So this way you can differentiate. Third, you can think of a radial scar, but in the case of a radial scar, you will have a central sclerotic area and the haphazard tubules will be all in the periphery, unlike adenomyoepithelial adenoma where the distribution is throughout the lesion. And fourth differential diagnosis is tubular adenoma, where you have the tubular pattern, but you don't have the haphazard dilatation and you don't have the myoepithelial proliferation. So why is it so important to recognize this? One, because it can have local recurrence with inadequate resection. So what if there is local recurrence? It is usually a precursor to malignant myoepithelioma. So you need to differentiate it from other benign lesions. And follow-up is essential when you see increased mitosis, nuclear atypia, prominent nucleoli necrosis. This tumor can also be associated with ductal carcinoma. So that's why, though it is a benign entity, it is very important to recognize this as a practicing pathologist or as a consultant and differentiate it from other benign lesions. So with this, we move on to the next slide, case 2. A 52-year-old female presented with a lump in the upper outer quadrant of left breast, which was noticed 5 months back with recent sudden increase in size. The lump measured 4 into 3 centimeter. It was non-tender with restricted mobility. The nipple was retracted. The FNAC reported was positive for malignancy. A modified radical mastectomy was done. So this is to show the MRM specimen where you can see the cut section, which shows an infiltrative gray-white growth, almost resembling similar to that of an infiltrating ductal carcinoma. So microscopically, we saw sheets of polygonal cells which had abundant granular cytoplasm and which had vesicular nucleus, prominent nucleoli, and you can see the tumor cells with exhibiting atypia infiltrating into the fibrous tissue and also into the fatty tissue. So the immunohistochemistry, ER-PR was negative and androgen receptor positive. So with all these features keeping in mind, a gross resembling an infiltrating ductal carcinoma with microscopic features showing abundant granular cytoplasm, atypia in the cells, and with the immunohistochemistry showing a positive androgen receptor and ER-PR negative, the diagnosis is invasive apocrine carcinoma. So this is a very rare lesion forming only about 4% of all breast tumors. Age is usually elderly. Apocrine differentiation is seen in more than 90% of invasive breast carcinoma. Only then you use the terminology invasive apocrine. So it should be more than 90%. Or you can also use the word invasive duct carcinoma with apocrine differentiation. So it can also be seen as a mixed carcinoma, where it can be seen associated with infiltrating ductal carcinoma, no special type, micropapillary, tubular, medullary, can be also associated with DCIS and LCIS. So histologically, there are two types, type A and type B. So in type A, you have abundant granular cytoplasm, whereas in the case of type B, you have a foamy cytoplasm. So this has got no clinical relevance, but in terms of differential diagnosis, it plays an important role. Type A, the differential diagnosis, you can think of oncocytic carcinoma. In type B, you can think of a granular cell tumor. You can think in terms of histiocytic proliferation. You can think even in terms of lipid-rich carcinoma or a secretory carcinoma. So immunohistochemistry wise, you say apocrine carcinoma, one, when you see the apocrine cells more than 90%, second, the immunohistochemistry should complement. So you should have an ER-PR which is negative and an androgen receptor which is positive. So all this put together, you call it as pure apocrine carcinoma, which accounts for less than 1%. So this apocrine molecular signature. So what is this entity? You have an ER-PR which is negative. You have a HER2 positive, androgen receptor positive, GCD-FP positive, which is a primary mammary, says it is a primary tumor, BCL2 negative, and you also have loss of PTEN and P53. So when you have this apocrine molecular signature, it is associated with a very poor prognosis. And it is also important when you have this HER2 and androgen receptor positivity, it helps in targeted therapy for the patient. So generally, when you have this apocrine molecular signature, the prognosis is poor. Otherwise, the prognosis is similar to that of invasive breast carcinoma. So again, just to show the H&E, the estrogen receptor, the androgen, and the HER2 news. So the differential diagnosis, as I said, you can think of a oncocytic carcinoma, where your anti-mitochondrial antibody in HER2 will be positive here, whereas anti-mitochondrial antibody will be negative there. Histologically, oncocytic carcinoma will not have that much of atypia. So that's one differentiating point. Similarly, granular cell tumor and histiocytic proliferation, you will not have atypia. You will not have nucleoli. You just have the nuclei. And of course, the markers help to differentiate. You can do an S100 for granular cell tumor and CD68 for a histiocytic proliferation. So just to show granular cell tumor and oncocytic carcinoma. So with this, we move on to case 3, which is am I fast? Okay, 65-year-old female presented with swelling in the right breast.
You can little slow down.
Okay, slow down.
You can slow down a little bit.
Okay, is the time I'll slow down? Yeah, I'll slow down.
I think we have.
Okay. So 65-year-old female presenting with swelling in the right breast. So there was a history of bloody nipple discharge. The location, it is in the lower inner quadrant, measuring 1 into 1 centimeter. Ultrasound showed a hypoechoic lesion measuring 1.3 into 0.7 centimeter and few very tiny cystic spaces, and it was given as Birat's 2. We had a USG guided FNAC, which was inconclusive, showing only hemorrhagic material and few adipocytes. So in view of the ultrasound picture, and because the swelling was mobile, an excision biopsy was done for the patient. So what we received is a fibrofatty tissue, where you can see the multifocality. You can see the gray white solid areas all around 1 to 0.5 centimeter. We can see very tiny small cystic spaces. So microscopically, we saw a solid expansile neoplasm, and you can see the barely discernible fibrovascular core, which is covered over by the neoplastic cells. You don't have a heterogeneous population. You have a single population of neoplastic cells, so that is very important. And you have an inconspicuous fibrovascular core, which is the second important feature. So you can see again the inconspicuous fibrovascular core and the infiltration of the tumor into the stroma. So when we did a Ki67, it was very low. The ER-PR was positive and the chromogranin was negative. So again, the P63 we had done, this is the control on the left side. So the P63 at the level of the papillae and at the tumor stromal interface was negative. So keeping all this in mind, that is the solid lesion, the multifocality, and the inconspicuous fibrovascular core, the P63 which is negative. Of course, we did not have the neuroendocrine marker positive. The diagnosis was invasive solid variant of papillary carcinoma. So this is generally a tumor where you have closely opposed expansile cellular nodules with fibrovascular core which can be inconspicuous. Generally, neuroendocrine differentiation is frequent, and you can have the invasive growth pattern which may have mucinous and neuroendocrine features. So again, here the invasive component is important. That is, the prognosis again depends on the invasive component. So it is very important to mention in the report whether the invasive component is ductal, lobular, neuroendocrine. So you have to mention what is the invasive component. So I will be discussing case 3 and 4 together. So 60-year-old female, case 4, presented with the lump in the left breast, subareolar lesion measuring around 3 into 2 centimeter. There was no bloody discharge from the nipple. FNAC reported as proliferative breast disease, probably papillary lesion. Through-cut biopsy was given as invasive papillary carcinoma. What we received was a modified radical mastectomy with axillary lymphadenectomy. So this is again to show the modified radical mastectomy specimen. The cut section showing the intracystic tumor, which is fleshy white, and it is friable. And you can see the neoplastic tissue extending beyond the cystic area into the fatty tissue. So again, you can see the extension of the neoplastic tissue. So microscopically, we saw slender fibrovascular core, and surrounding that, you have the neoplastic cells. Again, a uniform population, not heterogeneous. And you can see the alignment of the nucleus, which is perpendicular to the fibrovascular core. The perpendicular alignment, there is very minimal nuclear atypia, but there is some degree of nuclear atypia, the infiltration into the stroma. So an ER was positive, HER2 was negative, and Ki67 showed around 20%. So with all this diagnosis, the invasive papillary carcinoma was reported. So just the WHO classification of breast tumors, you have epithelial and papillary lesions. Under epithelial, you have invasive breast carcinoma, the invasive micropapillary and invasive papillary carcinoma, which we'll be discussing. And under papillary lesions, we have the papilloma, encapsulated and solid. So encapsulated and solid is a very close differential diagnosis. In fact, there is a lot of overlap between the two lesions. So both you can have a in situ component and an invasion component. So in the case of intraductal papilloma, it will present as a single or multiple lesion where you will have dense fibrous stroma. So you will have a broader papillae, and you will have a heterogeneous population of cells where you will have basal myoepithelial cells, and you will have the basal and the myoepithelial cells present. And when you do a P63, you will see the myoepithelial cells around the papillae and also around the stromal papilloid interface. So you can see in both the areas, you can see the P63. In the case of next differential diagnosis, intraductal papillary carcinoma. So this is again a multiple lesion. You will have same slender rods, and you will have a single population of neoplastic cells. The grading may vary, but when you do the marker, but when you do the P63 marker, you will see that the marker is present only along the neoplastic cell papilloid tumor interface border, you will not see it surrounding the papillae. So that is one important point. So you can see atypia, unlike intraductal papilloma. The next, encapsulated and solid papillary carcinoma. So in the case of encapsulated carcinoma, you will see a well-defined fibrous capsule. In solid papillary, you may see, but it won't be very well defined. In the case of encapsulated, you will see fibrovascular core, which is more prominent. In the case of solid papillary, it will be very inconspicuous. And in the and considering the gross also, in encapsulated, you will have mainly cystic lesion. In the case of solid papillary, usually it will be multiple and solid. But of course, in the case of solid papillary carcinoma, many times it can express neuroendocrine or it can express mucinous differentiation. But that is not a must. It may be associated. So the prognosis usually, if it is intraductal papillary carcinoma or if it is an in situ of solid or encapsulated variant of papillary carcinoma, it has got a favorable outcome. If it is an invasive tumor, then the prognosis depends on the invasive component in the case of solid and encapsulated. So invasive papillary carcinoma, the prognosis depends on the tumor grading and staging. Usually, all these papillary lesions are node negative, except micropapillary carcinoma, which does not have a fibrovascular core. It is just the epithelial cells which form the tufting. So these tumors have got a very poor prognosis, micropapillary, and it is different from all other tumors because it is usually node positive and usually it has got lymphovascular invasion. So when we see a micropapillary carcinoma, we should always look for angioinvasion because very commonly associated. And micropapillary carcinoma always has a poor prognosis except when it is associated with mucinous carcinoma. So that is one important point we have to keep in mind when compared to all other papillary lesions. So with this, I just completed the papillary lesion. Now case number 5, a 44-year-old female had a lump measuring 3.5 into 3 centimeter, just sent us fibroadenoma. It was just a routine incidental finding where you can see the gross almost resembling a normal breast, gray-white lesion, and microscopically you can see the hyalinized collagen, and in between that you can see small cleft-like spaces which are lined by spindle-shaped cells. So again you can see the cleft-like spaces, the duct, the spindle-shaped cells, and you can, if you closely observe, you can see the spindle-shaped cells inside the cleft does not have any RBCs and there is no atypia. So CD34 was done and it shows the myofibroblast component was positive, so the spindle cell exhibited positivity. So with this, the diagnosis is pseudoangiomatous stromal hyperplasia. So this is pseudoangiomatous. I just thought of presenting this only because you should not miss it. It can come as it can be associated sometimes even with mammary hamartoma. It can come along with fibroadenoma. Sometimes if it is there, even a surgery is not essential for the patient. So discussion, it is a benign proliferative mesenchymal lesion, usually incidental, where the myofibroblast will proliferate and simulate a vascular lesion. So that is one of the other reasons why I wanted to present this slide. So this entity should not be mistaken for a angiosarcoma. And it is usually seen in the premenopausal age group, postmenopausal, and patients on OC pills. So here there is an aberrant response to estrogen progesterone. So usually if you do an immunohistochemistry, CD34 will be positive and estrogen progesterone receptor will be positive, but it will be negative for the vascular markers. So the main differential diagnosis you should not confuse with low-grade angiosarcoma. In the case of angiosarcoma, you have the endothelial cells which may exhibit mild atypia. You will have RBCs inside, and when you do a marker, CD31 will be positive. Of course, myofibroblastoma is also a close differential diagnosis because here also you have the hyalinized collagen. Sometimes you need an androgen receptor to differentiate the both. Fibromatosis is also another differential diagnosis where again you will not see the clefting. When you have a confusion, you can go ahead and do a beta-catenin. And sometimes this entity can be associated with hamartoma where you have adipose tissue present inside, and it can also be associated with the juvenile fibroadenoma. So next case, case number 6. Do I have time? I have time.
How many cases more?
How many more cases do you have?
Two more. One is very
okay.
Yeah.
Okay.
Case
Yeah.
6. 34-year-old type 1 diabetes presented with bilateral breast mass. So that's why the important history taking. So the history is a middle age, type 1 diabetes, bilateral breast mass. On examination, subareolar lump is seeing 1 2 into 2 centimeter left side, the other 1 into 1 centimeter. The lump was mobile, non-tender. So what we received was an excision biopsy specimen. We received two lesions, both which was glistening, gray white, and microscopically we saw there were numerous lymphocytes which were present around the, so the slide is not very good, around the lobules, around the ducts, and you can see a lot of hyalinized collagen present in between the lobules. So with this, the diagnosis is sclerosing lymphocytic lobulitis. So in sclerosing lymphocytic lobulitis, you will have ducts, but the ducts will usually be compressed and atrophied. So that is one very important point we should keep in mind. And we'll have lymphocytes which are present around the lobules, around the ducts, and around the vessels. Sometimes in the stroma, you may have some epithelioid fibroblasts which may mimic malignancy. So you should not get confused with malignancy. So two important points we should keep in mind is the atrophied ductules and the hyalinized collagen. So why this is so important? So sometimes it can be associated with the lymphoepithelial lesion. So why the sclerosis and the atrophic duct is very important? Because the important differential diagnosis for this is a maltoma. So in maltoma also you will see lymphoepithelial lesions, you will see lymphocytes which are present around the ducts, but this type of sclerosis and this type of atrophy will not be present. And in the case of maltoma also, when you do an immunohistochemistry, it will have positivity for B cell markers. So that time you have to do gene rearrangement study and look for the clonality. If it is monoclonal, then you should think in terms of maltoma. So that is one reason why I wanted to put this slide, to just know that this entity is there, because even maltoma, you can have an autoimmune history. So the history taking becomes very important. Here, mostly autoimmune, mostly with type 1 diabetes, mostly bilateral, mostly seen in, it is usually seen in females, and it may be associated with DCIS. Sometimes it may be confused even with invasive lobular carcinoma because of the target type pattern. So the last slide, a 53-year-old female presented with lump in the lower inner quadrant of left breast. The lump measured around 5 into 3 centimeter. What we received in FNAC was a pale, glistening, jelly-like material reported positive for malignancy, mucinous carcinoma. So you can see the mucinous stroma. You can see, I think it's not very clear. You can make out the chicken wire-like blood vessels were there. And the atypical epithelial cells, if you carefully notice, the mucin is both extra, and you can also see intracellular mucin, with the mucin all directed more towards the base. So that's one important finding which you should keep in mind. So grossly you can make out the circumscribed lesion having the glistening material on cut section. So microscopically you could see lakes of mucinous material in which the neoplastic cells are seen floating. So we did a ER, PR which was positive, and chromogranin again was negative. So with this, the diagnosis is mucinous carcinoma. So I'll come to the types. So before that, mucinous carcinoma, otherwise called colloid carcinoma, mucoid, gelatinous, or mucinous adenocarcinoma. So this is again a rare entity accounting for only about 2% of all breast carcinomas, mostly seen in women above 55 years. So when they use the word pure mucinous, when it should be more than 90% of the invasive component should be admixed with stromal mucin. Stromal mucin with 50 to 90% is called as mixed mucinous carcinoma. So you have two types here. So ours was type A, where you have the classical or non-endocrine types, or ours the neuroendocrine differentiation was negative. This usually occurs in a younger age group, and there's more amount of extracellular mucin. Type B, you have the neuroendocrine differentiation. So there will be more amount of intracellular mucin, and you can see a glandular pattern. There are different variants here. So micropapillary, as I mentioned earlier in papillary lesions, if micropapillary is generally has got very poor prognosis, but when it is associated with mucinous carcinoma, it has got a little better, more favorable prognosis. And again, I said solid papillary carcinoma, sometimes you can have a small solid papillary component. Associated with that, you can have a mucinous carcinoma present. Second variant is signet ring cell variant, which again sometimes can be confused with signet ring lobular carcinoma, but here you can see the intracellular mucin. Third is cystic papillary variant. So these are the variants: micropapillary, signet ring, and cystic papillary variant. In the patterns, it can be trabecular, it can be solid, it can be papillary. So the differential diagnosis, you should think of mucosal with extravasated mucin. So in the mucin, you will have the epithelial cells, but when you do a P63, there will be no myoepithelial cells surrounding it. There will be myoepithelial cells present here, unlike mucinous carcinoma. So that's how you differentiate. And sometimes once you have an entity called cystic hypersecretory lesion, where you may see dilated ductules, but there will be no atypia surrounding the ductules. Inside that, you will have material which resembles mucin. So you have mucinous material. So the immunohistochemistry here is ER/PR is usually positive. HER2 is variably, I just missed one point. The other differential diagnosis we can think of is a metastatic mucinous ovarian or pancreatic tumor. So again, here this will be positive for CK20. So that's how you differentiate it from a mucinous carcinoma. So immunohistochemistry, ER/PR will be positive. HER2 will be variably expressed. But MUC2 and MUC5 is positive. So this is again a very important point, because MUC1, membrane-bound mucin, is usually seen in infiltrating ductal carcinoma, whereas MUC2 is seen mostly in mucinous carcinoma. So this MUC2 will actually limit the aggression of the tumor. So that is why in MUC, when you have MUC2 is positive in mucinous carcinoma, and that is why mucinous carcinoma has got a more favorable prognosis compared with IDC having a mucinous component, because there you have mostly MUC1. So the prognosis, pure mucinous carcinoma usually carries a better prognosis than the mixed type. So with this, my take-home message is a good clinical history, because we saw from the various slides, for example, slides saying type 1 diabetes, so the history was important there, and then correlation with the radiographic finding, how your BRAX2 in your radiography helped in just going only for an excision biopsy. Second, the histopathological and immunohistochemistry, as in the case of apocrine carcinomas, is vital to clinch the right diagnosis. Thanks. Thank you.
Thank you, Teleflo, for the excellent presentation. I'm very happy that you have chosen all the rare slides for this presentation. It was indeed a treasure to see all these lovely slides. And there are a few questions. One is, how do you differentiate between invasive papillary carcinoma and solid variant of papillary carcinoma?
Yeah, invasive papillary carcinoma, you should take invasive papillary carcinoma. Usually you have a fibrovascular core which is present, but in the case of solid papillary, it is very, very inconspicuous. But in the case of papillary carcinoma, you have a nice slender papillae, and you have the nuclear alignment which is not a perpendicular arrangement, unlike solid variant. And in the case of solid variant, it is usually solid and gross, and it is usually multifocal. And of course, when you see the infiltration, in the case of solid papillary, sometimes you can see a fibrous capsule, unlike invasive papillary carcinoma, where you don't have the capsule at all. So this is histologically the main differential diagnosis. So once the histology is very clear, there should be no, the marker is not even essential, marker is only needed for other things, because in the case of invasive papillary, the fibrovascular core is very prominent. In solid papillary, I just showed you the slides, you have a very, very inconspicuous fibrovascular core.
Yes. And the next question is, how to differentiate between solid papillary carcinoma from type B or type AB mucinous carcinoma, since both show neuroendocrine features and mucin content?
That's why sometimes they say you cannot differentiate, because in the case of mucinous carcinoma, especially type A, you have this solid papillary carcinoma can be a small component in the mucinous carcinoma. But when you see the mucinous component, that is when it is more than 90%, then you should not think of a solid papillary. Of course, in solid papillary, you will have mucinous, you may have a neuroendocrine differentiation, but in the case of mucinous, the mucinous component should be more than 90%. So that is the main main definition of mucinous carcinoma. Second, you can have a solid papillary component, but that is a very minuscule amount compared to the total, compared to the larger picture.
Okay, thank you. Thank you very much, Teleflo. If there are any more questions, I think you can type it out in the chat box, and Dr. Teleflo will be happy to answer them. So we move on to the next session, and over to Dr. Padma.
Mindray, can you project the screen? Yeah. Thank you, Dr. Hediflo.
Yeah, thanks.
It was very interesting. So now we will post the certificate to you online. We will move on to the next session. So next session is a teaser round just for 10 minutes to break the monotony of sessions. It is just for the postgraduate sake, all spotter slides. So there is no history or anything. You can answer in the chat box. Start from the first slide. Can you start from the first?
Yes, I'm going to first slide, ma'am. I'm going to first slide.
Go to the slideshow mode. It will take 10 minutes. After that, the Damayanti session is there. That will be the last session. All these slides will be kept as a spotter slide for you during your postgraduate examination, just for you to revise. All of you would have seen it umpteen number of times, but it doesn't matter. You can keep seeing it again and again so that you don't miss it out. Can you go to slideshow mode?
Ma'am, just a moment. There is something.
No issue.
Allow me a moment.
I think it is in Google slide mode. Otherwise, just so in your postgraduate examination, all of these slides will be kept as slides for diagnosis or spotter or identify the organism or identify the organ and lesion, this sort of thing. So this either will be an easy slide. It is not coming as slideshow. No issues if it is not coming as slideshow also, because all these are.
Yeah.
Yeah. Okay. So
I'll move the slides on your instructions, ma'am.
Yeah, move it up. Keep moving till the emoji comes. So this is the gross appearance and the microscopy. So what is the diagnosis? So you can chat in the chat box. You can, yeah, that's it. So all of you will be very familiar. Can you go back to the first and second slide? Yeah, this is the gross appearance and next slide, microscopy. So you have the, yeah, third slide, next slide, next slide, next slide, next. This is again another teaser. Teaser 2 is this. So this is a microscopic appearance. Again, this will be kept as a, yeah, all of you are right. Yeah, next slide, please. Next, yeah. So this is the mucosal biopsy. Next slide, please. Yes. Strongyloid is the correct answer. Yeah, next slide. This again is a mucosal biopsy. Yeah. No, previous slide. This is CMB, right?
Should I move ahead, ma'am?
Yeah, you can. So this is Cryptococcus. Yeah. What is the special stain? Cryptococcus, what is the special stain? GMS, right. Yeah, India Inc. and GMS. This is GMS. Next slide. So this is again a mucosal biopsy. Gastric mucosal biopsy, organism, H. pylori. What is the special stain? Vardin-Starry stain. All of you are right. Silver stain, Vardin-Starry. Right. Next slide. This is a bullous lesion in the skin, and this is the IF picture. Bullous pemphigoid. So that is the right answer, bullous pemphigoid. Okay, next slide. What is this? EM picture. This again will be in your OSPE So you have the tennis racket. So what is this? LCH, right? Tennis racket appearance, Langerhans histiocytosis, Pyrrhic granules. Right. All of you are right. Next slide. Next slide, please. So this is again a special stain of renal biopsy and IF picture. Sorry, this is polarizing light. So this is Congo red appearance, amyloid, and polarizing light, apple green by reference. Right. Next slide, please. So all these are very easy things, but still keep seeing it again and again. So this again is a bullet lesion, skin biopsy, subepidermal, and this is the IF picture, fishnet appearance, pemphigus vulgaris. All of you are right. I don't think consultants are answering for this. It's only for postgraduates. Okay, next slide, please. Next slide. So this is bone marrow. Previous slide. Yeah, this is bone marrow. Leishmania, LD bodies. Right. You are right. LD bodies, the correct answer. Next slide. So what is this? EM picture again. So this again will be kept as an EM OSPE question for you in the molecular and the EM pictures. Parking lot inclusion. You are right. Next slide. This again is a renal biopsy. PA stain. Crescentic glomerulonephritis. You are right. So this is a fibrocellular crescent. Cellular crescent, sorry. Next slide. Next slide, please. Is that the last one? Yeah. This is a skin biopsy. Like yesterday, we had a great session by Dr. Chitrakala. So all of you should be answering this. Histoid leprosy. What is the special stain? Special stain for this is Phyte Farraco, right? So this is histoid leprosy with Phyte Farraco stain. Right. Next slide, please. No short forms. You need to write it fully in the examination. Next slide, please. That's it.
Ma'am, that's the end of it.
Yeah. Okay. Now you can project Dr. Damayanti's profile. Last slide was Dr. Damayanti's profile, please. Okay.
Dr. Padma, the answer for last slide.
Niemann-Pick disease. Sorry. Maybe we will post the slide again. We will show the slide again. So we invite Dr. Damayanti, who is the Associate Professor of Pathology from Madurai Medical College. She has a teaching experience of 15 years and her expertise is in FNAC and bone marrow aspiration, biopsy crossing of fetal autopsy. So she is a consultant in with private pathology labs also. She has got publications and with evaluation of incidence and accuracy of FNAC with histopathological findings in thyroid neoplasm. So over to you, Dr. Damayanti. Next half an hour. Dr. Damayanti, you can come on video and share your PPT. Mr. Varun, any issues? Mr. Varun?
Damayanti, can you hear us?
But Damayanti, you need to unmute and...
let me try.
Yeah, later. No issue. I would like to thank Dr. Mercy, who is a final year postgraduate, who was helping me in getting this teaser ready. We wanted to do this teaser during technical hitches, but by God's grace, everything was going fine. So I thought I will do this as a revision for the postgraduate. Thank you. Thank you, Dr. Mercy, for the PPT which you had done. Dr. Damayanti, over to you. You go to slideshow mode.
Yes, madam.
I
am audible, madam?
Yeah, you are audible. You have to come on video also, if possible.
Yes, madam. Video. 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 எது? இதுவா?
Yeah.
Scroll பண்ணிட்டே இரு, சரியா?
Good evening, one and all. I must very much thankful to the organizing team of TAPCON 20, to Madam Padmavati, and I'm thankful for the Department of Pathology who has helped me in preparing these slides. My colleagues and PGs and HOD, I am thanking special thanks to my HOD. Now I am presenting 5 interesting different cases in this forum. I move on to case number. So the case number 1 is a 37 years old lady who complains of headache for the past 10 days, and she has history of a slurring of speech. So the MRI picture shows there is an enhancing mass lesion in the ventricles, enhancing mass lesion which is occupying almost the ventricles. So grossly we received multiple pieces of gray white tumor mass which is together measuring 1.5 into 1 centimeter, which is soft and firm in consistency. So this is the scanner view, shows a monotonous, that is monomorphic sheets of tumor neuronal cells. In another picture, it is the tumor margin is well demarcated. There is a sheets of monotonic sheets of tumor nests of cells. Here the high power view shows a neuronal cells which are round cells with regular nuclei. They are arranged in sheets. The background show one pinkish appearance. So the tumor cells are embedded in a matrix of nuclear free fine neuropil. This is another high power view, shows some perinuclear arcs like an oligodendroglioma. This is another picture. High power view shows a monomorphic tumor cells with a clear perinuclear half. So with this we had a diagnosis of central neurocytoma, ependymoma, and oligodendroglioma. These are all the differential diagnoses we made. So we have done immunohistochemistry, synaptophysin Ka67. This synaptophysin, their tumor cells are constantly expressed by the synaptophysin, including their processes. This Ka67 was negative. This new N, this marker shows a diffusely expressed in all the tumor cells. So with this we arrived at diagnosis of central neurocytoma. So central neurocytoma is a grade 2 WHO tumor. It comes under the neuronal and mixed neuronal glial tumors. So the central neurocytoma, it is an uncommon intraventricular neoplasm. It is composed of uniform round cells with a neuronal immunophenotype and a low proliferation index. The age group is 20 to 40 years. It is equally distributed. Sex distribution is equal. The incidence is about 0.25 to 0.5. So clinically, there is an increased intracranial pressure. The site of tumor location is supradentorial, especially in the lateral and the third ventricles. The cell of origin for this tumor is the nuclei of septum pellucidum. So we have to differentiate from ependymoma and oligodendroglioma. So the EMA and the GFAP will be positive in the oligodendroglioma and ependymoma. So the prognosis depends upon the degree of resection of the tumor cells. So the tumor has to be excised totally so that the recurrence should be corrected. So I move on to the second case. This is the 45-year-old female who is clinically diagnosed as carcinoma ovary, and they have done a staging laparotomy. So this is the specimen we received. The specimen is a ovarian mass, which is measuring 10.5 into 10 into 9 centimeter. The external surface is smooth and bosselated, and the cut surface shows some cystic and solid areas. The cystic areas are filled with a solidified material, solidified mucinous material, and there is a tan yellow fleshy areas also you can see. So the cut surface is the multiloculated cystic and solid areas. The cystic areas is filled with the solidified mucous material, and the solid area is grayish white and friable with tan yellow fleshy areas. So this is the low power view showing some glandular structure and the spindle cell biphasic component. This is the high power picture where you can see the tumor cells are large round oval shaped cells with the acidophilic, that is eosinophilic cytoplasm, and you have a prominent vesicular nuclei. They have some nuclear stratification. They are arranged in glandular and papillary pattern. So this is another picture, shows some many multinucleated giant cells, and you have a mitosis there, and there is a spindle cell component here. So this is another high power view, shows bizarre cells with a atypical vesicular nuclei, and there is a mitosis. There are plump spindle cells with irregular large nuclei. So with this, we arrive at a diagnosis of carcinosarcoma ovary. By WHO classification, comes under malignant mixed Mullerian tumor, that is mixed epithelial and mesenchymal tumor. So it is the age group is more common in postmenopausal age, that is 64 to 66 years. More common age is postmenopausal. The tumor size may vary from 15 to 20 centimeters. So grossly, these tumors are soft, firm, yellow to brown. They are solid and often exhibiting hemorrhage and necrosis with cystic degeneration. Hemorrhage and necrosis is a striking feature of the carcinosarcoma. So microscopically, they have a biphasic component, which is intimately admixture of the malignant epithelial and the stromal elements. The malignant epithelial element is high grade. It can be of serous endometrioid carcinoma type, endometrioid carcinoma, but can be of any other surface epithelial types of tumor, ovarian tumor. So the mesenchymal component may have a feature of fibrosarcoma, leiomyosarcoma, endometrioid stromal sarcoma, or non-specific stromal sarcoma, or rhabdomyosarcoma, chondrosarcoma, or osteosarcoma. The stromal component usually contains sheets of hyperchromatic cells. They are rounded to spindle-shaped cells with marked nuclear atypia and high mitotic index. So this is the heterologous element where you can see the cartilage, osteoid, and the rhabdomyoblast differentiation. So the intracellular and extracellular hyaline droplets you can see, which are PAS positive in sarcomatous as well as sometimes in the carcinomatous component also. So the differential diagnosis is immature teratoma and Sertoli Leydig cell tumor. So the immature teratoma, there is a heterologous triple MT. They are never found in women older than 50 years. It contains elements derived from all the three germ cell layers. They lack malignant Mullerian type of component. So here the microscopic picture, you can see a primitive neuroectodermal component. These are all the tubular-like structure with a blastemal-like cells. So in Sertoli Leydig cell tumor, the findings of Leydig cells, they are sex cord formations, tubules or gastrointestinal type mucinous glands or cysts. Homologous Sertoli cell Leydig cell tumors, epithelial component that resemble Mullerian type carcinoma but occurs in a younger age group than a triple MT. So IHC shows a EMA positive and alpha inhibin and calrectinin may be positive, but a triple MT are usually EMA positive. This alpha inhibin and calrectinin are positive for Sertoli and Leydig cell tumor category. So the rare surface epithelial tumors, that is serous, mucinous, or clear cell, if they are present, they have contained a sarcomatous nodule. They lack the extensive admixture of carcinomatous and sarcomatous elements. They are characteristic of triple MTs. So the IHC for the skeletal muscle differentiation, they positive for desmin, myodin 1, myogenin can be used to help identify the heterologous rhabdomyoblast. Usually the triple FT are positive for EMA. So prognosis, most of the tumors, they already extend to the outside of the ovary at the time of surgery. They are aggressive, rapidly fatal tumors with a median survival of 1 year. So taxane and isoflavonoid therapy increases the survival rate in these tumors. So I move on to next third case, which is a conjunctival swelling in a 70-year-old male. So this is the clinical picture, shows a mass in the conjunctiva, which is in the junction between cornea and the conjunctiva. We received a soft tissue measuring 0.5 centimeters in diameter. So low power view, there is a lining stratified squamous epithelium of the conjunctiva with ulceration, which is focally replaced by the tumor cells. So the tumor cells, they have an entire thickness. The areas of melanin pigmentation is there in here, and the stroma is free of tumor. The high power view, the tumor tissue shows sheets of polygonal cells with the round nuclei and eosinophilic cytoplasm. The superficial cells show melanin pigmentation. There is no nuclear atypia or mitosis here. So with this, we arrive at a diagnosis of conjunctival melanocytic intraepithelial neoplasia with a score, that is conjunctival melanocytic intraepithelial neoplasia has got a scoring system. The total number of score is 10. So out of which in this case is possessed 7, that is 4 plus 3 plus 0, according to the radial spread and the involvement of more than 90% of the epithelial thickness in a vertical spread. The score is 7 was arrived. So here the Siemens scoring, the horizontal growth, we can able to score according to the presence of melanocytes in the horizontal position. So here first picture, it is normal. There is a basal cell and there is a squamous lining epithelium. Here it is 0. In the basal cell, if there is a few melanocytes, it is score 1. There is pagetoid differentiation. If it is there, it is score 2. Then the isolated nests of melanocytes, if it is present, it is score 3. And the confluent nests, if it is present, it is score 4. So this is horizontal spread. In vertical spread, we have to compare it with the basal cell layer of the squamous. It is if it is there is no cells, it is 0. If it is 1 to 50% of the nevoid cells, if it is present in the vertical region, it is 1, score 1. If it is 50 to 90, it is score 2. It is more than 90, almost it is occupying the whole squamous lining. It is 90. More than 90 means it is score 3. So the melanocytic nuclear features, that is melanocytic nuclear and cytoplasmic ratio, according to which it is the score is graded in a melanocytic nuclear atypia. So the nucleus and the cytoplasmic ratio in a basal squamous cells is compared. It is, if it is normal, it is 0. The nucleus mild nuclear atypia, it is score 1. That is moderate means that with the basal cell, it is score 2. And it is nuclear atypia is more and there is mitosis means it is score 3. So coming to the neoplastic conjunctival system of scoring, that is primary acquired melanosis system and the Siemens scoring system and WHO scoring system. In PAM without atypia, it comes under Siemens score 1, and the PAM with mild atypia, the Siemens score is 2. So the both Siemens score 1 and 2 comes under WHO low grade conjunctival melanocytic intraepithelial lesion. Then the PAM with moderate atypia, the Siemens score is 3. And the PAM with severe atypia, that is more than 75% of the epithelium, the Siemens score is 4 to 5. So these 3 to 5 comes under high grade conjunctival intraepithelial lesion. So melanoma in situ is score 5 in Siemens score. It is also melanoma in situ in WHO, and then the invasive melanomas. So in current TNM staging, the guidelines for melanoma in situ is more than 75% of the normal conjunctival thickness is replaced by atypical melanocytes. So the mala A is positive in our case. So the differential diagnosis is pure conjunctival nevi, pigmented ocular squamous neoplasia, benign epithelial melanosis of the conjunctiva. So how does it differ? It is pure junctional nevi is generally found in young adults, whereas middle-aged and older people affected by basal melanocytic proliferation is lacking. Subepithelial component is much more likely to be CME and PAM than the nevus, Then pigmented intraepithelial squamous metaplasia clinically mimic the ocular neoplasia, metaplasia. It clinically mimic the CME and PAM with the atypia. The melanin production by cytologically normal looking melanocytes. There is no increase in the number of the cells. But in benign epithelial melanosis, increased melanic pigmentation within these melanocytes will be seen. The nuclear enlargement, prominent nucleoli and mitosis will not be present in the benign epithelial melanosis. So we move on to case number 4. Here the 42 years old male patient, we received a mass which is infected, diagnosed as infected sebaceous cyst, size is 5 into 3 centimeters in the back of the chest wall. So we received a skin attached soft tissue mass measuring 6 into 4 into 3 centimeter. The cut surface is grayish white. So the scanner view, there is a epidermis under which there is a cellular tumor. The tumor has got a interlacing fascicles, arrangement of interlacing fascicles. The tumor cells are spindle shaped with elongated nuclei. In this high power view only we can see the nuclear pleomorphism, and there is a scanty cytoplasm, acidophilic cytoplasm, and there is some mitosis. So in still more high power view, you can see the nuclear pleomorphism and the mitotic activity. So we put a Caldesman, H-Caldesman is positive. So there is a diffuse strong positivity of cytoplasmic positivity of tumor cells. Then the Ka67 showed it more than 20% positivity. So with this we arrive at a diagnosis of cutaneous leiomyosarcoma. So in cutaneous leiomyosarcoma, it is described by Montgomery and Winkelmann in 1959, also called as atypical intradermal smooth muscle neoplasm. This is the rare tumor comprising less than 5% of the adult soft tissue sarcomas. Male to female ratio is 3:1. The age group is 50 to 70 years with mean age of 56 years. Two types of superficial, two types are there. One is superficial, that is dermal, and subcutaneous, that is deep. Most frequent abnormality is loss of chromosome 13q4 to 21 region. So clinical feature, there is painful solitary red pink nodule, which rarely ulcerates. They arises from the erector pili muscle and smooth muscle surrounding the sweat glands. Scrotal lesions arises from the dartos muscle. So the predilection for trunk and the lower extremity is more common site. Documented sites are radiation dermatitis, ectopic areola, in a datu marker, then scrofloderma scar, and nevus sebaceous. So the criteria here is the highly crowded, that is cellular tumor with an infiltrative growth pattern. The significant cellular and nuclear atypia with the plump hyperchromatic nuclei. There can be a tumor cyan cells, and the mitosis is 1/10 high power field. So the variants are epicular variants, granular cell variant, inflammatory variant, and desmoplastic leiomyosarcomas. Small lymphoid aggregates are sometimes present within the tumors. They have a dense infiltrative. They are quite rare, called inflammatory leiomyosarcoma. Then stromal sclerosis, it is called desmoplastic leiomyosarcoma. It's very rare. So the differential diagnosis are spindle cell melanomas. The spindle cell melanomas are the spindle-shaped melanocytes with a uniform, wavy, slender nuclei. They look remarkably similar to leiomyosarcoma, especially in an acral location. But the growth pattern is in the former is more infiltrative, pleomorphic, and is usually more predominant, and the S100 will be positive. Whereas the muscle marker are negative. BRAF mutation is in spindle cell melanomas and PTEN mutation in cutaneous leiomyosarcomas. So another DD is cellular fibrous histiocytoma. The cellular fibrous histiocytoma is highly cellular tumor with a more prominent fascicular growth pattern with frequent involvement of superficial subcutis. The tumor cells tend to have more abundant eosinophilic cytoplasm and normal mitotic figures are common. They variable staining with SMA and calponin. So another DD is malignant fibrous histiocytoma. It is composed of plump spindle-shaped cells and clusters of sheets of histiocytes. They are scattered pleomorphic with multinucleated cells, giant cells, and mitosis are common. The spindle cells may be arranged in a whorls and have a storiform pattern. So they have a short fascicles and bundles in leiomyosarcoma. Here the striking feature is a storiform pattern. They are positive for histiocytic markers and alpha-1 antitrypsin deficiency, alpha-1 antitrypsin and alpha-1 anti-chymotrypsin. CD68 and CD10 can be positive in these cases. All these cases negative for the cutaneous leiomyosarcoma. Then another DD is cellular schwannoma. Cellular schwannoma is present subcutaneously as a large encapsulated mass. They are marked increase in cellularity combined with a mainly fascicular architecture and have a antennae A and B areas, hypercellular and hypocellular areas. They have a mitosis of 10 per 10 hyper field. Distinction from smooth muscle tumors is readily afforded by S100 positivity. So this another DD is metastatic leiomyosarcoma. It is present as a dermal nodule showing a nuclear pleomorphism and mitotic activity, increased mitotic activity. The clinical pathological correlation is essential to establish the correct diagnosis. These are nodular and well circumscribed. They arise from the retroperitoneal and uterine primary lesions. Predilection for the scalp and the back. This is the IHC picture shows a Carl Desmond positivity and epithelioid variant positive for Desmond. So diffuse or focal positivity for Desmond and calponin, pan muscle actin positivity and very focal keratin positivity. PTEN lost in majority of the cases. Prognosis, dermal leiomyosarcoma have good prognosis with 5% risk of metastasis. Subcutaneous leiomyosarcomas are greater recurrence, that is 40 to 60%. Metastatic potential to lung, liver and bone is 30 to 60%, have a fatal outcome. The tumor size is greater than 5 centimeters is associated with poor prognosis. We move on to last case, that is 17-year-old female. She presented with a primary amenorrhea. Her ultrasound showed a hypoplastic uterus with a streak ovaries. Her karyotyping report was 46XY. Her FISH was negative for SRY gene. So there is a SRY gene positive, it may be a phenotypically male. So the gross finding we received on tube attached small streak ovary, which had a very minimal lesion of 0.4 into 0.2 centimeters. So this is the scanner view, shows some tubular and a gonadal structure in a, and there is a calcification in this. So this is the low power view. You can see the tubular cellular structures with a surrounded by a connective tissue stroma, and there is a calcification. Here there is a areas of calcification and there is a germ cells. They are large cells, large round cells with a granular, pale granular cytoplasm, and there is an areas of calcification. Almost calcification is more extensive in our case. So there is a calcification and there is a foci of extensive areas of calcification and there is a foci of germ cells. So with this, we can arrive at we concluded that it is a gonadoblastoma. So gonadoblastoma occurs in a young individual, first and the second decade of life. Phenotypically, they are females. 80% they are females. Clinical features, there is primary amenorrhea, virilization, or developmental abnormalities of the genitalia. Male, there is a cryptorchidism or a hypospadias. They exclusively underlying the gonadal disorder 46XY, that is gonadal dysgenesis. So the external sex organs may be ambiguous or normal, but internal sex organs, you can see a hypoplastic uterus with the tubes. So this is the gross finding. Usually there will be a microscopic to 8 centimeter 8 centimeter diameter tumor can be present. It is soft and fleshy, solid tumor. It is gray brown and yellow in color. There is a smooth contour and lobulated surface. Sometimes you can see some dysterminomatous component in it. So this pickled with calcific granules and completely calcified also. So microscopically, you can see a nest composed of large germ cells admixed with sex cord derivatives. There is hyaline, Carl-Exner like bodies. Carl-Exner-like bodies. So microscopy, another microscopic picture, you can see the cellular nests surrounded by the connective tissue stroma and foci of calcification. Here there is a foci of calcification. These individual cells are large cells with a round nucleus and pale, abundant pale, slightly pale cytoplasm, eosinophilic cytoplasm, and the prominent nucleoli. So the differential diagnosis for this gonadoblastoma is dysgerminoma, sex cord tumor with annular tubules, mixed germ cell tumors, sex cord stromal tumor. So the dysgerminoma, you can see the large tumor aggregates of uniform cells, and there is a separated by the fibrous septa. This ovarian sex cord tumors with the annular tubules, you can see the absence of tumor germ cells. The tubules, mostly tubules, it is composed of tubules lined by the Sertoli cells and granulosa-like cells. They contain hyaline Carl-Exner like bodies and they calcify. So it is associated with the Booth-Zegers syndrome. So in mixed germ cell sex cord stromal tumor, it is more pronounced in the proliferative activity involving the sex cord stromal derivative, absence of nest-like pattern, absence of calcification and hyalinization. Their tendency to occur in the normal gonads. So IHC, they are positive for anti-Mullerian hormone, ACT3/4, SAL4. In testis, they are positive for TSPY. If there is a sex cord stromal cells, if it is present, it is positive for SF1 and FOXL2. Thank you so much.
Thank you, madam. It was a very wonderful session. All the slides were very interesting, and you had absolutely, like, timing also was very perfectly managed. So it was a wonderful session from you. Thank you very much for
Thank you,
joining us.
madam. Thank you.
So with this, we are coming to the last session. Yeah. So I convey my heartfelt thanks to each and one of the participants who made this program very lively and successful. This is the certificate for you, madam, which will be translated.
Thank you, madam. Okay.
So at this juncture, I would like to thank each and every one of you, all the speakers who are readily accepted, because it was a very short notice within which we started organizing this program, and all the speakers were very generous, and they just immediately obliged to us, and we were making lot of requests, trial sessions were going on, and all that they adjusted for everything which we conveyed, and we asked them to stick on to timing and all that, because of it's a new platform for every one of us, so we wanted to be little more very strict about all the thing, but everybody obliged for all that, and all the participants also. So you were there from the beginning till now. So I'm really, I really thank each and every one of you. I thank Dr. Sudha, Dr. Aruna, and all my senior professors, and finally all my TME. So who encouraged us, and amidst this COVID season, somehow we were able to manage and conduct this session successfully. Thanks to each and every one of you, and Mindray. So you were totally behind us, supporting us completely in all the sessions from the trial session onwards, because we were very apprehensive about this platform, but it was you made it possible. Like, you encouraged us and you took us all the way through, and finally it's coming to an end. It was a wonderful session having each and every one of you in this platform, and Mindray. Thank you, Varun. Almost all the day
Thanks.
you stay with us.
Thanks, Dr. Padma. Thanks, Dr.
For
Sudha.
the past
It was
10 days we were disturbing you and you were.
no, ma'am. It has never been a trouble. It was always a pleasure to associate with you. And since this COVID started, and we realized that we will not be able to meet and greet and do gathering-based events. And once we embraced the technology, we understood that, okay, we might not be able to do the way we used to do earlier, but definitely we can do events, we can share the.
In a way, people have started loving the sessions. It is easy sitting at home and watching everything live, and people don't miss out anything, and they are able to attend to their house call also to some extent. So people are very happy about these sessions. I think technology is improving, and we might as well have this sort of sessions more.
Sure, we will have more. And as you have already announced, I would request all the participants to respond to the feedback mail along with this form which you have given, so that we can process their certificates and they can receive their certificates at the earliest.
It's only with the feedback forms, not with the registration. So registration is optional, but we would encourage every one of them to register for the chapter. So because more number of people are registered, that shows the strength of the association. So we need more young pathologists like you. Please register and become member of Tamil Nadu Pondicherry chapter.
Yes, ma'am.
Over to you, Dr. Sudha.
Yeah, thank you so much, Mindray and team. The 3 days went off in a jiffy without any technical issues. We were a little nervous at the beginning, so now we are so used to it, and I think many of the participants also enjoyed the whole show, and everybody has praised the technical platform, which has gone very smoothly in the past 3 days. And I would also like to thank Dr. Padma and Dr. Arunalata for making me a part of this team, and it was a really enjoyable experience. I would like to thank each and every participant and all the speakers who were very supportive, and it was 3 days was a very enjoyable session. So thank you one and all, and thank you Mindray specifically, all the entire team.
We are more than happy, madam.
Thank you. Dr. Francis from Stanley and the entire team of Stanley. And
yes.
Dr. Francis was helping to, he was helping me from the behind the screen. So my sincere thanks to Dr. Francis and all the others who helped me in some way or the other. It is the encouragement from all of you. So the
it is a team effort.
From the
a lot of people, faculty and PGs from Stanley and other institutions have helped us. So the entire team. And I think we should really pat ourselves on the back. I've been getting feedback from senior professors congratulating the way this whole thing has been conducted. So I'm very happy to share my pleasure with the entire team. Thank you so much.
Thank you. Thank you, one and all.
Thank you, Doctor. Thank you, Dr.
Thank you very much, ma'am.
Thanks to everyone.
Thank you.
So thank you, ma'am, for giving us this opportunity.
Okay, so we sign off.
Yeah, shall we sign off? Yeah.
Yes, ma'am.
Yes. Thank you, ma'am.
Bye, everyone.
Bye.
Bye.
We
Shama.
hope to have
Bye, Kumran. Bye,
association again. We'll have another meet, or we'll meet sometime, either
Sure.
virtually or in person.
Sure, ma'am.
It's a pleasure, Doctor. Sure, definitely.
Our pleasure. Thank you.
Thank you.